I think, sir, we have started. See? It is showing that the meeting is being live stream.
It'll take a couple of seconds.
It is live on the app, right, sir? Live.
We are live on the YouTube, I guess.
Yeah. Hello, guys. A very, very good evening, and I hope you guys enjoyed your INICET exams. We are getting mixed responses from students all over the country that it was a little bit of one-liner. Some of them are saying it's not like an INICET usual paper. It's a bit different. And this INICET had the same like last time, the sessions of the blocks, like 50 questions each. So we have, I have with me Dr. Santosh and I have with me Dr. Rishabh. It's an honor to be with both of them. Hello, Himani. Good evening. So what we'll be doing is we'll be giving a brief overview of how the paper was from the first response from whatever students said. And then we will have few of the students join us, the few aspirants, and give their perspective of how this INICET could be a base for the NEET PG exams. And then we'll start the recall. As usual, that we are very, very excited that all the 19 faculties will be lined up. We have been actively collecting questions, trying to provide the best possible answer. If there are any errors, do put in the comment box. We'll definitely change it and give it to you with a perfect solution as usual in the MedEd app, right? So first of all, to start with, the paper this year had this again mixed response from students. They say that quite a few subjects were not well represented. That happens in any exam, right? You cannot expect them to follow the blueprint. Unfortunately, they are professors, right? They don't follow the blueprint. We follow the blueprint. So they were a bit of good number of questions in the first and second year subjects. Path had more questions this time on blood transfusion medicine. Generally, we do expect like 1 or 2 questions. This time, like 4 or 5 questions came only from blood transfusion. Not much of questions on lymphomas. We expect AIMS to ask random CD markers. They didn't do that this time. We had one easy question, that's Hodgkin's lymphoma, which everyone must have answered. Microbiology had questions on infectious diseases, and ANAT had equal representation. Physio has a good representation as well. There were a little bit of more questions in the first and second year this time as compared to the previous AIMS exam. And I would say fair number of repeats did come, at least with respect to pathology. And the first and second year subjects had a little bit of more representation, like I said. And I will leave the dais to Dr. Santosh to talk about what was in medicine and the final year and third year subjects. Over to you, Santosh.
Okay, so when I interacted with students and spoke to them about the kind of questions that had appeared in this exam, what I understand is that the exam is kind of moved away from the lengthy, clinically oriented questions, and it has become more or less a one-liner based exam. And that makes the representation of clinical subjects little lower, because in the past, when the exams were heavily loaded with clinically oriented questions, like as usual, we used to fight, right? You would say this is pathology question, I would say this is medicine question, because both were bundled into one. But now that we have, like now that the exam had a clear distinction, because most of the questions were one-liners, it seems that clinical subjects were slightly underrepresented in comparison to first year and second year questions, second year subjects. And other thing is, the questions so far, whatever we have been able to recall, appear to be relatively easy to moderate type, not very difficult type. Though recall will always have a bias, because you recall the questions which are easy. The questions which were difficult tend to be recalled last or may not be even recalled. So maybe there may be a recall bias. So the merit of an examination I assess based on its discriminatory value, whether it can discriminate a well-read student and an under-read student. Instead of saying easy, moderate, or difficult, I would say this exam had a relatively low discriminatory value looking at the questions, because most of the questions could be addressed by a well-read as well as an average read students. So that's my take so far.
So Santosh, we missed an important point that the recall for us might be totally different from a student who's sitting in the exam hall, right? It might be a little bit easier for us because we don't have the stressful environment here. We're like,
yeah,
chill.
I agree.
So I think even sometimes as simple as a fever with chills and rigor might stump a student sitting in the exam hall. That might be difficult. That component also is there. I feel that could be a discriminative value. Like you said, if the questions are not of that very extremes, that could be, play an important role. Over to Rishabh, like what do you think? Like Rishabh is a radiologist who is from AIMS as an MBBS grad. So what do you think, like what do you want to give the students an opinion, like what happened from the time you wrote the AIIMS exam, and from the time I think this AIIMS INICET paper should have been by AIIMS only, looking at the amount of blood transfusion questions, most likely AIIMS likes that, right? So what do you think has changed, and is there any change you see? And if there is a change, what should a student do for that?
So very good question. And INICET is one exam that has followed a set pattern in some ways for a very, very long time, starting from my time as well. So like you said that the exam was heavy on first and second prof. So that is a constant. So like INICET has around 60 to 40 ratio of first, second versus third, fourth prof. So around 120 questions will be from first and second prof, and 80 questions will be from third and fourth prof. And that is why, I tell students who are preparing for INICET that, if your first and second prof are good, you'll get a top 100 rank. If your third and fourth prof are good, you'll get a top 1000 rank. So that is how important first and second profs are for INICET, and that has been a rule for a very, very long time now. Now, second important thing that within the first and second year as well. So, pathology students have a lot of fear regarding pathology because it's such a big subject. But INICET, again, what I feel since my time, what has been the norm that hematology questions usually get a more weightage than the rest of the systemic pathology. And I think sir would agree on this. But within hematology as well, there are some variations year to year. Now that we can't predict, like lymphoma versus leukemia versus general hematology, what will be the pattern on which, what will be the emphasis this time. But in general, hematology in pathology is a very, very important subtopic. Now, in this current exam, what I feel that, radiology had a little more questions as compared to last time. So if I recall correctly, around 4 to 5 questions were there in radiology in the November INICET. But this time, the questions that I have recalled, there are around 7 to 8 questions from radiology. Again, students have told me that Ophthal had a little more weightage as compared to other subjects. What used to be the norm was that ENT and Ophthal were very less represented in INICET for a very long time. I think I gave my exam in 2018. That time it was a norm that Ophthal and ENT and somewhat anesthesia were kind of a skippable subjects, but Ophtha had a very good weightage this time. So for any student who is preparing for the INICET, next INICET, or even for the NEET PG 2024, I would say that please don't miss your minors, because minors, मुझे ऐसा लगता है यार, once they are something that give you very good marks easily, because the matter that you have to read in minor subjects is relatively less as compared to the questions that are asked. Again, I talked to a few students that surgery, medicine had a little less weightage as compared to first and second prof. Yes, Obs Gynae, I think, is another one major subject in INICET, which is very focused as well. And this I recall because, in AIIMS, interns have a separate posting in village in which they are supposed to undertake deliveries and manage OBGY patients. So I think it comes from that AIIMS students, that AIIMS administration wants its undergraduates to read Obs and Gynae very well. And that's why that is more of represented in their INICET exam as well. So I think that is the whole overview, what I feel has changed, what I feel has remained constant since my time in the INICET.
Thank you, Rishabh. It was a very good insight to have someone who understands what happens inside AIIMS and their way of asking and the pattern of asking exams. Vansh has commented that he has messed up radiology. So I think when Rishabh recalls it, we will really find it's messed up or not. It should be easy, right? So it's about finding a few nuances and trying to answer the question. And KK has commented that ortho and ophthal was on the higher side. Yes, they were on a higher side as before, like Rishabh said, and surgery and PSM was a little bit on the lower side as compared to the original way the AIIMS used to ask. Like I said, these questions are vetted by different people. So we can learn, we can predict to some extent, but ultimately it's left to the people who is going to finally say yes or no to the questions. That's how it's going to be at the end of the day, right? OBG has very less questions this time. Yes, PSM has very less questions, like AK said. YouTube doctor has commented that OBG has very less questions. See, one thing like what Rishabh said, I want to reiterate that fact as well as the short subjects, no one will be going in depth.
Yeah.
It'll be and that's why they are high yielding. You read medicine for, let's say, 2 months, And even then, I can ask you 30 questions, which might be from gray area of medicine, because the subject is very, very vast. But for short subjects and OBG, because OBG is a subject which has kind of very less correlation with other things. If you have a strong base in path pharma, you can attempt few questions in medicine. If you have a good phase of understanding a subject, quite a few things can be solved. But OBG is very unique in that aspect. Yes, like Anurag said, that one-liners were more than a previous time. And we have Dr. Sandeep with us. So Dr. Sandeep went to the exam center and he interacted with students who just came out of the exam hall. I'm not sure if they're frustrated, not sure if they're happy. So over to you, Sandeep, what is your take? What was the feel of the student who came from the exam hall? Were they okay? Were they happy? Your first-hand opinion.
Hi, sir. Hi, everybody. This question, don't you think is an inappropriate question to ask in an exam, and how would they feel? Most of them, yeah, the same thing. Now, when we gave an exam, that mode, no, please do not disturb. I just want to go back home and sleep. Okay, get out of my face. 90% of them were like that. 10% I got those enthusiastic kids who were like, yeah, they did exam well. So they were telling a couple of interesting, see, this is the first time we have ever done going to an exam center to get a real feel on the day of the exam itself. More or less, no important observation, a good observation that I felt. One, that slotting wala jo point was there, where a lot of students were worried. INICET started last year itself, but then students got used to it by practicing also. So they were like, no, it's a very good welcome change, because as the exam was split into slots, they were not, trying to recall all 200 where they had to go and check back again. So they were like, okay, once a session is done, they were able to get a break also because they were finishing it earlier. Few of them said I had 8 minutes, 10 minutes left, so I was able to relax and then go to a next session. So in that way, it helped a lot. So they were in a good frame with that welcome change. A couple of things that a lot of students pointed out, the change in the trend of exam. Now, as those lengthy questions, the clinical vignettes and all, they have stopped. I mean, they've become very less. More or less, it was one-liner questions. Options were very tricky, which as INICET or AIMS was pretty known for. So that's continued to happen. IBQs were a bit on a lesser side. All the so-called important subjects were not important this session. All the big subjects become smaller, or the smaller ones become bigger. A lot of questions were from Ophtha, it seems. Good questions from Ortho as well. Radio had an intermix. Medicine surgery is lost in oblivion. So there were like 1 or 2 questions we were able to think it is medicine or surgery. Apart from that, they felt the exam should not be in summer. Common this thing that, the exam should be in winter so that they can think better as well. But yeah, it was all in all a very good experience being down there. If Delhi had a temperature of 45, Noida was at 55. Trust me, it was not a good thing to do in a scorching summer. Otherwise, it's pretty nice.
Great. Thank you, Santosh, for giving that insight of what a student must have already actually felt. And we'll be having a couple of more students joining us who are aspirants. We just wanted to take this moment and tell to the entire audience listening here, as well as the students who will be joining us, that few takeaway messages from Dr. Sandeep, who went to the exam hall, and we'll be sharing it with all the students. Like one of the important points which he mentioned, that having a 50-50 split, that's kind of the talk of the town for the past 2 weeks. So it's actually good for student, and whoever is given the INICET would have realized it, and who was not given the INICET, and we have Dr. Jigar and Dr. Vijay will be joining us very soon, and we'll tell what we have got from the students to them. And also, if they have any queries on how to go for the upcoming exam, the NEET PG, which is just close to a month away, and how to prepare for them. Dr. Jiga and Dr. Vijay.
Hi, Dr. Ranjit.
Hi, Dr. Vijay. And hi, Dr. Jiga. So we have both Dr. Jigar and Dr. Vijay, and we welcome you to discussion here. So, do you have any questions to ask? Because you have been preparing for quite some time for the upcoming exams, and is there any burning questions? The recent talk is that split sessions, like 50-50 questions. Is it really going to matter or not? If you have any things to ask us, you can ask, and we'll try to convey whatever Dr. Sandeep has gone and interacted with students. He'll give the first-hand information from the students. Right? Over to you, Dr. Jigar and Vijay. Yes, Jigar.
Yes, sir. So, sir, most likely it looks like INICET board is moving towards next pattern based on the students' review.
So, Jigar, whether it's towards next or not, I'm not exactly sure. But one thing, when the split session started with INICET, went on to FMG and is going to happen in NEET PG also, because next is proposed to have a 8-hour long exam. So having 3 hours in the morning and 3 hours in the evening is a bit difficult. Like USMLE exam used to have sessions, used to have 40-50 questions. It's a bit easier to go ahead in that, that rather than having a 3-hour lengthy exam. Maybe this could be the first step towards that. Not sure what they have in mind. Only they can answer that. And we know our an MC, and MC gives everything in the final moment. Like, so we'll wait and watch. But it looks like they are in that mode of going towards the next exam, having a qualifying exam for an entire day for 3 days. What is your opinion, Dr. Santosh, Rishabh, and Sandeep?
Okay. So if they are moving towards the next pattern, probably I won't fully agree that breaking them down into the batches will make much of a difference, or whether it is a step towards next, because as far as the original document by the government about next, their initial proposal, it appears that the questions are going to be more clinically oriented. But when you have such batches or split sections, then including heavy number of clinically oriented questions becomes a bit difficult. Because when we had 200 or 300 questions and running for 2 hours or 3 hours as an exam, there the students could balance, like, okay, some questions take more than 1 minute of time. The other questions take just few seconds. In the end, at the end of 3 hours, you would have done the 200 questions efficiently. Time management wouldn't have been difficult. Now the challenge will be on the paper setters to make sure that each batch, the time management is justifiable. So if they can do it efficiently, then it is a right move towards next. But if the paper setters crowd too many clinically oriented questions in one section and then too many one-liners in the other section, that can become a nightmare for students. So how things will progress, I don't know, but it is a good step from the student sides to start practicing when this all MCQs, keeping the batches in mind or the sections in mind.
Great. So we have a student who is asked, Satyajit, which are the subjects to have more weightage on NEET PG? Rishabh, your take on this?
So I think NEET PG, unlike INICET, is a more balanced paper and more sort of 50-50 split between first, second, and third, fourth year. So again, I think in the NEET PG space, the major subjects will be more weightage. But what I still want to add here is that even though in NEET PG, you would say that medicine surgery might have more questions as compared to INICET. But, again, the rank deciding will be first, second prof and minors. That has been a constant in all entrance exams in India, medical entrance exam in India, PG based. Because, first and second prof and minors are something in which the content is limited and the questions will come only from that content. Medicine, surgery, Obs Gynae, Pediatrics, these subjects are something, which are like an ocean. Like the examiner can ask anything from you in these questions, in these subjects. So I would still suggest you people that if your first, second prof and minors are not strong, it is a good idea to make them strong. And yes, later on, after that, medicine, surgery, Obs Gynae, PSM, Pediatrics in that order.
Great, great. So, Dr. Sandeep, like Anurag Rana has a question, like, will NEET PG also have more one-liners? Now they are in a dilemma. They tried to prepare for an scenario-based question, and INICET has put a bouncer with more of one-liners. So they are stuck, like, what should I do for the next 1 month? What's your take on that, Sandeep?
See, as Rishabh sir was saying, NEET is more or less predictable when compared to INICETs. INICETs are known to give bounces. They groom you. They prime your brain towards one sector and then they switch to the other component. NEET, I don't think they will go as a complete one-liner because they've been doing a lot of clinical questions. So even though this year also it could be a 50-50, because if you take it from the INI's perspective, see, the thing about the INICET exam question was, even though this question was small, the stem of a question was small, the options were longer and they were more trickier. So again, if you're thinking that it is going to be only a crude exam where you learn, you memorize your facts and go, you're not going to crack the exam. Because each individual option was so trickily placed. For example, today there was a question on a breast cancer. The minute you see the opening line of a question, because everybody reads breast cancer. So you think you know a familiar answer, but then when you look into the options, no, so which among the following options in the following is true or false, I think is the question. And the question was given with respect to breast cancer. What is the estrogen receptor? Is it a prognostic receptor? Is it a diagnostic receptor? Is it going to be a molecular receptor? It is a treatment determining receptor. So now they're testing your core competency, your concepts there. So INI was on that context. So I still believe if your concepts are good, if they are strong enough, no matter is it INICET or NEET PG, wouldn't matter. Clinical based questions, long stem winglets is a forte of NEET PG, so they'll continue to do so. Yes, after next year, because NEET PG always follows the trend of INI. If the INI is going towards one liner, it will also follow. But I don't think immediately they're going to switch. But yeah, the concepts are, as Rishabh sir was saying, it is very important. Again, today also, every student who came out had only one thing. If your basics are strong, this exam is not difficult. If your first year, second year minus, you have done well, it is an easy cake. Otherwise, it's a very tricky one.
Okay. So KK has commented like PSM, OBG, surgery, medicine is equal to 50%. It's very difficult to divide, like, will it come exactly? Like I said, like, it's not an NCERT exam where I know that this is my blueprint, this has to happen like that manner, right? Even though if you take a scenario-based question, like initially what Dr. Santosh was saying, I'll not be able to decide whether it's from medicine, or if the treatment is asked from pharmacology, or if the pathologist is from pathology, or if an image is put, it's in radiology. So when a scenario-based question comes, it's a patient at the end of the day. The same way what you sat in OPD, you diagnose a patient. You don't think that which subject it came from. So that's what will happen when it's a scenario-based question. We cannot discriminate it. But of these 4 subjects, OBG and PSM can easily be discriminated because they don't have an overlap. And PSM is a very, very important subject when it comes to a NEET PG exam. OBG and PSM, both of them have high chunk of representation and there's very less overlap. So that would be required. Compared to medicine, surgery will have kind of an overlap and it will be very difficult to determine. Will it come as 50%? Not sure. But yes, they will have an equal representation for the third final year and the first second year. That's what the general trend of NEET PG is. Yes.
I'd like to add something, sir, regarding the PYQs and PYTs. So I talked to a few students and they said that the previous questions per se were not repeated. And again, that has been a norm that AIMS does not repeat the exact questions. But again, the topics, so I think Sandeep sir would agree that surgery this time also had predominant questions from breast, thyroid, trauma. And so these topics, like INICET loves your previous year topics. Like if NEET PG, if PYTs are important in NEET PG, they are very, very, very important in INICET. So a very good idea for the upcoming November session INICET, somebody is planning to do that. And let's say somebody is an intern right now and watching our video and planning for the November INICET. So it's a very good idea that you do your previous year questions, get to know the previous year topics and do these topics in detail, especially for your INICET.
Great. Thank you. Thank you, Dr. Rishabh. With Dr. Vijay, you have any questions to ask us, and if you have any things, yeah, please.
So, sir, I would like to ask Dr. Rishabh, sir, after seeing today's recalls by the student, do you feel that exam pattern was more toward a PGI exam, like
Yes,
the level options?
So since INICET is now clubbed, so they get their question bank from all the 4 institutes of national importance. And so in that way, their question bank will have match the following options like PGI used to have. So they will have true and false options. So earlier, PGI used to have multiple choice, but in INICET, you can't have multiple choice options. So they have made that multiple choice into true, false, which of the following statements are true and false, A, 1, 2, 1, 2, 3, 2, 3, 1, 2, 4, etc. So the pattern is similar to PGI. And slowly, such kind of questions will only increase, I feel, because, there is only so much so that you can do in an exam. You either put in new information and ask the student, or you just complicate a little question asking pattern. So this is a trick that these INICET people play sometimes. Sometimes they'll put in a video in the question and ask a question. Sometimes they will do match the following. I think assertion reason, one question from assertion reason also came this time, and the time is not far when assertion reasoning will be introduced in NEET PG and INICET too.
Great. Thank you, Rishabh. There's a student, Dr. Amresh, wants to crack INICET number 24. All the very best, and we wish that you do crack the INICET. and hope to see you in one of the AIMS or GIMS or PGI. Okay. So thank you everyone. So we have had a good brief discussion of how the paper was, and now we'll be starting the recall slowly. I'll start with pathology, then we have all the 19 subjects ready for you. So it's going to be a long day. So for all the students who are just completed their exam and was listening here, just put the headphones on and like you see a series, watch us recall one by one questions, and I hope this will be helpful for the upcoming NEET PG exam, because it's not far, it's just a month. So if there any concepts you learn new here, any new one-liner, if it's getting repeated in the next exam, that will definitely be useful for you, right? Thank you, Dr. Santosh, Dr. Rishabh, Dr. Sandeep, Dr. Vijay, and Dr. Shikhar. And thanks a lot.
Bye, everyone.
Bye-bye.
Thank you, sir. Bye.
Just give me a second, please. Okay, Dr. Rahul, how to go for NEET PG after today? Advice in session, just relax, take a day off, get back to your PYQs, PYTs, and that should be more than enough for you to go ahead, fine? Yes, Amrish, for INICET, generally there will be a little bit of more weightage in the first and second year topics compared to the third and final year. That has always been the trend, and this time also it was the same, fine? So welcome, guys. So let's go to the recall of pathology questions. I'm not going to take all the questions because there's a little bit of an overlap. I'll leave few of the blood transfusion question, the transfusion related thing to physiology, the basic ones. I'm just going to take a little bit of, let's go in a fast pace. I've created a stem for the question, whatever we got from the students. If there's any corrections, I want you to put it here. We'll take the inputs and we'll definitely give a much refined version for you in the near future in the MedEd app, fine? Himanshu, 5-year pattern of NEET PG. Yes, Himanshu, there's always, it's not a consistent thing that it will be there, but yes, first and second year do form a chunk of them in some of the exams. Sometimes it will be an equal representation, right? So let's go ahead with the recalls. So was this the right question? Which of the following is a nuclear marker for neuroendocrine tumor? Because I want to start with the bouncer. This was definitely a difficult question because INSM1 is the right answer here, which is a marker which an undergraduate need not know, right? So every time in INICET, there used to be a question which is very high standard for more than an undergraduate level. So these questions are where you have to be a little bit cautious and let the question go. Don't write the answer here because there's more chance of you getting a negative mark. But some students were smart enough to look at N. They thought N for nuclear. And they said, okay, it must be the nuclear marker, right? Yes, it's a nuclear marker, undoubtedly. Synaptophysin and chromogranule are not nuclear markers. NCAM is also not a nuclear marker. So this is a nuclear marker. These questions, if the same question gets repeated next time, try to learn it, try to solve it. But please don't overdo understanding which marker is nuclear, cytoplasmic, and membrane. That's the job of a pathologist, definitely not the job of an undergraduate student, right? So the answer for this, INMS1 is the right answer. Thank you, Lydia. Okay, if there is... it's fine, Babu. If there's any error in the recalls or the questions, please do put in comments so that we can get a much refined version, like I said, right? Next question. Let me know first, was this the right question? Which of the following diseases will predominantly have infection with catalase positive organisms? I think this was the question. We had discussed in the class as well, right? So catalase positive organisms, perfect. The answer is CGD, chronic granulomatous disease. Because of the presence of the enzymes in catalase positive, the catalase negative organisms produce the H2O2, and even in the absence of the NADPH oxidase, catalase negative organisms will be killed here, right? The catalase negative organisms can produce H2O2. This H2O2 will be used by the neutrophil to produce HOCl. So catalase negative organisms will be killed in case of CGD, and catalase positive organisms will not be killed, and you'll have a recurrent infections, fine? Satyajit, I would say that stick to your routine first. If you're with PW, you have daily updates of DPPs, right? Solve them, listen to the lectures, and that will make your basics very, very strong, fine? Thank you, guys. So this was a previous year question. This was an exact POQ. I think this was more or less the right, same stem and the same options, right? Lydia and Dr. Babu, if you can comment, that will be great, and we can look at the answer. 11-year-old boy, came with history of cough for 15 days. We had the same question discussed in the ASAP batch as well when you had the TND. Examination found to have a cervical lymphadenopathy. Lymph node biopsy showed this. And these are your classical granulomas here, right? As a classical granuloma, and you have the giant cells, right? So you have giant cell granuloma. This image is a extra finding. Tell me how many of you will think of a tuberculosis when you see a 11-year-old kid with cough, expectoration for 2 weeks with a cervical lymphadenopathy, right? You must have definitely thought of tuberculosis only. That's the first response what we have clinically also. And this should be the right answer, fine? So the answer here is tuberculosis. Though your sarcoidosis can form granuloma, syphilis can, leprosy can, but TB is the right answer. TB is most common. Do remember, any question down the road, when you have granuloma in the question, I want you to think of TB. Be it necrotizing or non-necrotizing granuloma, the first answer should be and must be tuberculosis only. I think this is a simple one and is in previous recall. Let's look at this question. I did discuss a similar question in the ASAP batch TND, where there's one very important clue here. Was this the right question? A 10-year-old treated with antibiotics for tonsillitis, later presented with swelling of face, or some of the students said swelling bilateral pedal edema. Doesn't matter. Ultimately, they are trying to imply there's a renal involvement, swelling of face or a pedal edema. Examination of urine showed eosinophils and WBC cast, right? WBC cast was found. What is the right diagnosis? Now let's flip the thing. So here I have a history of antibiotics. So there's a drug involved. Of these 4 options, which is drug induced? There's only one thing which can be drug induced, right? Pyelonephritis, infection induced. UTI, infection induced. Lupus nephritis, it's not an infection or a drug, it's your autoimmune antibodies, right? So here, the answer has to be a drug-induced interstitial nephritis or just an interstitial nephritis. To prove the fact it's interstitial nephritis, I have eosinophils. That's an important marker here. So if you have eosinophils in the urine, WBC cast does not always mean pyelonephritis. When you have a WBC cast, the only information what I can get from WBC cast is it implies that the problem is in the kidney. That's all. So here, except for the UTA, rest everything the problem is in kidney, WBC cast can be seen. The eosinophils, history of antibiotics, moves us towards your interstitial nephritis, and that's the right answer here. Fine. Okay, great. Let's go next question. Was this the image? Because see, I don't know what the image came from. Few students say it's a struvite stone. Few students say it's a calcium oxalate envelope shaped stone. But I'm sure you know all the exact stones which came. Can anyone tell me what was the exact image? Few of them say there's an envelope shaped crystals. Few of them say it's in coffin lip shaped crystals, right? So you should be the best judge of what came. Like Jagdish, if it's a triphosphate crystal, coffin lid, we'll just look at everything. If it's in coffin lid, obviously it's two-way calculate. I put an envelope shaped crystal. This has to be a coffin lid one. This has to be an envelope shaped crystals. Uric acid stone will have a rhomboid shaped crystals. Just let's quickly go through everything. And cystine stones will have an hexagonal shaped crystals, right? Perfect. Dr. Lydia, Jagdish, and Priyanka, if it's coffin lid, we have to go with two-way calculate. If it's an envelope shaped crystal, we have to go with this. Alkaline urine also is going to point to the same thing, the protease infection, everything. Again, it will be more likely to two-way calculate. I'll change this image and maybe add the alkaline urine like Dr. Jagdish said, and we'll rephrase it and we'll give you the exact recall very soon. Fine. Okay, great. Triphosphate, steroid is a triphosphate crystal. I'm sure you know that, right? Okay. So this one, which are the following tissue degeneration, collagen, connective tissue degeneration presents with aortic aneurysm? Was this question there? Because very few students said this question was there. Was this question there first? That was the first thing for me. Okay. So if this question is there, rheumatoid arthritis, atherosclerosis is not a connective tissue disorder, right? It is not a connective tissue disorder. I can rule them out, right? So these two can be ruled out easily. Now the question is it Ehlers-Danlos or Marfan syndrome? Because both Ehlers-Danlos as well as Marfan syndrome can cause aortic dissection and can cause aortic aneurysm by default, right? So this is where you're getting confused with. Every exam, it's choose the best answer, not the right answer. I would prefer here to be Marfan syndrome than Ehlers-Danlos because there are very different types of Ehlers-Danlos. There are dermatitis type, right, where you have more of skin involvement. Kyphoscoliosis type, where you have more of bone involvement, right? There are the type 4 Ehlers-Danlos is your vascular type. That definitely will have aneurysms, that definitely have dissections, but not all the types of Ehlers-Danlos syndrome. But Marfan syndrome definitely will cause your aneurysm. That will be the right answer. Dex, if scurvy was an option, which was not the option here. If scurvy was the option, even if scurvy was the option, that's fine. I will still prefer Marfan syndrome to be answer. Scurvy might not cause an aneurysm. It might cause bleeding. Scurvy aneurysm is not the presenting feature. Bleeding comes also a presenting feature. Those are common features here. Fine. Okay, which was not there. If scurvy was there, let's say maybe atherosclerosis must have not been there. Scurvy must have been there. Even then, I would prefer the answer to be Marfan syndrome. Okay, rheumatoid arthritis is not there. Okay, let's replace it. Fine. Okay, and even then, Marfan syndrome will be the right answer. Okay, great. Thank you, Roy. Next, was this the question? Any change in the question first? If there's a change, let's look at the change and then let's go to the right answer. Because transfusion reactions and transfusion this time has quite a good number of questions, right? I hope the recall options were more or less same. Which of the following is not seen or all except? Cola colored, fine. I'll add cola colored urine instead of dark urine. It's a symptom, fine. It's fine. Okay. It's a hemolytic reaction. There is two things here: a delayed hemolytic reaction and the question which is not seen. First thing, every delayed transfusion reaction happens minimum after 24 hours. Actually, delayed hemolytic reaction can happen even after a week, but minimum after 24 hours. So here, so if it's minimum after 24 hours, the option D will never happen. You will not have cola colored urine because cola colored urine indicates hemolysis. So hemolysis by definition for any delayed reaction is after 24 hours, that's minimum. So 2 hours after transfusion, you will not have cola colored urine if the question is on delayed transfusion reaction. That's the right answer. Undoubtedly, that's the right answer. Now let's look at the other options. LDH will be elevated when any cell lyses. Same with your RBC or delayed or an early hemolytic reaction. Bilirubin will definitely be elevated because whenever there's hemolysis, jaundice, bilirubin, everything will be elevated. This option, some of them are thinking whether it could be the right answer. Let's dissect this thing. Let's assume you are giving a blood transfusion for a patient with anemia. You know for a fact that whenever you give an entire unit of blood transfusion, the hemoglobin should increase by 1 gram percentage. That's the criteria here. So I'm giving blood transfusion here. After a day, almost every blood here is having a hemolysis. So will there be any rise in hemoglobin? You won't have, right? So post transfusion, that's a trigger here. There's no rise in hemoglobin means there is hemolysis. That's all it means. So it's not a very tricky option. If you read it carefully, you will understand what they are meaning. There's no increase in the blood hemoglobin after giving a transfusion because there's been hemolysis here, right? So the right option, which is not seen, is option D, cola colored urine. After within 2 hours of transfusion, you won't see them, right? Okay. Next. What was this the right option? Which of the following gene mutations not seen in GIST? I think it's not an immunohistochemistry question. It's about genetic mutation related questions. All the options are right. SDH, 𝐒𝐿, PDGF, RA or RB, and NRG1, right? GIST has classically, this is the most common mutation. Close to 85%, 90% of GIST will have 𝐒𝐿 only. SDH is generally seen in inherited GIST, your Carney-Statakis syndrome, and also seen in your pediatric patients. Yes, SDH also will be seen. PDGF, RA, RB is also seen here. Okay. NRG1 is actually not seen in GIST. NRG1 is actually a subtype of EGFR. Can anyone comment where do you see EGFR? It's one of the 4 components of EGFR. This is seen in lung cancer. Maybe keep in mind, INICET always tried to ask the previous year topic related ones. So you might have a question in future. Where do you see NRG1? NRG1 is a marker, it's a mutation which is component of lung cancer, though it's not very, very important, but that can be seen here, right? Option D is the right answer. It is not seen in GIST. Rest of them are definitely seen in case of GIST, fine? Okay, perfect. As of now, we are going with a decent recall, not an exact one, but yes, definitely a decent recall. So ER in case of breast cancer indicates what? Was this the option or was there any clinical option so that I can pass it on to surgery? If this is the option and the 4th option is a molecular marker. Okay, was these 4 there? See, because if 4 are there, I have to take a guess. Prognostic marker, molecular marker, both of them can be predictive. So which is not there. See, because here it's not a surrogate marker. That's ruled out. ER is not a diagnostic marker. For a breast cancer, ER is never diagnostic. If you want diagnostic for breast, I want you to remember this. There's a marker called as GCDFP. Okay. We use that for diagnosis. I don't use ER for diagnosis, right? So here, can ER be useful as prognosis? Definitely. If ER/PR is positive, better prognosis. Triple negative, worse prognosis, definitely there. So that ER/PR being positive is actually a surrogate for a molecular genetics, right? So tell me, was there not here? Was there a not here? Or except here? Or was it a single, which is the right answer question? It's the right answer question. I would prefer it to be a prognostic marker if there's no, prognostic or predictive. I think that should be the right one, right? Easy medicine. Okay. Single correct. Rashmika, both prognostic and predictive was there. See, then which was not there? See, because these are very tricky words. ER is definitely a prognostic marker. ER is not classical molecular marker. We have like BRCA1s and all those things and few mutations, P53, those are molecular markers. ER is a surrogate for a molecular marker, right? So I would say if it's a direct single option, estrogen receptor is one of the most important prognostic marker. Predictive and prognostic is more or less same. If they are asking about future cancers, not, but prognostic marker, I would put my entire bet on the prognostic marker, fine? That would be the right answer. Molecular was not there. Then all the confusion is sorted. I'd go with the prognostic markers, fine? Okay, this was a previous year question. What is the answer? Yes, KK. Prognostic will be the most appropriate answer. Fine. Fish can detect all of the following except fish is undoubtedly an. Yeah, fish is undoubtedly a chromosomal problem, right? When it's a chromosomal diagnostic method, you cannot diagnose point mutation, fine? Point mutation cannot be picked up in case of a chromosomal problem. Fish can pick up one amplifications. Fish can pick up translocations. Fish can pick up deletion. I like to add one more here. Fish can also pick up your aneuploidies, your trisomies, monosomies. That also fish can pick up. Obviously, fish cannot pick up a point mutation. There's a PYQ. You're not going to spend much time on it. Right option? Was the question right? I'm not jumbled it. I'm directly put it. Single donor platelet, 5 days. Pack red blood cells, 35 or 42 or 21 based on what your nutrient additive is. Cryoprecipitate or FFP, 1 year. And granulocyte concentrate is absolutely 24 hours, right? I just matched it directly. I think these are the 4 things which came and these are the 4 recalls as well, right? Okay, 42, fine. That's fine. So 42 or 35, it's more or less the same, fine. So it's based on whatever additive use. So 42 is also okay, 35 is also okay. But this is the right answer. Single donor for 5 days, 35 or 42 for PRBC, cryo or FFP for 1 year, and granulocyte concentrate for 24 hours. Fine, great. This is the question. I have just added all these things to make look like a question. 40-year-old came with a road traffic accident and the blood group of the patient is not known. Which of the following should be given? If it was multiple correct, which was even if molecular was there, I would still go with prognostic marker, right? If this was the option, O positive and O negative would be a better answer, right? We will definitely read more about blood transfusion. We have in the app what to use and what not to use. And I also have a separate session on to understand the entire intricacies of blood transfusion after the recall before the NEET PG exams, fine? See, if AB negative is there also, I would prefer O positive and O negative are the ones which has to be given if I don't know the blood group of the person, right? Because the AB negative, no. So fine, let's take AB negative. But even then, I would prefer O positive and O negative to be given if I don't know what is the blood group of the patient. So option C and option D, I think it is a multiple option right question. Option C and option D, that C and D will be the right answer here, right? O positive and O negative, perfect. Okay. Though it's not primarily pathology, it's Kawasaki disease. It is more attractive, so I used it. Which of the following is not seen in Kawasaki? Kawasaki, I'm sure you know that you have non-purulent. You don't have purulent. Purulent conjunctivitis is undoubtedly seen in case of an infectious disorder. You'll have non-purulent conjunctivitis there. Lymphadenopathy, fever, and strawberry tongue, you'll have it, right? This is a very, very simple question. Okay, perfect. Was this the right option? Which of the following is a proto-oncogene? Some students said it was not proto-oncogene, or which of the following is not involved in cell division or cell proliferation. See, both means one and the same. First, understand proto-oncogene is a normal one. For which one? Okay, polymorphous rash is fine. Okay. Proto-oncogene is a normal gene which involves in cell proliferation. Fine. So which of the following is not a proto-oncogene? Only thing which may confuse is TGF-beta also is given as a growth factor, right? So all these are proto-oncogenes. TGF-beta is not a proto-oncogene. TGF-beta, though it's a growth factor, is a tumor suppressor gene. I'll try to explain this. Am I right in saying that you must have read TGF-beta in almost wound healing with fibrosis? You must have, right? So TGF-beta results in fibrosis. When something is going to become fibrotic, do you think they'll promote proliferation or suppress proliferation? They will obviously suppress proliferation, right? TGF-beta is written as a growth factor for fibroblast. So it will divide or reduce the cell proliferation or cell division. It is not a proto-oncogene. It's a tumor suppressor gene. Option D is the right answer here. Fine. TGF-beta is the right answer. TGF-alpha is a proto-oncogene. Just to take one more point here, can anyone tell me in which GI tumor you'll have TGF-alpha mutation? May come in the next exam. A GI tumor with cerebriform appearance, corkscrew appearing gland in microscopy. Anyone? Have you heard about the disease? You must have heard about the disease called Menetrius disease. In Menetrius disease, you have a TGF-alpha mutation. PDGF have multiple things. FGF is more commonly seen in hepatocyte tumor, right? Okay, perfect. Great, great, amazing. Fine. This is a very simple one. Not much difficulty here. Most of things. Hoarseness of voice is generally not the presentation of medullary carcinoma. When you see hoarseness of voice alone, I would think of an anaplastic carcinoma because that's the fastest growing thyroid cancer that can go and compress and cause hoarseness of voice or your dysphagia or whatever it is, right? Amyloid deposits, and students also said there were nests of tumor cells. Any neuroendocrine tumor will have nests of tumor cells. So my diagnosis here is very simple. It's your medullary carcinoma thyroid. So you have medullary carcinoma thyroid. It originates from your parafollicular seed cells and your calcitonin will be the, if tumor marker is asked or if your IHC is asked, calcitonin will be the right answer. Fine, perfect. Nest of tumor cells is classical for any neuroendocrine tumor. Here also you'll have neuroendocrine tumor. Option A is the right answer. Fine, great. Are the options right? If the option is right, let's go and dissect it. Necrosis and apoptosis, very, very simple heading, right? But this time, even in necrosis and apoptosis, they have kind of made a jumble out of everything, right? The options are right. Which of the following will not help to differentiate necrosis versus apoptosis? Let's go one by one, right? If first option, let's take enzyme activation. Can I say enzyme activation will be there in both endonuclease, nuclease, caspases, proteases? It will be there. So it will not, it definitely is more or less same here, right? When I say altered cell shape, necrosis will have increase in the cell size, apoptosis will have shrinkage of cell size, right? That will be there. Sihat, I'll take it. We'll look at it soon. We'll look at this soon. Fine, I'll come to this soon. Lipid change, your necrosis and apoptosis. Lipid change will be seen more in necrosis and it will not be seen in apoptosis, right? Here. Internal structure changes. So if it's intact cell membrane, I'm just taking all your inputs, intact cell membrane and enzyme degradation, right? See, enzyme activation will be common in both. Alteration of cell shape will happen in both. Lipid change, I would say it will be seen only in necrosis. Apoptosis will not have a lipid change. Fatty change is a finding seen in reversible cell injury and necrosis and not in apoptosis. Internal structures will have changes in both. Though in apoptosis it will be limited, but necrosis will have much more internal change. That also is a common finding here, fine? Okay. So if intact cell membrane is there, intact cell membrane actually helps me to differentiate necrosis and apoptosis, right? The question is, the following will not help me to differentiate necrosis or apoptosis. Intact cell membrane will help me to differentiate. Enzyme activation will not help me to differentiate because in both I'll have enzyme activation. Altered cell shape will help me to differentiate. Lipid change will help me to differentiate. If it's internal structure, will help me to differentiate, right? So option A, enzyme activation, will not help me to differentiate because in both necrosis and apoptosis, I'll have enzyme activation. If it was enzyme degradation like Sihat said, let's take that point. Can I say, I want you guys to comment, can I say both necrosis as well as apoptosis will have protease activation? I'm coming to your thing, Sihat. Can I say that? In necrosis, I'll have protease activation for sure, right? In apoptosis, you'll have caspase activation for sure, right? Both are proteases, right? If I have a protease activation, can that destroy other enzymes? Yes or no? It can, it will. right? So be it enzyme activation or an enzyme degradation, because both have this, as a common finding seen in both necrosis and apoptosis, I will not be able to differentiate based on that. But based on cell shape, based on lipid accumulation, or based on an intact cell membrane, I can differentiate. And enzyme activation or degradation, I will not be able to differentiate necrosis or apoptosis. That will be the thing. The question is, will not be able to differentiate, right? This was the question, right? Which of the following will not help in differentiation? That was the question, right, Siraj? If that was the question, my enzyme activation will not help me to differentiate, or enzyme degradation will not help me to differentiate, but rest of them will be able to differentiate. Clear? Perfect. I hope that should be the right answer. If this is not there also, that should be the right answer, right? Perfect. Great. Amazing. I hope we got it sorted. I couldn't get the rest two of the image. This was the easy question. I was told it was calcification blue in color. Someone said that there's one more image with hyaline image and there are 4 more images, right? So if it's blue color, I'm just going to go with calcium. I'm just going to go with calcium for the blue things, fine? Okay, so these are the few questions which I have for recall now. I hope we have done close to 17 or 18 questions here. That should be more than enough for us. There are a few more blood transfusion related questions like ABO antigen, Salis hemoglobinometer. I'll let it for Vivek sir will come and discuss you in that, because you must have read Salis more in there, and ABO antigen, the normal blood there, right? So rest of them will be covered by the Vivek sir in physiology. And I'm going to take your leave. Will be more than happy to invite Dr. Jagdish sir, who is ready with the PPT. Over to you, sir. If you have any other doubts, please ping me on Insta or your Telegram group. Let's sort it out very soon. Thank you, sir. I'm leaving. Stage is yours.
All right. Thank you, Dr. Ranjit. And I think you guys hope you've done well. I think from ENT standpoint, pretty straightforward. No bouncers or surprises in ENT. Everything has been covered by me in the teaching as well. And questions are very, very basic. That basically means no ENT was involved in the question setting for INICET. But I think there are about 4 very clear ENT questions that have come. But I am picking some ENT overlap questions from anatomy as well as surgery, because this is what we as ENTs do. We take away other departments' work. That's what we do. You know, we pick up surgery cases also. We take up opthal cases also. We take up, other cases also. So I'm sorry, other faculties. I'm taking a couple of your questions. So we have 8 ENT questions overlapped that I think we can find, and I want you to help me if I have missed something, okay? So there was one question, I think it was a very straightforward anatomy question on constrictors of the pharynx, the structures passing through middle and inferior pharyngeal constrictors. Very unlike INICET to just directly ask a question. Normally they will twist this and give it a little bit of a clinical touch, but they didn't do it to that level. But I think this is very straightforward. Okay, so this is the superior constrictor you can see over here. Just when you wanted to write, my pen stopped writing. So you can see the superior constrictor, middle constrictor, inferior constrictor, and the structure that goes in between is the superior laryngeal artery, superior laryngeal vein, and the hyoid bone. Okay, so those are the structures. Very straightforward. Same. Okay. Then there was a question over here, which I think there is some confusion, and I want you guys to help me with this. There was this question saying a patient with dysphagia, halitosis, and regurgitation of digested food. What is the diagnosis? Okay, wait. Saurav is saying it is superior and middle, and not middle and inferior. If it is superior and middle, then they're looking at glossopharyngeal nerve and glossopharyngeal nerve or the stylopharyngeus muscle. Okay, if it is that was being asked. All right. Now, on this question, okay, I'm not sure if I got the question, correct. If there is this option, dysphagia, halitosis, and regurgitation, then, this is very classical of actually Zenker's diverticulum. All right. But if the image is eclasia cardia, then halitosis is actually not a very classical symptom of eclasia cardia. That's why I got confused. So suppose if a Zenker's diverticulum image was given, that's very straightforward in terms of history. But I think you were asked the bird beak sign, which is seen in eclasia cardia. And that is very classical because, the lower esophageal sphincter has got higher tone. So you see this dilation of the esophagus and you see this. Okay, no halitosis was given, Sehag has clarified. Yeah, that's why. So if halitosis is not given, then this is very straightforward 𝐒𝐿𝐴 was also age 26, because 26 is a very, not a very common age for 𝐒𝐿A. It's usually seen in older, age group people. But otherwise, if halitosis is not there, dysphagia is there, they've given you this radiological image, then there is no confusion. So Nisha is saying halitosis was given, but Lydia is saying halitosis was not given. See, halitosis, when there is Zenker's diverticulum, it's much closer to the oral cavity and a lot of unchewed, undigested food is there. So halitosis is more prominent in Zenker's diverticulum. 𝐒𝐿A is in the lower esophageal part. So it's very far away from the oral cavity, 40 centimeters down. So usually you don't have that much of halitosis as a primary symptom. So, sir, it was straightforward. No, we didn't ask the age, but weight loss was mentioned. Shashank is saying, then again, it goes towards 𝐒𝐿A. All right, great. This other question, okay, no confusion. All right, so Sehag has cleared that. Now, radiology of sinuses, best X-ray for viewing frontal sinuses, no confusion over here. You have the Cadwell's view, which is also called as the occipital frontal view, which, you can see the frontal sinuses very, very clearly. So I don't think there was any confusion there. This is also a very straightforward radiological question. So 2 image-based questions. I don't know if this was an image or whether it was directly asked. Prayas is saying this question was not given. Or ye bhi tha kya? Okay, so maybe this question was not asked, and in the recall, this was recalled from maybe a figment of imagination. Okay, great. There was a question on allergic rhinitis there. Allergic rhinitis does not include allergic salute. The allergic salute, when the child is, having chronic allergy, they lift up. This was there. Yeah, allergic shiners. And what was the option that was another option that was included? So Mushahid is saying wrong question. So allergic salute, allergic shiners, nasal crease, some oligowath line like that. What is Whitberg fold? Wen-Groth something was given. All right. Was it Denny Morgan folds? Denny Morgan folds, Whitbird fold. Okay. So Whitbird fold is not related to allergy. It is Denny Morgan fold. This. All right. Okay. Great. There was a question on vertigo, guys. Was there a question on vertigo, like progressive vertigo that later on stopped? Something like this was, recall. Yeah, Mushahid, you're right. Very good fold. It's a psychiatric depression, nothing to do with allergy or, ENT. Anything on vertigo? What is this? Recurrent bleeding with unilateral obstruction was given, Dr. Sumitra. Yeah, I have that question. That is a very classical juvenile nasopharyngeal angiofibroma question that, comes. This question was not asked, is what Lydia is saying. Juvenile nasopharyngeal question. Okay, so nothing on vertigo. Okay, let's get through this. Anything on vertigo was asked? No question on vertigo, so no need to waste time on this. Okay. This lower lip paralysis after parotidectomy, was this there? Which structure was involved in lower lip paralysis after? Hey, Sehag is saying vertigo pe question tha. What question was there, Sehag? Was there any question on vertigo? Because if it was there, then can you clarify what question was asked related to vertigo so that I don't miss that out? See, if there is any progressive vertigo, that progressive vertigo is usually will be seen in vestibular neuronitis, and then it will be self-limiting. It will stop on its own. But otherwise, I cannot make out from just this one line. But if you guys are not able to remember, then that's okay. But facial nerve ye wala tha. Facial nerve was the cervical branch, lower lip paralysis after parotidectomy, which structure? Okay. So marginal mandibular nerve is a very commonly asked, you can see the marginal mandibular nerve over here. Very commonly asked, question in surgical training as well as in ENT training. It's a cervical branch, so that's even more easier. They didn't really ask you the name of the branch. but it's a part of the cervical branch. All the other options, don't really make sense. Main trunk, you'll have, complete facial palsy. So Lydia is saying, yeah, these were the options that were there. So cervical branch would be your correct answer over here. All right. Now here I got different types of questions related to this. 8-year-old child, 10-year-old child. One, what is the treatment? One, what is the contraindication? Kaun sa wala tha? Jaya Chandra is saying that's progressive vitiligo. Oh, progressive vitiligo. Vitiligo, vertigo में बहुत फर्क है. Ego नहीं लाने का बीच में. Okay. All right. So then that is clarified. Thank you, Jaya Chandra, Chanakya, Gangapati. Okay. All except wala question is our second wala. All right. So in this, it is very straightforward. Okay. A child with sensory neural hearing loss, what will be contraindicated? Obviously, adenoidectomy and 𝐒𝐿 is a conductive deafness problem, okay? Because of the eustachian tube getting blocked and having otitis media with effusion and adenoids, you do that for conductive hearing loss. But cochlear implants, hearing aid, and making a child sit in the front row is also something that you can do for any child with sensorineural hearing loss. So if you think that sitting in front row in school is a contraindication, it's not really a contraindication. Sometimes children who have hearing problems can hear better when they're closer to the teacher. So here the contraindication would be adenoidectomy and grommet insertion for sensorineural hearing loss. Otherwise, cochlear implants, hearing aids, and all of that is fine. And here in the chat section, vertigo vitiligo contest is going on. Sir, dono question. Nahi sir, dono question the. Vertigo, vitiligo, both were there. Okay. See, whatever it is there, if anybody can remember the vertigo question, I will be able to help. If we do not remember the vertigo question, then let us forget it like vertigo, because we all don't remember that. Okay. And CJ is behind the Verogoth fold. Wo wala question already ho gaya hai. Okay. Yes, you have written contraindication. That was the exact question. So contraindication, adenoidectomy and 𝐒𝐿. And the last question, guys, very straightforward. Young male with unilateral nasal blockage, recurrent epistaxis, juvenile nasopharyngeal angiofibroma. This is always a very classic question without which no exam is complete. And, beefy red appearance in the nasopharynx, whether they ask it as image or ask it like this. So it was very, very straightforward. ENT, very easy. I am quite, relaxed, nothing, no bouncers, all very straightforward. And so I wish you all the best. And if there were any other questions asked in ENT that we have missed out that you can remember, then let me know. Otherwise, I think we are done over here with our ENT recall, and I wish you all the best. And we hope that in future also ENT exams are just as easy as it is in life and as a career. Okay. All right, guys. Thank you very much. Dr. Ranjit, to pass this on to whoever is next. But thanks, signing out. Any other questions, leave it in the comment section. Bye-bye.
Thank you, sir. And always fun as well as easy with you. So thank you, sir, for the quick recall. So next we'll be going with Ophthalm. Dr. Sudha ma'am will join us with the recall of Ophthalm. So over to you, ma'am.
Hi, Dr. Ranjit. Hi, everyone. So we'll be going over a quick recall of ophthalmology. So just tell me if I'm audible and visible to all of you.
Yes, ma'am.
Yes, okay. So see, I know you people have just come back after the exam, and it has been really difficult for the team also to collect and recall the questions from the students because everybody is tired. So this is like a very, very superficial run through of the questions. We will be coming up with a proper recall in the days to come. This is just to give you an idea about how the questions were. So in Ophthalm also, we have a collection of questions, but all the options are not complete. But still, we'll just run you through. So as it has usually been the case with Ophthalm, they have stuck to the PYTs in the INICET. In the INICET, they generally stick to the PYTs, and that is what they have done this time also. And let me just run you through the questions. So this is one question which I have received as a recall, a very simple one-liner, which has been asked multiple number of times. That is, what is anisometropia? Could not recall this we could not get all the options, but obviously there must have been an option which says that anisometropia is a significant difference in the refractive error between the two eyes, or a significant difference in the refractive power between the two eyes. Something like that should have been there in the options, and that of course is the answer. So when there is a significant difference in refractive error between the two eyes, that is what we call as anisometropia. Right, difference in axial length, difference in visual acuity. So, okay, those were the other options. But this was obviously there, I believe, difference in refractive error. Difference in refractive error must have been there in the options, right? I assume that must have been there in the options because that is what is anisometropia. Yeah, difference in axial length, of course, but I understand that was there in the option. But did you get something like difference in refractive error? Yeah, so that is the correct answer. It really doesn't matter what the others were options were. So difference in visual acuity, you're saying difference in axial length, difference in refractive error. So we should choose difference in refractive error between the two eyes, and that is anisometropia. So a simple one-liner which has been repeated multiple number of times before. So a simple question. Now, functions of superior oblique, again, something which we always say in our revision classes, in our general classes also, that this is something we must know like the back of our hand. That is, what are the functions of the superior oblique? So see, the primary function of superior oblique, you all know, is intorsion. The secondary function is depression, and the tertiary is abduction. So obviously, adduction is not one of the functions of superior oblique. So superior oblique is essentially abductor. So this we always remember by that mnemonic, right? RAD. RAD stands for rectus muscles are adductors, and which rectus muscles? That is the superior rectus and the inferior rectus. So the superior rectus and the inferior rectus are adductors. The superior oblique and inferior oblique are essentially abductors. So this was another question. Again, another simple questions I have to say. Now, the next question was also something which was simple, that all of the following are seen in third nerve palsy except. Right, I don't know whether the image was given. Was the image given in the question? I just thought I'll put the image in the slide, but I'm not sure whether the image was there. Was the image there? Was the image there in the question? Right, all of the following are seen in third nerve palsy except. So the options, no, the image was not there. Okay, fine. So the options, I think, were ptosis, dilatation of the pupil, or they may have given mydriasis, loss of abduction, and exotropia and hypotropia. Were these the options? So essentially, see, or something similar would have been given. Right. Obviously, we know that in third nerve palsy, the LPS is affected. So we are going to have severe ptosis. We will have pupillary dilatation because the sphincter pupillae muscle is affected. We are going to have the eyeball, which is deviated downwards and outwards, as we can see in this picture. It is deviated downwards and it is deviated outwards. So see, it is deviated outwards. Why? Because the LR is spared, we know, and hypotropia, that it is deviated downwards because the SO is spared. So these two are spared. And so obviously loss of abduction cannot be a feature of third nerve palsy because the lateral rectus is spared. So the LR is supplied by the sixth nerve and the LR is spared, and therefore abduction is going to be preserved in third nerve palsy. So abduction or limitation of abduction, loss of abduction, something like this would have been there in the option, and that is the answer. Loss of abduction is not seen in third nerve palsy. Right? So all these three questions were like very, very simple. Now the next question is something about chemical injury to the eye. The question was, what will not be seen, right? Yeah, so all are seen except, or something like this. All of the following are true except, or all of the following are seen except, or what will not be seen in third nerve palsy. Something like that, right? Yeah. So see, the next question is something about chemical injuries to the eye. Chemical injury, they may have given chemical injury, or they may have given lime injury, or they may have given alkali injury, or they may have given, yes, chuna injury, something like this. So exact words I do not know, but the question was about chemical injury to the eye. So either they would have said lime or chuna or alkali injury to the eye. And what is... Yeah, history of chuna fall in the eye, correct. So this is generally used by people for whitewashing, and that is when this alkali injury happens, and it's quite common actually in rural areas. So what is to be done next? Now this is like more of a common sense question. Even if you don't know anything about chemical injuries, common sense says that you have to wash the eye thoroughly. So continuous irrigation of the eye with normal saline till there is a normalization of the pH. So we are actually supposed to check the pH with litmus, and we have to normalize the pH. Till then you're supposed to give a continuous irrigation. There must have been other options, like for example, you patch the eye. Somebody said, yeah, fourth option was tarsorrhaphy. Okay, antibiotics, analgesics, tarsorrhaphy. So antibiotics, analgesics, all these things you obviously have to give. But I think the question would have been, what is the first step in the management, or what is the immediate management? The immediate management is obviously to wash the eye with normal saline till we have a normalization of the pH, and also to double evert the lids and to see if there are any particles of chuna or lime and to pick them out mechanically. So that is what is to be done next. So I think this question was also like very simple. Everybody would have answered it. Whether you have learned the topic on chemical injury or not, you would have done it with common sense only. Next, now this is one question I'm not very sure of, and I don't know whether the question was all are true except, or which of the following is true, but I think it was something like this, that there is a youngish patient and there is this kind of a fundus image that is given to us, where we can see multiple clumps of pigments in the mid-peripheral retina. Was it something like this? The clumps of pigments in the mid-peripheral retina in a youngish patient and suggestive of retinitis pigmentosa? I think it was like this, because retinitis pigmentosa traditionally has been a hot favorite with our INICET examiners. They really love it and they love to give questions on this. So I think it was something like this. So the picture is suggestive of a young patient with retinitis pigmentosa, and the question probably was all of the following are true except, right? So see, the most common of these is the rod cone dystrophy. It is essentially a dystrophy of the rods, but the cones are affected, may be affected in the end stage. On ERG, I think the option was both A and B waves are affected. Actually, A waves are affected in the beginning, and both A and B may be affected late in the disease. And night blindness is a late presentation. Was this the option? Was this the option? Night blindness is a late presentation. Night blindness is a late presentation is wrong. In retinitis pigmentosa, night blindness is the presentation. That is how the patient presents. Because that is how a patient of retinitis pigmentosa is going to present to us, and that is how you differentiate between cone rod dystrophy and rod cone dystrophy. In cone rod dystrophy, the cone is affected first, so the central vision will go first. But in rod cone dystrophy, which is the commonest, retinitis pigmentosa, the rods are affected first. So night blindness is the presenting feature. So according to me, if this was given, then this is not correct. I don't know what the fourth option was. Fourth option kya tha, pata nahi. Some of you are saying that it is hereditary. It is due to the congenital absence of photoreceptors. That was the fourth option. Congenital absence of photoreceptors. So it's not exactly congenital absence. It is a dystrophy of the photoreceptors. It's a dystrophy of the photoreceptors. I think they would have said it is a dystrophy of the photoreceptors, something like that. They could have said that it may be sporadic or hereditary, something like that they would have given. So yeah, it's a hereditary disease that is caused by dystrophy of the photoreceptor, something like this they may have given. So basically, night blindness is a late presentation is not correct. Night blindness is the initial presentation, right? So I think this is what is not true. So probably this is the question and this is the answer. This is also like, very much doable, right? So the next one is also, I am not too sure what exactly is the question, but this is what the students have recalled, that there is a patient of rheumatic heart disease who is not compliant to medication, and this patient has presented with a loss of vision, which is essentially described as a superior visual field defect, something like this. So if it is a patient of rheumatic heart disease and they are saying that the patient is not compliant to medication, they probably are trying to hint at a possibility of embolism. So patient of rheumatic heart disease and non-compliant to medication, this probably hints as the possibility of embolism. So if it is a possibility of embolism, and these were the options, I believe, CRAO, CRVO, BRAO, BRVO, यही था क्या option? CRAO, CRVO, BRAO, BRVO, ऐसे ही कुछ था? हाँ, so देखो here ना, if it is suggestive of embolism, we have to choose arterial occlusions. Now they have not said that there is a severe loss of vision. They have said that it is a visual field defect. So if it's a superior visual field defect, then it is likely to be a branch retinal artery occlusion. So this is probably, if this is the question, then this is probably the answer. Okay, so non-compliant to medication, rheumatic heart disease, suggestive of embolism, and the fact that it is, they have not said that there is a severe central loss of vision, but they have mentioned that there is a field defect, which means that only one branch of the artery is probably affected. So the answer to this question should be BRAO. I think that if this was the question, then this should have been the answer. Yeah, sudden loss of vision, of course, sudden loss of vision will be there, but they have also mentioned that loss of vision is described to be more in the superior field. If the superior field only is involved, that means that it is the inferior branch of the artery which has been affected. Otherwise, this kind of a field defect would not have been mentioned in the question. So if it is a BRAO which is inferior, you will have a superior defect. And if it is a BRAO which is superior, you're likely to have an inferior defect. That is probably what they were trying to mention in the question. So the question was something similar. This, I would say, was a slightly tricky question. It's a PYT, but it has been framed in a way which is slightly difficult. Now, let me go to the next question. The next question, I'm also not sure what this is. It probably mentions that there is an elderly patient and there is an advanced cataract. And in the eye that the patient has an advanced cataract, the IOP is also very high, right? Something like this. That elderly patient hai, cataract hai, and IOP is high, right? So this is probably, this mentions lens. This means that it is a case of lens-induced glaucoma, right? Now, I don't know what was given along with this. Isme two options ho sakte hain. Either they say that it's a shallow AC. If they say that it is a shallow AC, then the answer is phacomorphic. If they have mentioned in the question that the AC is shallow, then it is phacomorphic. But if they say that the anterior chamber is deep, if they say that it is a deep anterior chamber, or if they have mentioned cells and flare in the anterior chamber, it is likely to be phacolytic. Yeah, so I think that if they have mentioned cells and flare, then they would have mentioned deep anterior chamber. That is more likely. That is more likely because cells and flare in the anterior chamber is suggestive of proteins in the anterior chamber, which means that it is a protein, lens protein glaucoma or a phacolytic glaucoma. So agar ye question tha na, then the answer is phacolytic glaucoma. Was this? They have said that the anterior chamber... Yeah, they have mentioned that it is deep anterior chamber. Yeah, that is very likely because, see, the question says that it's an elderly patient with cataract and there are cells and flare in the anterior chamber. So cells and flare in the anterior chamber ka matlab hai there has to be some source of inflammation. So proteins in the anterior chamber. So they probably would have mentioned that the AC is deep. So it is phacolytic glaucoma. If it had been phacomorphic, they would have mentioned that the anterior chamber is shallow. Yeah. So the answer is phacolytic. Right? So this is another question. Now the next question, this also is, was this the question that photophobia and lacrimation are seen in all except congenital NLD obstruction, congenital glaucoma, congenital entropy, and congenital dystichiasis? Yahi the kya options? Photophobia and lacrimation are seen in all except? Yeah, so the answer has to be congenital NLD obstruction, because in NLD obstruction, for surely there will be no photophobia. Photophobia, lacrimation is going to be, I mean, watering will be there. We cannot even call it lacrimation. It's epiphora actually. Watering is going to be there in congenital NLD obstruction. But you are not going to have photophobia for sure. In congenital glaucoma, we know that photophobia, lacrimation, blepharospasm are the options, are the symptoms. In entropion and dystichiasis, we are more likely to have lacrimation, but if the cornea ends up having an epithelial injury, then you can have photophobia also. So entropion and dystichiasis are not very likely to present with photophobia, but they can have photophobia. Possibility is there. But NLD obstruction will never have photophobia. It is only going to present with watering. So that is the answer. Yeah, why are we going to have, yeah, photophobia is not going to be there because it's not going to affect the cornea. No? It's an outflow obstruction. So that's why. So, or if the question was, if the question is that photophobia with lacrimation is seen in, then I would mark congenital glaucoma as the answer. If they say that if the question is photophobia and lacrimation is seen in, was it seen in or all except? Did they say seen in or did they say all except? All except? Yeah. So all except हुआ तो फिर NLD को ही mark करना है, because NLD में certainly there is no photophobia. Entropy and dystichiasis में if it causes corneal injury due to rubbing, उसके बाद photophobia हो सकता है. Okay, चलो. Let's go to the next one. Yeah, there was one more question which I managed to gather, and then that is a question about a patient who presents with flashes of light and floaters. And probably they mentioned that this is a patient who has retinal detachment, right? Retinal detachment. So flashes of light and floaters. And in a patient who is also a myope, I think there was a question like this. This may be suggestive of a rhegmatogenous retinal detachment. Was there a question like this? Patient presents, a patient who's a known high myope presents with flashes of light and floaters. Yeah, high myopic patient. So it is obviously rhegmatogenous RD, rhegmatogenous retinal detachment. Yeah, I understand. See, we don't know what exactly this question was. Ideally, if they ask photophobia and lacrimation is seen in, then the answer is congenital glaucoma. But as I said, if the question is are seen in all except, then I have to choose NLD obstruction, because entropy and dystichiasis में rarely photophobia हो सकता है. If they injure the cornea, तो इन दोनों में भी photophobia का possibility is there. So if the question is all except, then you choose NLD obstruction. But if the question is photophobia and lacrimation are seen in, then we have to choose congenital glaucoma. Now I do not know what exactly was the question. Yeah. So these are the Ophtha questions that we have been able to recall. I think there were a few more, but as I told you, people were like everyone was tired, and we will try to make a proper recall of the questions and we will share them with all of you very soon. So till then, I think that this is what it was in Ophtha, and like questions were mainly previous year's topics, and I think most of you have been able to answer the questions correctly. So Dr. Ranjit, I think we can move on to the next subject.
Thank you, ma'am. That was, I think, the longest optal recall I've ever seen. So
yeah, we had a lot of questions this time, as is expected in INI.
Yeah, after a good number of questions, and students are saying that Optal and Ortho was more. I hope you guys got most of the answers right. And like ma'am said, we will be coming up with a very elaborate recall soon. Thank you, ma'am. Thank you once again. So next we have Physiology. Dr. Vivek sir will join us soon. And hello, Vivek sir. Sir is from Kashmir. He's there and he's going to give us a brief recall of the physio questions. So over to you, sir. The stage is yours.
Hello, sir. And hello, friends. Good evening. I'm taking this session from a little difficult circumstance, but I hope I'll be able to cover all the questions. And let's share the screen first. All right. Ranjit sir, am I audible and visible? I hope.
Yes, sir.
So, physio questions were not a really a full toss type of question. They were half volleys, juicy half volleys. That is, the topics were the same topics which are always asked. And I'm just trying to share the screen. Anyways, without wasting any time, I'll just share the questions with you, and you can suggest the options. Substantia nigra is connected to which part of the basal ganglia? That was the question. And I think the options were striatum, pallidum, subthalamic nucleus, and thalamus. So I'm really sorry, the network is little wavery over here. Substantia nigra, as you all are aware, it's not involved in the direct or indirect circuit of the basal ganglia. The question was, which part of the basal ganglia it connects to? And the options given were striatum, pallidum, etc. So, basal ganglia circuits involve cortex to striatum, striatum to pallidum, pallidum to thalamus, and back to cortex. This is the circuit of the basal ganglia. And substantia nigra just modifies or modulates the striatal neurons activity in the basal ganglia. And just to remember, nigrostriatal tract. So substantia nigra connects to the striatum. You must have done this in Parkinsonism also, degeneration of dopaminergic neurons in the nigrostriatal tract. So it connects to the striatum, and that was a straightforward one. Then the next question, I'm still trying to just share the screen, but till then you all can suggest the options. Particularly, I got the questions, but not the options. In what sequence does the erythropoietin synthesis occur in the following organs? And the option that I got was whether it is only kidney or liver and kidney or lungs, liver, kidney, like that. So next time we will just collect the options from you, and then we will have a proper session on this. But 90% of the erythropoietin synthesis occurs in the kidney, and there are extra renal sites like liver. So 10% occurs from the liver, and remaining and major, of course, is the kidney. So kidney and the liver, if this were the option, then that's the most appropriate and the correct answer. Then there was a question, which of the following is the correct match of the diuretics and channels they act on? And the options were thiazides, PCT, carbonic anhydrase inhibitors, PCT, spironolactone in the collecting duct, and loop diuretics, DCT. So here, loop diuretics, they act on the thick ascending limb of loop of Henle, and the transporter is NKCC transporter. Thiazides, they act on the DCT, and the transporter is NCC transporter. So that leaves us only with two options: carbonic anhydrase inhibitors, PCT. Now, basically, carbonic anhydrase enzyme itself is found in the PCT, and therefore, the carbonic anhydrase inhibitors, the acetazolamide, it acts on the PCT. That was the correct option in this. Spironolactone and collecting tubule, that was the option given to me while collecting the recalls. Well, spironolactone or let's say potassium sparing diuretics or aldosterone antagonists, they act on the distal nephron and mainly in the collecting duct. So I would go with carbonic anhydrase inhibitors acting on the PCT. Then there was a question on the GFR. Now, this was a straightforward one, and I hope all of you could solve this question. Which of the following would cause a decrease in the GFR? Is it increased capillary hydrostatic pressure, or increased plasma colloid oncotic pressure, or decrease in the Bowman's capsule hydrostatic pressure, or decreased plasma colloid oncotic pressure? These were the options. Now, basically, there is one factor. These are the Starling's forces, you know that. And one factor that favors the filtration at the glomerulus, and two factors oppose the filtration at the glomerulus. Capillary hydrostatic pressure is the force that favors the filtration at the glomerulus. So that if that increases, the GFR will increase. So the option given was increased capillary hydrostatic pressure. It will increase the GFR, not decrease. So that's gone. Then we had increased plasma colloid oncotic pressure. Yes, plasma colloid oncotic pressure is a force that opposes the filtration at the glomerulus, and therefore, if it increases, that means the GFR would decrease. So among the options, this was the correct option, and therefore the answer. Then there was one more question, which was a straightforward one. As I said, there were some full tosses and some half volleys, juicy half volleys. This was the one. All of the following are the characteristics of the ventricular muscle, except, and the options were, follows length tension relationship, or it has a long refractory period, or it shows tetanus, or has fast type of action potential. You know, ventricular muscle has a long refractory period, and therefore it is a non-tetanusable muscle. I mean, it does not show tetanus, and therefore that was the answer. It doesn't show tetanus like a skeletal muscle. Sustained state of contraction, failure to relax because of a high frequency stimulation of that muscle. This is not possible with the cardiac muscle, ventricular muscle, because it has got a long refractory period. So it doesn't show any tetanus, and that was the correct answer. Then there was a question on blood group, about the ABO blood group. I beg your pardon. ABO blood group. Which of the following is incorrect regarding the ABO blood group? IgM is the most common antibody in the ABO blood group. Yes, I got only 3 options from this during the recall, or recalled by the students. IgM is the most common antibody in the ABO blood group. Yes, the A and B antibodies are IgM type, and they are present in plasma almost immediately after birth. I mean, through food, through bacteria. A and B antigens are, I mean, the child is exposed to those antigens, and those antibodies are present almost immediately after birth. So they are present since birth, or let's say immediately after birth. And ABO antibodies can cross the placenta, if that was the question, that was the option. Well, RH antibody, anti-RH antibody is of IgG type, and it can cross the placenta, whereas A and B antibodies, anti-A and anti-B, they are IgM type mainly, and they don't cross the placenta. So therefore, that was the answer, I guess, because I got only 3 options in this, but ABO antibodies cannot cross the placenta, and therefore that was the answer. There was one visual. I'm afraid I'm not able to just show it right now, but colorimetric method, and it was Sali's method. You know, there is a small box like instrument with 2 colors on the sides, where with which you can match your blood sample. So it was Sali's hemoglobinometer, and then there was one question on anion gap. So sodium given was 135 milliequivalents per liter, chloride given was 92 milliequivalents per liter, and bicarbonate 20. So it was a increased anion gap acidosis, metabolic acidosis with increased anion gap, because normal anion gap is let's say 8 to 16 milliequivalents per liter. This was way above that. It was 24 milliequivalent per liter. And how you calculate it? Sodium minus the chloride plus bicarbonate. That is how you calculate the anion gap. And the values were given. It was high anion gap metabolic acidosis. So I guess because of the difficult circumstances, I could gather only these many questions. Ranjit sir, if you could take over from here.
Thank you, sir. Thank you for being available and sharing all the recalls. And sir, we will be giving a very complete recall with all the correct options very soon. Thank you once again, sir. So next will be Pawar sir for anatomy, and Dr. Pawar sir, over to you, and I'll leave the rest.
So hello students, ready for anatomy? How are the questions? Let us start one by one. So whatever questions I've got, let us discuss. You can add to this. So here, structure not present in the floor of inferior horn of lateral ventricle. We know the inferior horn of lateral ventricle comes in the temporal lobe, right? And what lies in the inferior horn is the hippocampus. The tail of the caudate nucleus comes there. The hippocampus comes there. Hippocampus is a gray matter. And what begins from the hippocampus? Yes, what begins from the hippocampus is the alvea, the fimbria. The fimbria then continues as the fornix. Correct? So the structure not present would be the commissure. The commissure. Right? So tail of caudate nucleus, yes, that's correct. Hippocampus is there. The fimbria would be there. So this is what the options have got. So answer for this not there would be the commissures. Right? Come to the next MCQ. True regarding the breast. So what are options I've got? The superior medial quadrant has more tissues. What is that? It's the superior lateral quadrant, not superior medial, it's superior lateral quadrant. 10 lobules are present. There's 10 to 100 lobules which are present within the breast. The axillary tail of Spence crosses the anterior axillary fold. Correct? So that is the answer for that. I got three options. The axillary tail of Spence, yes, it crosses the anterior axillary fold, lies in the anterior wall of axilla. Right? So this is the answer for this MCQ. The other MCQ which had come was structures passing between the superior and middle constrictor. Yes, what do you say, students? Bolo, answer this. Structures passing between the superior and middle constrictor. We always discuss this during our lectures. Yes, any guesses? It's the glossopharyngeal nerve and the stylopharyngeus muscle. The stylopharyngeus muscle, I don't know what were the options, but this is the answer for this question. The stylopharyngeus muscle begins from the styloid process, goes between the superior middle constrictor, enters the pharynx, joins with the palatopharyngeus and the salpingopharyngeus, gets inserted on the posterior lamina of thyroid cartilage. The nerve which supplies the stylopharyngeus, the glossopharyngeal nerve, also enters along with the stylopharyngeus between the superior and the middle constrictor. Right, students? So this was an easy MCQ. I hope this all of you must have definitely got correct. Okay, let us go to the next MCQ. Thoracic vertebrae forms which of the following joints? Yes, bacho, tell me. This were the MCQs. This were the options, sorry. Thoracic vertebrae forms which of the following joints? I've got three options. So symphysis, yes, what is symphysis? That's a secondary cartilaginous joint. Yes, that is present between the bodies of the thoracic vertebrae, correct? The symphysis, the secondary cartilage joints, which is the temporomandibular joint, the intervertebral joint, the pubic symphysis. What is synchondrosis? Synchondrosis. Okay, synchondrosis. What is synchondrosis? It is a primary cartilaginous joint. And what happens to the synchondrosis? It gets converted into a bone, and this is known as synostosis. So synchondrosis is a primary cartilage joint not seen in the vertebrae. What is syndesmosis? Syndesmosis is a fibrous joint. Fibrous joint, again, not seen in the vertebrae. So the vertebrae shows two types of joint. One between the bodies of the thoracic vertebrae, that's symphysis, and the facet joint between the facets. Okay, the transverse processes have got, the pedicle have got the superior and inferior articular facets. That joint is a synovial joint. Also, the vertebrae articulates with the ribs. This costovertebral joint is a synovial joint. Synovial joint was the fourth option. Synovial joint was the fourth option. Right. So synovial joint is also correct. So what are options I've got? I'm telling you. Synovial, if it is the fourth option, yes, it also forms the synovial joint. Clear? So later we'll come with the detailed answers for this. See this MCQ, this was marked, students, this was marked. What is this slide of? This is the suprarenal gland. Okay, this slide had come. So this was the suprarenal gland. What is this marked structure? That's the zona glomerulosa. And what does it secrete? It secretes mineralocorticoids. That's aldosterone. Clear? So this was the marked structure. Correct, hai na? Yes, students. Bolo, bolo, bolo. What do you say? Right. So zona glomerulosa. As we know, fasciculata secretes glucocorticoids and reticularis secretes androgens. The medulla secretes catecholamines. Okay, so that was the pointed structure. There was an image of histology in which an epithelium was shown. Can anyone tell me what was the type of epithelium? What have you answered in the exam? Okay, that's fine. That's fine. What was the image? Histology image? Yes, Shag, what was the histology image? It was a multi-layered epithelium with squamous cells at the top. So what was that epithelium? Hi, Samudra. Bolo. Not formed. What? Which question are you talking? Which was not formed. Okay. Okay, we'll come to that. We'll come to that. Answer this. So it was a multi-layered epithelium with flat cells at the top that was stratified squamous epithelium, stratified squamous. Whether it was keratinized or non-keratinized, I have not got that. But it was a stratified epithelium, stratified squamous epithelium. I hope you've answered that. We'll come to that question, which were level of ischial spine. Yes, anyone? What have you written about this? Options have not got, but what is the level of ischial spine? The coccygeal vertebrae, the coccyx, the coccygeal vertebrae. That's the level of ischial spine. If that was there in the optional, the answer would be the coccygeal vertebrae. Okay, lower lip paralysis after removing the parotid gland after parodectomy. Yes, involvement of which nerve? It's the marginal mandibular branch of facial nerve, which is going to supply the lower lip. So it was written as lower lip paralysis. So answer for that is, okay, that's fine. So answer for that is the marginal mandibular nerve, which supplies the lower lip. Okay. So the nerve injured is marginal mandibular nerve, which is a branch of facial nerve during parodectomy. Fine. So what are questions I've got? I'm telling you. Most common hernia in females. Shall I answer this? This I hope I'm sure that you must have answered this. Most common hernia in females. Yes, Shag, this was there, no? Most common hernia in females. Yes. What is the answer? Yes, Somatra, you must be knowing this. This is the femoral. Most common hernia in females is femoral hernia, no? Because the femoral ring is wider in females. This we have been discussing all the time. The femoral ring is wider in females because of the wider pelvis and the smaller size of the blood vessels. So femoral ring becomes wider in females. So chances of femoral hernia are more common in females as compared to the inguinal hernia, which is common in males. So I'm definitely sure this you must have got right. Where will be calcification? Okay, parotid duct. Calcification, if that was the question, bacha, it would be parotid duct, right? Anything else? Any other question was there? Any other question? So this is what I've got. Recall of anatomy. Fine, Ajit sir.
Hi, sir. Thank you for the quick recall. And we will be
a quick recall.
images and the complete answer with detailed explanation will be on the MedEd app. So thank you, sir, once again. So next we have Dr. Ira Datta. So she'll be discussing with you the questions which came in psychiatry. Over to you, Dr. Ira.
Thank you, Dr. Ranjit. All right, students, how was psychiatry for you all? In my opinion, it was quite an interesting mixed bag. I've written all the topics on the screen for you. There were things from alcohol, substance, a very classical favorite. Almost every year there's something from here. There's child psychiatry, and autism was the particular topic that they picked this time, autism spectrum disorder. Definitely, please keep dropping in the chat box if any recall of mine is incorrect or if I've missed something. Happy to make amends to this later. And there was something about paraphilias, which in my opinion was a PYQ. So ek bari dekhenge. Seizure disorder, which is an overlap between pediatrics and definitely psychiatry as well because of the substance involved in it. There was a depression related question, bipolar disorder related question, particularly rapid cycling. And there was something from community psychiatry, which was a little bit of a googly. So let's get started. All right. The first one that I managed to get was something around matching the following. Was there such a question? And if yes, then yes, this was most likely a PYQ because a similar one was asked in INICET 2022. I have matched the right ones for you so that it becomes easy. You can definitely, go ahead and tell me if I missed or I've added some other option through my recall. So eonism is also called transvestism. Now, how you remember it is essentially you wear a vest and you take it off, right? So it is sexual pleasure by wearing clothes of the opposite sex. You can put on a vest and you can remove a vest. So that is transvestism, aka eonism. It's the same thing. Exhibitionism is when you show your genitalia to unsuspecting, unconsenting strangers. Voyeurism is exhibition was not there. Okay, exhibition was not there. Which option was there instead? Sexual gratification by rubbing private part against another person who is non-consenting is voyeurism, and necrophilia is sexual gratification with dead bodies. So which one was there? If exhibitionism was not there, please definitely add. We'll amend these questions as we go along. The next one was about cannabidiol, which is one of the substances found in cannabis. So cannabis has many compounds. And in those compounds, we already know about THC and CBD being the main one. But one of them is cannabidiol, and there is a brand name called Epidiolex, which has been FDA approved for the treatment of seizure in Dravet syndrome. Yes. Lennox-Gastaut or LGS, absolutely yes. Tuberous sclerosis, yes. I was able to recall that there was a Rett syndrome option. Is that right? If Rett's was an option, then the answer is that Rett is not there. So it was approved for the use of all except. It was an except kind of question that I can recall. Please correct me. What was the question? Tulsi, please tell me the question. Siha, you can definitely correct the question because this is what I was able to recall. Rett was there, okay, and I didn't mark any. Okay, it's fair. Also, this is an overlap question. And Dravet and LGS and TBS may it is eonism. Eonism was already covered in the previous question. Eonism was already there, and I told eonism is also transvestism. So can't be used. Yeah, can't be used. So not used in Rett syndrome. That is the answer. Moving on to the next one, the question was from child psychiatry. This is a pretty straightforward one. I believe you should have gotten this right. ASD or autism criteria does not include social developmental issue, communication skills issue, cognitive developmental issue, and repetitive acts. Now, the question may have been framed differently, of course. They may have been like a lack of development of like that, it may have been framed, but I've just tried to highlight what I could recall the basic points. So the 3 hallmarks of autism spectrum disorder, please always remember, is impaired social interaction, restricted and repetitive behaviors and repertoire. So that is RRRB, and communication challenges. Now, why I've written challenges is because just lack of communication is not the only thing. There could be many things. So if this is the question, then the answer is yes, cognitive development. You're right, Mont, you're absolutely right. So then cognitive development is the one which is not included in the ASD diagnosis. Pretty straightforward, easy tha, in my humble opinion. Next was favorite, alcohol. Alcohol related questions are super common. Who all can complete this question for me? What I understand is that they gave you a lot of options around Korsakoff. The question was around Korsakoff. I'm not able to get the full question. To the best of what I've understood is that there were multiple options given, and you were either supposed to sort of tell that what is not there or what is there. वो आप लोग मुझे बताएंगे please in the chat box. What am I missing? But just for a quick reminder, you should always remember Korsakoff and Wernicke's differences. So to start off with, clearly Korsakoff has retrograde amnesia, anterograde amnesia, confabulation. So this short form, I called it RAC, and it happens because of deficiency of vitamin B1, which feature is not included. Okay, so which feature is not included, and the options are correct. Have I picked up the right options? Confabulation, ophthalmoplegia, polyneuropathy, and amnesia associated with same exact question, same. Okay, all right. So in that case, it's very, very simple. You can see I have mentioned all the features. So what is the right answer, guys? Polyneuropathy, absolutely. Polyneuropathy is not a part of Korsakoff psychosis, while yes, B1 deficiency can show with polyneuropathy, but not a part of Korsakoff psychosis. Okay, and confusion agar rehta, if confusion would have been one of the options, or if let's say ataxia, I'm sorry, ophthalmoplegia is the right answer. Polyneuropathy is there. I'm sorry, I got carried with your answer. So see, ophthalmoplegia is not there in Korsakoff because it is there in Wernicke. Polyneuropathy hai because B1 deficiency may, if you remember, if you remember the fact that polyneuropathy can happen because of B1. Ophthalmoplegia is the right answer. Absolutely. So who had said poly? Mon? No, you confused me as well. So I will rectify in case this question was different, but to the best of the knowledge, this was the question. Confabulation hota hai, polyneuropathy hota hai, amnesia hota hai, but ophthalmoplegia Wernicke's mein hota hai, which is why polyneuropathy is acceptable here because of the B1 deficiency. Okay. Moving on to the next. You were not expected to know this answer. I know this is a very difficult one. Which condition is not covered in the mental health action plan? This is a community psychiatry question and it's a WHO this thing. Which are present, which is not present or are present. Now, in case if the question was which is not covered, then OCD is the right answer. Which all are covered? Yeah, OCD is the most appropriate answer, although I'm still going through the entire 40 pages of the mental action plan myself and trying to come back with a better answer for you. Just in case if this answer changes, then please bear with me. Children, that's why I will take a little bit of time to get the best answer for this particular one, because in community psychiatry, I have to read the latest updated manual, which is for the new particular years, the next decade. So I'm going to take some time, but currently OCD is the best possible answer. The next was a very straightforward one, the Beck's triad of depression. We have covered this in our classes. And this question, if whatever options it had, definitely there was something framed around the negative view around the world, negative view of oneself, negative view of the future. And if cognitive decline was one of the answers, was it, guys? Was cognitive decline one of the answers? Then Beck triad does not include. What does it not include? It does not include cognitive decline. Is that? Yeah, not present in Beck's triad of depression is cognitive decline. So it will be negative view about self, negative view about others, negative view about the future, and introjection was there in the option. Okay, then in somatic thoughts was one option. Okay, I've got the dysfunctional belief. So dysfunctional beliefs, automatic thoughts, all right, introjection, and what other options were there? Okay, I'm going to jot down your options and I'm going to come back to you with a reformed recall for this because I didn't get the entire options for the particular question on depression. Okay, cognitive was one option. Cognitive what? Cognitive decline, automatic thoughts, dysfunctional belief, introjection. Introjection is towards inwards. Yes, automatic thoughts are there. Negative automatic thoughts tha ki sirf automatic thoughts tha? Dysfunctional belief bhi correct hai, but cognitive kya tha? If you can fill in that for me, that dysfunctional belief, automatic thought, introjection, cognition. Cognition what? Just cognition was there? Or was there a particular word? And automatic thoughts was just automatic thoughts and negative automatic thoughts. Among which one of the following should not be considered? Okay, I'm going to take time to get back to you on this particular one because now the options that I had thought originally, which I procured, are very different. In that cognition assessment, okay, give me time to get back on this one. The next one is pretty straightforward, is about rapid cycling, and I could only get two options. Please fill the options for me. That is something around rapid cyclers, all are true except what is not true. Now, if the options were that it is not there in females and more in males, which of these options were noted by you? The answer was that it is not more in males, it is definitely more in females. And what is rapid cycling? It is 4 or more switches. Switches matlab going up and down. So either you have a manic or a depressive episode. When the switch happens more than 4 times in a year is called rapid cycling. All right. Triggered by antidepressant. Associated. See again, thank you guys. You're really adding more good options. I wasn't aware of this. Meko ye recall mein nahi mila tha. If you can put in triggered by antidepressant therapy was one of the options. Rapid cyclers. Yes, it can be triggered by antidepressant therapy. Absolutely. Rapid cycling can happen. So if except was the question, more in males option was there, triggered by antidepressant, rapid cycler. Okay. Things just got out of our hand. It's given us the whole question. Rapid cycler is not true in more in males associated with hypothyroidism, at least 4 attacks per year, increased risk with antidepressant. In that case, the first is the right answer, more in males, because it is actually more in females. It is associated with hypothyroidism, and there are 4 attacks per year. And then there is a risk of antidepressant switch. That is called a manic switch because of antidepressant. Yes. So that one is sorted, more in males. A question tha, guys, help me out. This was something around supportive psychotherapy. I don't know what the question was. I only got the topic off from some people. If you could help me out, fill in the questions about supportive psychotherapy. And later, I am going to sit down on the next question to rework it, definitely. And I'll try to put it back here in the comment section by the night to understand it. Was there supportive psychotherapy related question? Anything? Am I missing something? It was an option. Okay. This question option were long. Right. That's what everybody said. It was very heavily worded. If you can even just give me a rough understanding of what was there around supportive psychotherapy? Was it indications of supportive psychotherapy? Because then I could just explain to you what are the possible indications of supportive psychotherapy. No, it was which feature is included. Okay, we'll wait for this one. I don't think then we need to sort of dig up into something. One patient was stable. Supportive psychotherapy, if you just want to understand, is where there is no particular agenda like getting the cognitive restructuring done. It is just to support the patient, and indications and all I can add patient with frustration tolerance. So we'll come back with the question for this. So just to recap, alcohol, very, very important, guys. ASD, child, yes, important. Sexual disorder, paraphilias, asked, repeat in my opinion, PYQ. Seizure disorder was something interesting and new. Depression, same old, but question I will rework and add in the comments later. Bipolar disorder, rapid cycling, important topic again. And community psychiatry was a little bit of a googly question. All right. So that's from me, Dr. Ranjit. I think I will wrap up because I will add in whatever is left over later. We will try to obviously modify this to the best of our knowledge and bring the better version to our students.
Thank you. Thanks a lot, ma'am. I'm never going to forget transvestism. So that's with psychiatry. So next we'll have Dr. Sandeep, the surgery guy, with us. And over to you, Sandeep. So it's your place.
Thank you. Thank you. All right, guys. Give me a second. Okay, wait. Okay. So I hope everybody is there. I think it's audible, visible, all clear. Surgery, no bouncers. Yes, there was here and there. This time the options were tricky. Like I love how the questions were framed. So let's see, dig into each question and try to understand how the options were tricky. The question number 1, which of the following step will not result in hoarseness of voice? This is about the thyroid surgery, right? This is with respect to thyroid surgery. Now, when we talk about the various steps in the thyroid surgery, the first step is the skin incision. That is going to be your Koch's incision. Then you divide the platysma, that is to create a subplatysmal plane. You'll incise the strap muscles. Now, recurrent laryngeal nerve. See, when you talk about the hoarseness of voice is occurring due to the damage in the recurrent laryngeal nerve, right? And that to unilateral. If there's a bilateral damage, it will result in medialization of vocal cord causing severe respiratory distress. So which step will not cause damage to the recurrent laryngeal nerve? Ligation of the superior thyroid artery. Now, recurrent laryngeal nerve is present on the inferior pole. Now, you take this as the representation of the thyroid gland. You will see the recurrent laryngeal nerves course will be here. So this is where the recurrent laryngeal nerves are present. Ligation at the superior thyroid artery will not cause the recurrent laryngeal nerve damage. Strap muscles is in the midline. Recurrent laryngeal nerve will not be in midline. So hence there is no problem here. Tubercle of Zucker-Candle is on the lateral side here. Again, it will not cause any problem. Bear's triangle is the triangular area to identify the recurrent laryngeal nerve. Yes, dissection at this area can result in the damage of your recurrent laryngeal nerve. right? So recurrent laryngeal nerve injury is associated with Bayes triangle dissection. Clear? So you need to analyze, see, it's a post-operative complication of a thyroid surgery, and then you know that what are the components where are going to be closer to recurrent laryngeal nerve. As simple as that. Clear? Okay? So moving on. Again, very interesting question. Cholangiocarcinoma is not seen in which of the following condition? Remember, cholangiocarcinoma is not seen in hepatitis B. It is seen in hepatitis C virus, right? So see, all except mein pucha tha beta question. This is what I've got. If there's a reframe of the question, kindly repost it. Then we'll look across here. Okay. So this is the question that I got. In this, the best answer will be a Bayes triangle dissection. Except hai, we'll check across it. If the question is on except, then we have to get the options also. Okay. Sure. Now, cholangiocarcinoma is not seen in hepatitis B virus. It is seen in hepatitis C. 𝐒𝐂𝐈𝐀 disease. Yes, 𝐒𝐒𝐈𝐀 is, as we all know, it is the multi-cystic component of the intrahepatic biliary tree, right? Opisthochus viverni and your Clonorchis sinensis are the two parasites which are associated with cholangiocarcinoma. Primary sclerosing cholangitis is also associated with the cholangiocarcinoma. Answer here is going to be your your option A, that is your hepatitis B virus. Now, this is the same table that is taken from your Bailey chronic conditions, primary sclerosing cholangitis, oriental cholangiohepatitis, hepatitis C virus. You can say Opisthochus viverni, Clonorchis sinensis, congenital choledochal cyst, the 𝐒𝐂𝐈𝐀 disease, chemicals are thorium dioxide, vinyl chloride, dioxin, asbestosis. Any biliary enteric anastomosis will result in cholangiocarcinoma. Okay? Chalo. Now, question number 3, what we have a patient presented to the ER, symptoms suggestive of anaphylactic shock. Which of the following signs and symptoms will not be seen in this patient, right? Now we're talking about anaphylaxis and we're talking about shock. Any patient of shock is going to have two things. One, you will see there will be presence of hypotension, and to compensate, there will be tachycardia. Now, this tachycardia will be converted into bradycardia in a neurogenic shock. Otherwise, everywhere you will have this. So, hypertension cannot be seen in shock. Hypertension is seen in Cushing's triad. So, answer here is C for Calcutta, right? Absolutely easy peasy question. Now, the next question that we have a 26-year-old patient, dysphagia, halitosis, regurgitation, or digested food. Best diagnosis based upon the symptoms. See, achalasia is not seen in young patients like at 26, but again, that's the only, downside to it. You look at the image, this looks like a bird beak appearance or a pencil tip appearance. The best answer for this is going to be your achalasia cardia. Stricture will have narrowing, then again, there'll be flow will be present. Malignancy will have an apple core appearance. Option D, if anybody has it, please pick it across so that we can add to the option. Any other option, guys? Option D. Any other option? Option D, option D. Option D. Okay. So moving to the next question, identify the instrument that is given below, right? Identify the instrument given below. Now, rather than an instrument, it's more like a kit. What you have to see in this kit is to draw your attention to this, right? You see, there is a stopper, and the stopper is an evidence of percutaneous endoscopic gastric tube. That is your PEG tube. Answer is A. Tunneled catheter is what we call it as the Hickman's line. This is what we call it as the Hickman's line. The Hickman's line is going to be a tunnel central line. All these, when you look at this is how a central line would look like. In the central line, you have the cannulating catheters here. So this is the image of the central line. And this is how you see a chemo port. Now, remember, in the chemo port, you will have this diaphragm, right? This is in the subcutaneous plane through which you inject, and this goes into the vein, which is going to be an access point. Okay? PEG was not given. What was the options given? I got the options as PEG, Hickman, that is tunnel, central catheter, central line, chemo port. What else was given, guys? Yeah, PEG is done for gastrostomy. But it is also called as the gastrostomy tube. Also referred to as the gastrostomy tube. Okay. Achha, the other options were orogastric, This is not an orogastric tube. Can you identify and recognize the image? Is it the same image given in the exam? That's something that I want to know. Is it the same image given in the exam? Almost same. Okay. Oral is more common in females, but oral is. बेटा we'll come to that question, don't worry, it's a very repeat question. ठीक है, हर्नियास पे वो सवाल ना बचपन से पूछा हुआ है. ठीक है, वार्ड्स में पूछा है, आपके क्लिनिक्स में पूछा है, नीट में पूछा है, आईएनआईसीटी में पूछा है. अगर अभी भी गलत कर रहे हो देन प्रॉब्लम अपने में, क्वेश्चन में नहीं है. ठीक है, चलो. Now, which of the following is the most common hernias in female? Remember, males or a female. Let it be male or a female. We'll write female first because they're always first, right? Let it be males or females. Remember, it is indirect inguinal hernia, which is more common in direct inguinal hernia. Overall, most common is inguinal hernia only. But if you ask you femoral hernia is more common in females when compared to males. This is a repeat telecast. So answer here is going to be your indirect inguinal hernia. Okay? Clear? Chalo. Now, the next question, patient has presented to OPD, hard neck swelling, a hard swelling was biopsied, amyloid deposits were found. What is the cell of origin? If the question structure is same and they're talking about looking at the options, they look like your thyroid cancer. Presence of amyloid deposits indicates medullary cancer thyroid. Medullary cancer thyroid originates from parafollicular C cells. Rest, all the other variants of thyroid cancer are going to originate from the follicles. So the answer here is going to be C for Calcutta, that is the parafollicular C cells. Okay? It's a parafollicular C cells. Now, according to the AJCC, what is the class? AJCC is for your staging for malignancy. So it is telling you it's a breast cancer. There is an ulcerated lesion. Presence of ulcer is involvement of skin. If there is presence of ulcer, if there is presence of POD orange, either ways, this basically tells you that the skin is involved. Involvement of the skin is T4B. T4A is involvement of chest wall. T4B is involvement of the skin. T4C is involvement of both skin and the chest wall. T4D is inflammatory breast cancer. Can't get easier than this. No image was given. Chalo, agar ulcer diya hua tha, if it was given as an ulcer, then also it is the same. Skin, beta, agar skin retraction diya hai, again, look at the options. If the skin retraction is given, this indicates dimpling. And remember, dimpling do not alter. It does not alter. It does not alter the stage. So you have to tell me whether carefully it was given as skin retraction was given, ulceration was given, or if there was skin edema was given. Edema indicates PO, the orange. All those are important. Okay? Also, ulcer was given. If ulcer was given, settled, it is going to be skin involvement, that is T4B classification. Right? Moving on to the next question. Ulcer described, beta, end of discussion, T4B. Now, identify the mark structures when you look across here. So, this is an X-ray which is on a PA view. Okay? So, in a PA view, that is the prominent ribs are your posterior ribs. But when you look at this shadow, beautifully, if I mark it down, so you see this is a shadow that is present. You see, there's this shadow that is present. These are your anterior ribs. You see all these shadows that are present. These are your anterior ribs wala shadow. And the mark points also tells you. So if you see, these are your anterior ribs, right? If I just remove all these annotations, no, now you will be able to see better. Now see, look at these points. You see beautiful. You can see this whole image. Right, you can see beautiful anterior ribs, right? So this is your anterior ribs. Okay? Sure. See, cartilage cannot be seen, artery cannot be seen, posterior ribs are visible. It is the shadowed line are your anterior ribs. The better ones, you can see it here. Right, these are your anterior ribs. Okay? Achha, ribs are more, see, and mark position was horizontal, sir. So if the mark position was horizontal, then it is going to be a posterior rib. Vivek, I didn't get here. You're showing wrong image, sir. Achha. Better than image, whatever we collected from the students is this. Can you send me a right image? So again, see, all these are arbitrary questions we have got in the first-hand review of the students. So whatever image they said they found it, this is what has been. See, I did not give posterior ribos mark. ठीक है. I'll reconfirm beta. This is on the first hand. If you see it's more horizontal marking, more prominent is going to be posterior ribs. If it is more arched out, it is going to be anterior ribs. Okay? Sure. Now, what type of kidney stone is given? Now you can see it is the urinary crystals of coffin lid. Now the coffin lid, where do you see coffin lid? The coffin lid is seen in your phosphate stones or the triple stones, right? So calcium oxalate, when you talk about in the calcium oxalate, either you would see an envelope shaped. If it is a calcium oxalate monohydrate, then you will see presence of dumbbell shape. Struvite stones, phosphate stones, all these will have your coffin lid. They will have a coffin lid presentation, and the coffin lid presentation is here. 16 stones will going to be hexagon. Monohydrate will have dumbbell. That is calcium oxalate. Monohydrate will have dumbbell. So answer here is going to be your struvite stones. It's going to be struvite stones. Okay? Now, what will not be done as a primary survey in trauma? Now, what is the essence of primary survey? It is to rule out immediate life-threatening injuries and manage accordingly. So endotracheal tube will be done. The new addition is chest X-ray. NCCT is not done. ICD will be done. Okay? Clear? But these are coffin. देखो envelope जो होगा, envelope crystals जो होगा, they will look something like this. ठीक है? Whereas coffin lid will be something like this. So this is the orientation of the coffin lid. It looks like more like a coffin lid. अगर यही image था तो ये coffin lid का है. ठीक है? चलो. Okay. For here, the answer is going to be NCCT head. What is not done a primary survey. Now, which of the following is an extra esophageal manifestation? See, I need this question properly because when you talk about it, the common extra esophageal manifestation are laryngitis and asthma. Pulmonary fibrosis is also seen, but it is not a common component. So I need the fourth option. Okay? I need the fourth option. Because see, when you talk about, I've given an image from the Bailey, it says clearly that the patient will have chronic cough, it will have laryngitis, asthma, and dental erosion as common. But the other ones which includes are sinusitis, pulmonary fibrosis, pharyngitis, and recurrent otitis media. Okay? Clear? Option 4. So if it is from any of this, either it is because of chronic, see, it will have a dry cough. It's an irritative cough. It will not be a productive cough. So if the phlegmon is coming, it is going to be productive. Then that is not the answer, beta. Which of the following is an extra, which of the following is not likha hoga, then it is going to be phlegm. All these three are the manifestations. All these three are seen. What is not seen is productive cough. You will see dry cough will be seen, not the productive cough. It's an irritation. Okay? Sure. But agar not mein hai, so all these three are present. The option D. What is option D? That is important. Agar option D mein productive cough diya tha, ya phlegmon diya tha, ya fir increased productive phlegm, then the answer is going to be that. So, which of the following identify the condition shown in the image? Remember, when you talk about pneumoperitoneum, there is air under diaphragm. It is not. Diaphragmatic rupture will have bowel loops, but here you can see it's a completely consolidated area. It looks like hemothorax because pulmonary contusion will have a patchy area. So answer here is C for Calcutta. So here, this is the image for the pneumoperitoneum. This is the image for pneumoperitoneum. You can see free gas under diaphragm. This is the image for pulmonary contusion. This is for pulmonary contusion. You can see patchy area. and this is the diaphragmatic hernia or the diaphragmatic rupture. Somebody saying what? So, which of the following scenes after stab injury in supine X-ray? But a stab injury hoga, to you will have presence of chemoperitoneum. Okay, agar if this is not the right image or right question, please add on to it. I'll put a question mark. Okay? Sure. Which of the following is not a cause of bilateral pedal edema? Remember, venous insufficiencies are usually unilateral. Heart failure, bilateral, renal failure, bilateral, renal cause will be bilateral. So answer here is going to be A for Ahmedabad. Hemothorax was the option. More likely it is the hemothorax is the answer. Now, a female, this is an interesting question, diagnosed with breast cancer, known now taking a test for estrogen receptor. Estrogen receptor is a predictive marker. It tells you whether the tumor, if the estrogen receptor or receptor status is positive, then I'll give an HRT, that is hormonal therapy. If it is negative, I'll give a chemotherapy. So it's a predictive for treatment process. It does not determine the prognosis. Okay? Chalo. This I need for you to complete the question. Only ER beta, yeah, only estrogen receptor is going to be a predictive marker. A 20-year-old male presented to ER with severe vomiting. Friend informed about his chronic alcoholism and binge drinking for last 5 days. Ultrasound shows distended portal vein and liver is hyperechoic. Injection of pantoprazole is given. What is the next step in the management? So can you give me the options here? So we'll see the other options. I need the options for this question. If there is any options, let me know. Because if it's the context, is it the vomiters with blood? If it is that, then we'll take it as portal hypertension. In portal hypertension, the next one will be your fluid management. Okay. If it is only vomiting and there is no distress, then I would do an upper GI endoscopy. Okay. So based upon the options, we can determine the question. Can you help me with the last question here? Which of the following is not a cause of hepatic cancer? Options. Okay, if there's no blood vomiting, it's only vomiting, then you should go ahead with upper GI endoscopy to look for varices. Not a cause for hepatic cancer. Again, I need options here. If you can complete the options, then we'll talk about it. Hepatitis B is definitely a cause for hepatic cancer. Already covered? Okay, guys. Take it. Fine. Or not there. Okay, cool. I think it is about cholangiocarcinoma, right? So these were all the questions, guys. Nothing new. So again, it's like old wine in a new bottle. The questions are a bit shaped up. Few questions were not correctly framed. I know it's a, it's a very immediate recall. So we'll try to give you a more authentic question and an answer and an image. But now mota topics were this. Okay. So with that, thank you guys. I will call upon Ranjit sir again and switch back.
Thank you. So I hope all the surgery questions were discussed, and like Dr. Sandeep said, that we will be coming up with a very elaborate recall very soon. So next we have Dr. Mamta with us.
Hi everyone, good evening.
Dr. Mamta, your video. The OBS virtual camera, I think.
Hi everyone, good evening. I hope I'm audible and visible.
Yeah, Mata.
Hi, everyone. Good evening. I hope I'm audible and visible now. Good evening, everyone. So micro today was pretty easy and very much doable, and a lot of questions have been asked from micro. So let's start. The very first question was on match the following. The viruses in the left column were supposed to be matched with their genome. So rotavirus, SARS coronavirus, parvovirus, HPV. So this is very, very simple. You need not mug this up or ratify. You all know all the DNA viruses have got double-stranded DNA as genomes. So the DNA virus amongst all these viruses we have is HPV and parvovirus. So HPV has got double-stranded DNA, and parvovirus, which is the smallest DNA virus. Remember, this guy, parvovirus, is so small that God decided that it is not going to have two strands of DNA. So this is going to have single-stranded DNA. So this is done. Option C is done. D is done. Now, rotavirus and SARS coronaviruses are what? They are both RNA viruses. And as a general rule, all the RNA viruses have got what? Single-stranded RNA as a genome. So SARS coronavirus has got single-stranded RNA as genome. And what about rotavirus? Rotavirus belongs to the Reoviridae family, and this family of viruses have got double-stranded RNA as their genome. Is this clear? So this was pretty simple. You just have to apply your basics. They have asked this this basic concept in the form of match the following. Okay, next question. Parvovirus does not contain. I just said parvovirus, specifically parvovirus B19 is the smallest virus overall, and it is so very small that it has got a single-stranded DNA. Okay. Now, what does it not cause? Transient aplastic crisis, yet it is yes, it does occur in those individuals who unfortunately have got hemolytic anemias like sickle cell anemia or anything else. Remember, in general, parvovirus B19 infection is going to be self-limiting. It is going to infect what? It is going to infect erythroblasts. बट इन पीपल विद हेमोलिटिक अनीमियाज ऑलरेडी आरबीसीज मर रहे हैं, तो ऊपर से अगर एक ऐसा वायरस इन्फेक्ट कर देगा जो आरबीसीज को इन्फेक्ट करता है, then these individuals will end up in a transient aplastic crisis. Why it is transient? Because as I just said, the viral infection in itself is what? Itself is self-limiting. So it is going to be transient. So this is not the answer because this is caused by parvovirus. And petechial rash with fever is wrong. This virus causes a macular rash, a macular red, that is erythematous rash. So this is wrong. Hydrops fetalis, yes, it is caused in case a pregnant lady gets infected with this virus in the second trimester. Okay? In the first trimester, if infection occurs, it leads to fetal death. That is why parvovirus is not a common cause of congenital malformations. If infection occurs in third trimester, then it is uneventful and nothing happens to the baby. Pure red cell aplasia definitely is an entity caused by this virus, and it specifically occurs in individuals who are immunocompromised, like for instance, HIV infected individuals. So what is not caused by this virus? The answer is option B, that is petechial rash with fever. Next question. Parthenogenesis is seen in. अब देखो ये question AIMS वालों का favorite है. A few years back, AIMS people had a favoritism towards parasitology, and they repeatedly asked questions on Strongyloids stercoralis. In I think 2018 or 19, a video-based question also was asked on this fellow itself. So I'm not at all surprised to see this question once again in INICET. So parthenogenesis is seen in not Necator or Enterobius. It is seen in Strongyloids. Last option was not recalled. We'll be very grateful if anyone is able to recall the fourth option. So Strongyloids stercoralis shows parthenogenesis. It's a helminth. Parthenogenesis means what? The female can produce the offspring without fertilization by the male. So pretty independent female, you see. So the production of offspring is independent of the help of the male. And also this fellow Strongyloids is also unique because in the entire helminthology, it is the only worm which is ovoviviparous. Ovoviviparous. Acha, Trichuris tha. Thank you. Trichuris trichiura. ठीक है. ऑल राइट, सो एक चीज और याद कर लो, एंटेरोबियस एंड ट्राइचरस जो हैं दे आर लार्ज इंटेस्टाइनल वर्म्स। तो LET लेट से याद रख सकते हो, L से लार्ज इंटेस्टाइन, E से एंटेरोबियस, T से ट्राइचरस। नेकेटर अमेरिकानस हुकवर्म इट्स अ स्मॉल इंटेस्टाइनल हेलमिंथ, ठीक है। Anyways, even if Necator americanus was not given, strongyloids was given, that is the answer, because as I said, किसी और worm की ये uniqueness नहीं है। Next question. A child presents to the OPD with CNS symptoms. Multi-nucleated giant cells were revealed on lab investigations. Mother gave the history of genital ulcers. What's the likely cause? Again, a very easy question. There's a lady giving history of genital ulcers, and the child having CNS symptoms and MNGs seen goes in favor of HSV2. HSV2 is the most common cause of genital herpes. 95% cases of genital herpes are caused by HSV2 and 5% by HSV1. Because the general rule with HSV is that HSV1 causes infections above the waist, HSV2 causes below the waist. But in individuals engaging in oro-anal intercourse, the reverse can also happen. That is why 5% of the cases of genital herpes can be attributed to HSV1 also. And remember, neonatal herpes is how does it occur? It occurs when the baby, the baby passes through the infected birth canal and not transplacentally. This is very, very important to be remembered. So passage through the infected birth canal leads to acquisition of infection of this virus by the baby, which leads to neonatal herpes, and the signs and symptoms could be, could be very, very variable. There could be asymptomatic kids, or there could be signs and symptoms confined to just skin or mouth, or there could be serious complication involving central nervous system. ठीक है, हाँ देखो easy है ये, पहले भी पूछा जा चुका है. So answer is HSV2. The other option which was recalled was varicella zoster, तो बैठ नहीं रहा fit. C and D, if anyone can recall, will be very thankful. Now, next question. Which of the following is caused by Streptococcus 𝐴 Streptococcus 𝐴 क्या है? This is nothing but GBS group B Streptococcus. मैं हमेशा सोचती हूँ कि ये जो ऑर्गेनिज्म है Streptococcus 𝐴 काफी बोल्ड है, इसके नाम में ही B है, B से बोल्ड enough to break down RBC. So ये बीटा हीमोलाइटिक है, बीटा हीमोलाइटिक. बी से और क्या याद करोगे? बोवाइन मेस्टाइटिस ये कॉज करता है. इसी तरह से ये फर्स्ट एंड फॉरमोस्ट डिस्कवर किया गया था, ठीक है. एंड इट हैज गॉट अ ब्यूटिफुल प्रिटी कैप्सूल ऑल्सो, ये कैप्सुलेटेड है. एंड इट इज बोल्ड एनफ टू रेजिस्ट व्हाट? बोल्ड एनफ टू रेजिस्ट बैसीट्रासिन. ये अनदर MCQ है आप लोगों के लिए कि ग्रुप ए स्ट्रेप्टोकोकस या स्ट्रेप बायोजीन्स जो होता है दैट इज सेंसिटिव टू बैसीट्रासिन, बाकी सारे ग्रुप्स क्या होते हैं? रेजिस्टेंट होते हैं. सो व्हाट इज कॉज्ड बाय दिस ऑर्गेनिज्म? नियोनेटल सेप्सिस यस, डेंटल कैरीज नो, इन्फेक्टिव एंडोकार्डाइटिस नो, फेरेंजाइटिस नो. दिस फेलो GBS is the most common cause of neonatal septicemia and neonatal meningitis in the West. GBS, ठीक है. अब डेंटल कैरीज की जहां तक बात है, डेंटल कैरीज का मोस्ट कॉमन कॉज क्या हो गए? हमारे विरिडन स्ट्रेप्टोकोकाई जो ओरल कमेंसल्स होते हैं, एंड ऑल्सो दीज आर द मोस्ट कॉमन cause of subacute bacterial endocarditis, ठीक है. तो उससे गड़बड़ मत करना. Yes, neonatal sepsis, Abhishek is the answer. Now next question, which of the following is not a polysaccharide vaccine? Again देखो बहुत easy है. polysaccharide vaccine आप खुद ही सोचो किसके लिए बनानी चाहिए, इसको भी रट्टा नहीं मारना. जिन organisms के पास polysaccharide capsule है as an important virulence factor, capsule we all know it's an important virulence factor क्योंकि it is antiphagocytic. Now Hib vaccine, which is against Haemophilus influenzae serotype B, which is the baddest. B for badass, B for bad, सबसे बकवास serotype, because this is the most dangerous one for us. Not just the most dangerous serotype for us, causing the most severe manifestations, it also is the most common serotype of Haemophilus influenzae infecting humans, ठीक है. So इसके पास एक कैप्सूल होता है पॉलीराइबोसिल राइबोटॉल फोस्फेट का कैप्सूल या PRP कैप्सूल, जो अपने आप में एक MCQ है. इसके लिए एक अच्छी वैक्सीन अवेलेबल है, एंड दैट इज द रीजन गाइज why Haemophilus influenzae serotype B was previously the most common cause of epiglottitis, but now इसकी पोजीशन किसने ले ली है? न्यूमोकोकस ने. न्यूमोकोकस now is the most common cause of epiglottitis. ये अपने आप में एक MCQ है. हेपेटाइटिस बी वैक्सीन, हेपेटाइटिस बी, अब देखो वायरस है तो वायरस के पास कैप्सूल तो होता नहीं है. कैप्सूल बैक्टीरिया में होता है, वायरसेस में एनवेलप होता है, वो भी सब में नहीं होता, सिर्फ एनवेलप वायरसेस में होता है. हेपेटाइटिस बी की वैक्सीन अवेलेबल है, बट इट इज अ सब यूनिट रिकॉम्बिनेंट वैक्सीन, ठीक है. तो ये है हमारा आंसर, बट डू सी दी अदर ऑप्शंस आल्सो. मेनिंगोकोकल वैक्सीन, न्यूमोकोकल वैक्सीन. मेनिंगोकोकस एंड न्यूमोकोकस बोथ हैव गॉट पॉलीसैकेराइड कैप्सूल्स एज देयर विलेंस फैक्टर. इनके लिए बहुत अच्छी खासी वैक्सीन अवेलेबल हैं. सो हमारा आंसर क्या होगा यहाँ पर? ऑप्शन बी. ठीक है, ऑप्शन बी. देन नेक्स्ट क्वेश्चन. Which of the following is true about the likely organism shown in the image? This image was recalled by the students. ठीक है, तो ये क्या देख रहे हो आप? You can, this is a negative stain वाली image and most likely it points towards cryptococcus. हालांकि हम ऐसे देख के कमेंट नहीं कर सकते हैं कि ऑर्गेनिज्म का ऑर्गेनिज्म का नाम क्या है. फर्दर इन्वेस्टिगेशंस दी जाती हैं, बट गोइंग बाय द ऑप्शंस गिवन इन दिस क्वेश्चन, इट इज पॉइंटिंग टुवर्ड्स क्रिप्टोकोकस ओनली. ठीक है, सो मोस्ट कॉमनली इन्फेक्ट्स लंग्स, ये बिल्कुल सही बात है. क्रिप्टोकोकस नियोफॉर्मन्स का इन्फेक्शन कैसे होता है? इनहेलेशन ऑफ द बेसिडियोस्पोर्स एंड इवन द यीस्ट फॉर्म, दोनों ही हैरिसन्स टेक्स्ट बुक ऑफ इन्फेक्शियस डिजीज में डिस्क्राइब्ड है एज द इन्फेक्शियस फॉर्म. तो इसको याद रखना. तो मोस्ट कॉमनली इन्फेक्ट्स लंग्स. जिनकी इम्यूनिटी अच्छी होगी वो लोग एसिम्प्टोमेटिक होंगे. जिनकी इम्यूनिटी थोड़ी डाउन हो जाएगी उनको फिर लंग के फीचर्स होंगे. एंड इम्यूनिटी बहुत डाउन होगी तो सीएनएस भी इन्वेड होगा. Pseudo hyphae are seen on gram stain, गलत. Remember Cryptococcus neoformans जो है that is a true yeast. True yeast अगर ये है तो ये झूठी बात नहीं करेगा, मतलब ये कोई दिखावा नहीं करेगा. Pseudo means false या झूठ, तो pseudo hyphae नहीं शो करेगा. Pseudo hyphae are a characteristic of Candida which is known as yeast-like fungus. Cryptococcus neoformans is a true yeast. It shows just budding. ठीक है, budding. Humans are the only host. ये भी गलत है क्योंकि cats and a few other animals also have been shown to be infected by this organism. Now, last option, severe infection is seen if CD4 count is below 900. ये भी गलत है. Severe infection in HIV कब होगा? जब CD4 count falls below 200. तो हमारा आंसर क्या है यहाँ पे? ऑप्शन ए. ठीक है, नाउ नेक्स्ट क्वेश्चन. रीजनिंग एंड असर्शन पे क्वेश्चन आया था. अब ये बहुत ही बढ़िया क्वेश्चन है. फैल्सिपारम मलेरिया के शाइजोन्स एंड ट्रोफोजोइड्स आर नॉट सीन ऑन पेरिफेरल ब्लड. तो क्वेश्चन बेसिकली इसी पर था. रीजनिंग एंड असर्शन की स्टेटमेंट आई कुड नॉट गैदर. तो जो भी हो, अगर आपके कॉन्सेप्ट्स क्लियर है, आपका फंडा सॉलिड है, तो आप ऐसे क्वेश्चन आंसर कर सकते हो. ब्रीफली आई विल जस्ट टेल यू. फैल्सिपारम मलेरिया के केस में क्या होता है? हमारे जो शाइजोन्स हैं एंड द लेट ट्रोफोजोइड्स ये कहाँ पे बनते हैं? दे आर फॉर्म्ड इन द कैपिलरीज ऑफ डीप विसरल ऑर्गन्स लाइक ब्रेन एंड किडनी. और फैल्सिपारम के केस में खास बात क्या होती है? जो आरबीसी होता है ना, द इन्फेक्टेड आरबीसी, मान लो ये आरबीसी है एंड ये अंदर गोल्डन कलर से मैंने पैरासाइट बना दिया. दिस इज एन ओवर स्कीमेटिक डायग्राम गाइस. तो आरबीसी शोज प्रोट्रूजन्स जिनको बोलते हैं नॉब्स. इसको बोलेंगे हम नॉब. And this knob expresses a protein, namely Plasmodium falciparum EMP1, erythrocyte membrane protein 1. ठीक है, तो इसका नाम हो गया प्लास्मोडियम फैल्सिपैरम इराइथ्रोसाइट मेम्ब्रेन प्रोटीन 1. अब इसकी लाइकिंग या अट्रैक्शन होती है टुवर्ड्स सर्टेन रिसेप्टर्स प्रेजेंट ऑन दी एंडोथेलियल सेल्स ऑफ द ब्लड वेसल्स. सो क्या होगा? ये वाले शाइजोन्स एंड लेट ट्रोफोजोइड्स जो ऐसे प्रोट्रूजन्स प्रोजेक्ट करेंगे जिसके ऊपर आप मान लो कि ये फेविकॉल या फेविस्टिक काइंड ऑफ अ सब्सटेंस है जिसका नाम हमने दे दिया प्लास्मोडियम फैल्सिपैरम इराइथ्रोसाइट मेम्ब्रेन प्रोटीन 1. This green colored protein will attach to receptors present on the endothelial cells in the capillaries of brain and kidney. तो ये peripheral blood में आएंगे ही नहीं, तो फिर हमें peripheral blood smear पे कहाँ से देखेंगे? So the reason why these are not seen is sequestration of parasites. यहाँ पे एक इंटरेस्टिंग बात क्या है? सीक्वेस्ट्रेशन क्यों हो रही है? सीक्वेस्ट्रेशन हो रही है बिकॉज ऑफ साइटो एडहेरेंस. यहाँ पे मैं एक और एमसीक्यू बता देती हूँ जो INICET वाले ही पूछते हैं बार बार. अगर मान लो एक ऐसा एमसीक्यू आता जिसमें आपसे यही क्वेश्चन पूछते कि फैल्सिपारम के शाइजोन्स और ट्रोफोजोइड्स क्यों नहीं दिखते, और मान लो एक ऑप्शन होता साइटो एडहेरेंस, दूसरा सीक्वेस्ट्रेशन, तो ज्यादा बेटर ऑप्शन क्या है? देखो आंसर दोनों ही हो सकते हैं, लेकिन जस्ट लाइक लाइफ में भी कई बार हमें मान लो दो ऑप्शंस दिख रहे हैं, दोनों ही अच्छे हैं, और आपको फिर एक डिफिकल्टी फेस करनी पड़ती है कि इन दोनों में से हम कौन सा चूज करें, तो आप तब थोड़े कंफ्यूज रहते हो. तो यहाँ पे आप कैसे डिसीजन लोगे, कैसे डिसाइड करोगे, कंफ्यूजन क्लियर कैसे करोगे? ऐसे करोगे, आप ये सोचोगे कि फाइनल इवेंट क्या है? फाइनल इवेंट है सीक्वेस्ट्रेशन. मूलतः कारण क्या है? मेन रीजन क्या है? मेन रीजन है साइटो एडहेरेंस. साइटो एडहेरेंस अगर नहीं होता तो सीक्वेस्ट्रेशन कहां से होती? तो उस केस में आप साइटो एडहेरेंस मार्क करोगे. अच्छा, अगर सीक्वेस्ट्रेशन दे रखा होता है तो फिर आप वही मार्क करोगे, अगर साइटो एडहेरेंस आज के एग्जाम में नहीं था. Is this clear, everyone? अच्छा, अगर both are mentioned, then cytoadherence you will have to mark. We'll be very grateful if any of you could please recall the exact language of the reason and assertion वाली statements. You can DM me on Instagram अगर अभी याद नहीं आ रहा, ठीक है, mj.micro पे आप लोग मुझे DM करके बता सकते हो. फिर जब हम full recall करेंगे, detailed recall, I will polish this question. Yes, next question, speciation of malarial parasite is done by. ये भी बहुत आसान है. Thick smear examination, thin smear, acridin. एक्रिडिन ऑरेंज स्टेन. तो आंसर क्या है? थिन स्मीयर. गोल्ड स्टैंडर्ड फॉर मलेरिया का डायग्नोसिस इज पेरिफेरल ब्लड स्मीयर. थिक स्मीयर होता है, थिन स्मीयर होता है. थिन स्मीयर स्पीसिएशन के लिए होता है, इसमें ज्यादा कुछ सोचने वाली बात ही नहीं है. एक्रिडिन ऑरेंज जो क्वांटिटेटिव बफी कोड में हम करते हैं, दैट इज हाईली सेंसिटिव, बट स्पीशिएट वो नहीं करता है. अगर दोनों मेंशन है रीजनिंग में तो और भी अच्छा है, फिर तो कोई कंफ्यूजन ही नहीं है. ठीक है, सो दैट्स अबाउट दिस क्वेश्चन. नेक्स्ट क्वेश्चन, व्हाट इज द लाइकली एसिड फास्ट ऑर्गेनिज्म शोन? Now I was told that size was mentioned, in microns of the structure shown in the image. Probably image closer to this, similar to this, must have been given. अगर size इतना दे रखा है 25 से 30 microns, 25 to 30 microns किस coccidian parasite का होगा? आइसोस्पोरा का होगा, आइसोस्पोरा बेलाई. ठीक है, एंड इट इज ओवल इन शेप. इसका साइज सबसे बड़ा होता है. क्रिप्टोस्पोरिडियम, देखो क्रिप्टो हो गया, बीच में साइक्लो लिखो और राइट में आइसो. ये अल्फाबेटिकल ऑर्डर में मैंने लिख दिए. अब ये तीनों के तीनों इंपॉर्टेंट कॉक्सीडियन पैरासाइट्स हैं जो रिफ्रैक्टरी डायरिया कॉज करते हैं HIV इन्फेक्टेड इंडिविजुअल्स में. जिनकी इम्यूनिटी अच्छी है उनमें अगर ये ऑर्गेनिजम्स इन्फेक्शन करेंगे तो डायरिया सेल्फ लिमिटिंग होगा, उसमें टेंशन वाली बात नहीं है. टेंशन वाली बात होती है HIV वालों में. क्रिप्टोकोकस एंड क्रिप्टोस्पोरिडियम सॉरी एंड साइक्लोस्पोरा के केस में द बूसेस आर स्फेरिकल, आइसोस्पोरा में ओवल होता है. एंड जैसे मैंने साइज बड़ा सा बना दिया तो लेफ्ट से राइट आप याद कर लो, 4 to 6 माइक्रॉन्स, 8 to 10 माइक्रॉन्स एंड 25 to 36 माइक्रॉन्स. ठीक है, लेफ्ट से राइट 4, 6, 8, 10, ये तो इजी है याद करना. फिर बिल्कुल एक्सट्रीम राइट में 25 से 36. So this is a very easy question. Next question, infection by catalase positive organisms is seen in chronic granulomatous disease, hyper IgE syndrome, SCID. No points for guessing. It is a CGD or chronic granulomatous disease. जिसमें क्या प्रॉब्लम होती है? There is defective NADPH. There is the gene which synthesize the NADPH oxidase enzyme that is defective. उसकी वजह से क्या होगा? Free radicals नहीं बन पाएंगे. All right. So infection by catalase positive organisms like Staphylococcus, Enterobacteriaceae are common. ठीक है, क्योंकि जो थोड़े बहुत फ्री रेडिकल्स भी बन रहे होंगे, they also will be broken down mercilessly by the catalase produced by these organisms. ठीक है, तो बहुत easy है. ठीक है. Now next question. A female presented with a burning micturition and yellowish discharge which on gram stain revealed gram negative diplococci. What can be the likely cause? The only option which was recalled by the students was gonococcus. Others were not recalled. ये likely है because यही answer है. पूरी मेडिकल बैक्टीरियोलॉजी में द सिग्निफिकेंट ग्राम नेगेटिव डिप्लोकोका जो आपको पढ़ने होते हैं, दे आर नथिंग बट मेनिंगोकोकस एंड गोनोकोकस. मेनिंगो एंड गोनो, एंड गोइंग बाय द हिस्ट्री इट गोज इन फेवर ऑफ निसीरा गोनोरिये और gonococcus. Vinita, cyst isospora is the new name of isospora bellae. Cystoisospora is the new name of isospora bellae. ठीक है, so answer is this gonococcus, not obviously meningococcus. Now gonococcus के केस में you all know जो मेल्स होते हैं they are symptomatic and जो फीमेल्स होती हैं they are carriers and act as reservoirs of disease. ठीक है, ऑपोजिट चीज किस में होती है? ऑपोजिट चीज होती है ट्राइकोमोनियासिस में. तो गोनोकोकल इन्फेक्शन और क्लैमाइडिया ट्राइकोमैटिस इन्फेक्शंस में मेल सिम्प्टोमेटिक होते हैं, फीमेल्स कैरियर्स. ऑपोजिट होगी ट्राइकोमोनियासिस में, जहां पे फीमेल्स आर यूजुअली सिम्प्टोमेटिक एंड मेल्स आर एसिम्प्टोमेटिक. नाउ नेक्स्ट क्वेश्चन, अगेन एक रीजनिंग assertion पे क्वेश्चन आया. On endocarditis apparently and bacteremia caused by Corynebacterium diphtheriae. Now this is the only thing I could get today. If anyone is able to recall the entire question, proper statement, will be very thankful. तो देखो एंडोकार्डाइटिस क्या कॉज कर सकता है? कॉर्निबैक्टीरियम डिप्थीरिया बिल्कुल कर सकता है. इट इज अ वेरी रेयर कॉम्प्लिकेशन ऑफ कॉर्निबैक्टीरियम डिप्थीरिया इन्फेक्शन एंड इट इज यूजुअली सीन इन इंट्रावीनस drug abusers, those who have got damaged heart valves, ठीक है, and those who have got cirrhosis. And moreover, these are also the risk factors, not just for endocarditis, but also for septic arthritis. अच्छा, बैक्टीरिया नहीं होता है डिप्थीरिया में. रिमेंबर, डिप्थीरिया इज अ सिस्टमिक डिजीज. डिप्थीरिया इज अ टॉक्सीमिया, इट इज नॉट बैक्टीरिया. अगर आप ब्लड कल्चर कराओगे तो वो स्टेराइल आएगा. Okay, some people are saying myocarditis was mentioned, which तो पता ही है हमें कि myocarditis is an important, complication of diphtheria. Diphtheria toxin has got affinity for, remember, MA and MAN, myocardium, adrenal and nerve endings. तो अगर myocarditis था तो ये तो अच्छी बात है because वो common है. बैक्टीरिया नहीं होता है, गेमिंग विद गौतम बैक्टीरिया नहीं होता है, टॉक्सीमिया होता है. What was the assertion given? And assertion given was myocarditis happens. अच्छा, अगर रीजन में बैक्टीरिया मेंशन किया तो रीजन तो अपने आप में ही गलत स्टेटमेंट है, जैसे मैंने बताया कि बैक्टीरिया होता ही नहीं है. ठीक है. और अगर एसर्शन ये दे रखी थी कि कॉर्नीबैक्टीरियम डिप्थीरिया कॉजेज एंडोकार्डाइटिस या मायोकार्डाइटिस, दोनों में से कुछ भी लिखा हुआ था वो करेक्ट स्टेटमेंट है. मायोकार्डाइटिस इज वे मोर कॉमन, एम से मोर कॉमन याद कर लो, एम से मायोकार्डाइटिस, और एंडोकार्डाइटिस बहुत रेयर है लेकिन इम्पॉसिबल नहीं है. ठीक है, चलो ये क्वेश्चन भी सॉर्टेड है. मोस्ट ऑफ यू आर सेइंग मायोकार्डाइटिस वाज मेंशन्ड. चलो नेक्स्ट क्वेश्चन, इंटरेस्टिंग वन. विच इन्फेक्शन कैन बी ट्रांसमिटेड बाय ऑल कंपोनेंट्स ऑफ ब्लड? टॉक्सोप्लाज्मोसिस, सिफिलिस, मलेरिया, फाइलेरियासिस. अब देखो, टॉक्सोप्लाज्मोसिस तो नहीं होता है, ना ही फाइलेरियासिस होता है. एक चीज में मेंशन कर दूं, फाइलेरियासिस के केस में जो इन्फेक्टिव फॉर्म होता है वो क्या होता है? द L3 फॉर्म ऑफ द फाइलेरी फॉर्म लार्वा, L3 स्टेज, है ना. तो अब फाइलेरियासिस के पेशेंट में ब्लड में कौन होते हैं? माइक्रोफाइलेरिया. माइक्रोफाइलेरिया आर नॉट द इन्फेक्टिव फॉर्म्स. ठीक है, इन्फेक्शन तो मच्छर के काटने से होता है. टॉक्सोप्लाज्मोसिस के केस में भी देयर आर सो मेनी इन्फेक्टिव फॉर्म्स, लाइक जितने भी मॉर्फोलॉजिकल फॉर्म्स हैं इस पैरासाइट के, सारे ह्यूमन बींग्स को इन्फेक्शन कर सकते हैं. दैट इज द यूनिकनेस ऑफ टॉक्सोप्लाज्मा गोंडाई. ब्लड ट्रांसफ्यूजन से ये नहीं देखा गया है कि ट्रांसमिट होता है. अब आते हैं सिफिलिस और मलेरिया पे, जो कि थोड़े से कंफ्यूजिंग है. लेकिन अब देखो, सिफिलिस मलेरिया की मैंने आज काफी टेक्स्ट देखे, जितना भी आज लिमिटेड टाइम था, बट स्टिल आई वाज एबल टू सी एटलीस्ट 3 to 4 आर्टिकल्स. अलग अलग आर्टिकल्स में ये लिखा है कि बोथ मलेरिया एंड सिफिलिस कैन बी ट्रांसमिटेड बाय वेरियस कंपोनेंट्स ऑफ द ब्लड. लेकिन अगर हमें एक सिंगल बेस्ट आंसर हमें चूज करना होगा तो हम मार्क करेंगे मलेरिया. कारण सिफिलिस का जो ऑर्गेनिज्म है, ट्रिपोनिमा पैलिडम, जो बहुत ही डेलिकेट है, इट्स वेरी डेलिकेट और फ्रेजाइल ऑर्गेनिज्म. तो जब जो फ्रेश फ्रोजन प्लाज्मा है, मान लो उसका एग्जाम्पल लेते हैं, तो वो तो -30 पे मेंटेन करते हैं, तो उसमें तो ऑर्गेनिज्म सर्वाइव ही नहीं करेगा, मर जाएगा. ठीक है, इट्स एन एक्सट्रीमली डेलिकेट ऑर्गेनिज्म. तो इवन इफ थ्योरेटिकली अगर हम ये बोल दें कि चलो ये बाकी सारे कंपोनेंट्स में प्रेजेंट होता है, तो जब सर्वाइव ही नहीं करेगा इतने लो टेम्परेचर पे, तो ये ट्रांसमिट भी नहीं हो पाएगा. लेकिन मलेरिया के केस में इट इज सीन दैट इन्फेक्शन ट्रांसमिशन मलेरिया इज अ नोन एंटिटी, एंड द इन्फेक्टिव द मॉर्फोलॉजिकल फॉर्म्स ऑफ प्लाज्मोडियम व्हिच कैन कॉज ट्रांसमिशन मलेरिया, शाइजोन्स, ट्रोफोजोइड्स एंड इवन मीरोजोइड्स. एक बात और मैं यहाँ पे क्लियर कर दूं कि मीरोजोइड्स, देखो, एम से मीरोजोइड्स, एम से मेटरनल टू चाइल्ड ट्रांसमिशन. ठीक है, तो ट्रांसप्लेसेंटल ट्रांसमिशन भी होता है मलेरिया के केस में, अगर मदर टू चाइल्ड, एम से मेटरनल, एम से मीरोजोइड्स. और अगर हम ट्रांसफ्यूजन मलेरिया की बात करें ना, ट्रांसफ्यूजन में टी से ट्रांसफ्यूजन याद करो, टी से ट्रोफोजोइड्स. जहां तक मुझे पता चला है, आज क्वेश्चन की लैंग्वेज यही थी कि विच इन्फेक्शन कैन बी ट्रांसमिटेड बाय ऑल कंपोनेंट्स. तो एक बड़ी ही जेनेरिक सी स्टेटमेंट हो गई, तो इसमें हम मार्क करेंगे. ठीक है गाइज, आई एम गोइंग बाय फैक्ट्स. तो दिस इज द रीजन. अगर और मुझे, जैसे मैंने बोला, द रीजन इज कि सिफिलिस हम क्यों मार्क नहीं करेंगे अकॉर्डिंग टू मी, बिकॉज ये बहुत डेलिकेट है, फ्रेजाइल है, और ये मर जाता है, सर्वाइव ही नहीं करेगा. आप फ्रेश फ्रोजन प्लाज्मा को ही लो, वो भी तो एक ब्लड का कॉम्पोनेंट हुआ ना. तो जब ये उस पर मर रहा है तो कैसे हो रहा है फिर उसमें ट्रांसमिट? नहीं हो रहा है. ठीक है, गेमिंग विद गौतम, आई वुड से पॉपुलर ओपिनियन इज नॉट ऑलवेज राइट, गो विद द राइट थिंग. ठीक है, अगर आप अपनी आंसर को रीजनिंग से बैकअप कर रहे हो तो फिर वही आंसर होगा. ठीक है, सो ये थोड़े से स्क्रीनशॉट्स मैंने लगा दिए थे यहाँ पे. दीज विल बी एक्सेसिबल टू यू इन द PDF. चलो नेक्स्ट क्वेश्चन. नाउ आज के पूरे सेशन में ये सबसे पोरली रिकॉर्ड क्वेश्चन है. आई वाज टोल्ड कि कुछ मैच द फॉलोइंग पे आया था, बट फॉलोइंग में क्या था वही समझ में नहीं आ रहा था. एक कॉलम में आई वाज टोल्ड कि ऐसे कुछ ऑर्गेनिजम्स लिख रखे थे, बोरेलिया, CMV. ठीक है, और दूसरे कॉलम में ग्रानुलोमा, नो रिएक्शन, इस प्रकार की कोई चीज थी. अब इसमें मैं क्या ही कमेंट करूं, लेकिन मैंने PDF में जरूर ये डाला है, क्योंकि फिंगर्स क्रॉस्ड, अगर मुझे अगले कुछ दिनों में कोई भी स्टूडेंट ये रिकॉल करके दे देता है तो फिर मैं इसको आंसर को डिकोड कर दूंगी. ठीक है, एनी ऑफ यू कैन रिकॉल राइट नाउ कुछ भी इस क्वेश्चन के बारे में, क्या था ये, क्या चीज थी? क्वेश्चन में कुछ नहीं लिख रखा था, बस मैच द फॉलोइंग और ये दोनों कॉलम्स दे रखे हैं। इम्यूनो कॉम्प्रोमाइज तो इम्यून रिस्पॉन्स कुछ माउंट ही नहीं कर पाएंगे, तो अगर उस कंटेक्स्ट में हम कह रहे हैं नो रिएक्शन, तो नो रिएक्शन से क्या मतलब है? इम्यून रिस्पॉन्स। चलो इसको अभी हम क्वेश्चन मार्क डाल देते हैं, बट आई एम श्योर ये कोई डिफिकल्ट क्वेश्चन नहीं होगा। उन्होंने बोरेलिया सीएमवी ये सब पूछा है, तो ये सब हम रूटीन ऑर्गेनिज्म से हम पढ़ते हैं एग्जाम के लिए, तो कोई मुश्किल क्वेश्चन नहीं होना चाहिए, बशर्ते ये ऑप्शंस अगर आप लोग रिकॉल कर दो। चलो आगे बढ़ते हैं फिर। डू नॉट फॉरगेट मी टू डीएम द करेक्ट ऑप्शंस ऑन माय इंस्टा हैंडल प्लीज, विल बी वेरी वेरी थैंकफुल। आगे बढ़ते हैं। चलो अगेन आ गया रीजनिंग सेशन। चलो ये एक ऐसा क्वेश्चन है रीजनिंग सेशन का जो बाय गॉड्स ग्रेस कहीं से रिकॉल हुआ है आज। एसर्शन ये था, आफ्टर कलेक्टिंग स्पूटम इन अ टीबी पेशेंट N-acetylcysteine and NaOH were added। ये क्या कर रहे हैं? ऐसा करते हैं क्या? बिल्कुल करते हैं। दिस इज अ concentration technique which the sputum specimen is subjected to so as to increase the yield of the organisms। ठीक है, रीजन क्या दे रखा है? N-acetylcysteine kills commensals, NaOH makes secretions thin। आप मुझे बताओ ये रीजन सही है गलत है? कितने लोग कह रहे हैं रीजन सही है? रीजन गलत है। असर्शन राइट है, रीजन गलत है। देखो N-acetylcysteine जो है ना, N-acetylcysteine ये उल्टा दे रखा है। N-acetylcysteine जो करेगा दैट लिक्विफाइज द स्पूटम, ठीक है, लेकिन NaOH है वो उसको मारेगा, इट विल किल द कमेंसल्स। तो उल्टा दे रखा है रीजन में कि N-acetylcysteine किल करेगा कमेंसल, तो ये गलत है। ठीक है, तो इसमें तो कोई दिक्कत वाली बात ही नहीं है। ठीक है, इसमें कोई कंट्रोवर्सी नहीं है। ठीक है, assertion right, reason wrong। next question, most accurate investigation done after 5 days of suspected dengue fever। ये शायद पहले भी आ चुका है, नीट पीजी में भी कितनी बार आ चुका है। एंड माइंड यू सारे के सारे टॉपिक्स जो है ना, दे आर ओवरलैपिंग टॉपिक्स अमंगस्ट नीट पीजी, INICET एंड इवन FMG ऑल्सो। ठीक है, तो कोई भी आप एग्जाम प्रिपेयर कर रहे हो तो ये सारे के सारे एग्जाम्स के PYQs कर लो, बिकॉज एज फार एज माइक्रो इज कंसर्न काफी ओवरलैप देखा गया है। तो इसका क्या आंसर है? 5 दिन के फीवर के बाद अगर पेशेंट आ रहा है तो यू वुड गो फॉर एंटीबॉडी डिटेक्शन। अगर फर्स्ट 4 days ऑफ फीवर में आता है तो आप NS1 एंटीजन करोगे। ठीक है, नॉट PCR। एंड एडीज एल्बोपिक्टस इनोकुलेशन तो बिल्कुल ही बेतुका सा ऑप्शन है। मस्कीटो इनोकुलेशन कौन ही करता है? ठीक है, so more commonly done method after presentation of 5 days of fever is antibody detection। Okay, dengue hemorrhagic fever was mentioned, is it? Even if he came not after 5 days but on day 5, then also answer remains the same। Okay, hemorrhagic manifestations, ठीक है। Now next question was on match the following। These are the correct options। ठीक है, तो मैंने यहाँ पे प्रॉपर क्वेश्चन उसमें नहीं लिखा है। इफ यू कुड रिकॉल कि चौथा ऑप्शन यहाँ पे क्या था। सो बेसिकली लेप्रेसी के लिए स्प्लिट स्किन स्मियर, KOH माउंट टीनिया के लिए पैच टेस्ट, कॉन्टैक्ट डर्मेटाइटिस के लिए गेमिंग विद गौतम। अगर एलाइजा भी लिखा था तो फिर वही एक ही बात है, IgM एंटीबॉडी डिटेक्टेड बाय एलाइजा, IgM मैक एलाइजा करते हैं टू डिटेक्ट IgM एंटीबॉडी। इसमें कैन यू रिकॉल द फोर्थ ऑप्शन? ये सिंपल क्वेश्चन लग रहा है। शिवशंकरन, फोर्थ ऑप्शन, आर यू टॉकिंग अबाउट बायोप्सी? व्हाट? आगे चलो नेक्स्ट क्वेश्चन। Disposable pipette tips are sterilized by autoclaving। I suppose the other options, one was microwave, I suppose। ठीक है, एक शायद हॉट एयर ओवन आया हुआ है। आंसर इज autoclaving। ओके, देन आई थिंक ये वाला क्वेश्चन शायद आपके उसमें डर्मा में भी डिस्कस हो, ल्यूपस वल्गैरिस। तो बेसिकली इजी क्वेश्चन है। ठीक है, ओवरलैपिंग बिटवीन डर्मा माइक्रो। ठीक है, तो डिस्पोजेबल पेपर टिप्स आर स्टेरिलाइज्ड बाय ऑटोक्लेविंग। सो ऑटोक्लेविंग, माइक्रोवेव, हॉट एयर ओवन और एक और ऑप्शन था जो प्रोबेबली रॉन्ग ही होगा बिकॉज हमारा आंसर क्या है इसमें? ऑटोक्लेविंग। ठीक है, so I could gather 19 questions। If beyond these 19 questions anybody else is able to recall, please do share with me the questions on mj.micro insta handle, or you can in this video के comments में भी आप लोग post कर सकते हो। I'll keep checking the comments। ठीक है, and hopefully we'll be back soon with a detailed video। So that's all for micro, एंड स्टडी अच्छा मैं बोलने वाली थी स्टडी वेल, अभी के लिए ब्रेक ले लो, गॉड ब्लेस यू ऑल, थोड़ी सी ब्रेक ले लो, थोड़ी मस्ती मार लो, ठीक है, एंड देन यू कैन गेयर अप फॉर द अपकमिंग नीट पीजी एग्जाम ऑल्सो, 1-2 दिन का रेस्ट लो, गॉड ब्लेस यू ऑल, थैंक यू.
Thank you, Dr. Mamta, for the elaborate recall. So that's a good set of questions from microbiology. And if there are any incomplete responses, you can any day ping us, and we'll be definitely coming with a much detailed response soon. So next we have Dr. Jambulkar sir. So welcome. The stage is yours.
Hello everyone. I hope I am audible and visible to you. Ranjit
Yes.
sir, please.
Yes, sir. So you're audible. You're audible. You can go ahead.
Yes, sir.
Yeah, you're audible, sir. You can go ahead.
Okay. So this is a biochemistry recall INICET 2024, and this is a rapid recall. So you must have done well. If not, and बहुत सारे questions अगर आपके wrong हो गए हो, तो don't worry. Just remember the Yash Dalal performance for RCB in the yesterday's match. उसका कल का performance देख लो, आप refresh हो जाओगे अगर आपने कल match नहीं देखा होगा तो. So let's start with this recall. So what is the graph? This is multiple answer type question. This was multiple answer type question. ये हम यूजी को भी बताते हैं जब पढ़ाते हैं, तो ये क्वेश्चन फर्स्ट टर्म में भी आएगा, प्रीलिम में भी आएगा और फाइनल में भी आएगा, एमसीक्यू. सो रिमेंबर दैट एक्स शेप ग्राफ इट इज कॉम्पिटिटिव इनिबिशन, the V shape graph it is non-competitive inhibition, and if there are parallel lines this is uncompetitive inhibition. And remember this, in this the in the competitive inhibition Vmax increases, so Km increases, so Km increases and Vmax remains same in the competitive inhibition. In the non-competitive inhibition Vmax lowered and Km remains same. So remember this, Km increases in competitive inhibition and Vmax lowered in the non-competitive inhibition. So this was multiple answer type question. Okay. Now moving to the second question, glucose 6-phosphate dehydrogenase deficiency. Regarding this G6PD deficiency, which of the following is not correct? This was again a multiple answer type question. Affect both males and females. NADPH decreases. It is drug-induced disease and will cause hemolytic anemia. Here, remember G6PD, it is connected with the HMP shunt, that is hexose monophosphate shunt. And this is X-linked recessive disorder, mostly affect the males. The females are carrier here. So here, these are the answers. NADPH decreases because there is production of NADPH in the HMP shunt. Then it is because of oxidant drug. When oxidant drugs are given, for example, primaquine for the treatment of malaria, sulfonamide, acetanilide, and favabins, that causes the precipitation of symptoms. Otherwise, individual is normal. So that causes rapid hemolysis because of generation of reactive oxygen species and decreased production of NADPH. So it will cause the hemolytic anemia. So these are the answers here in regarding the G6PD deficiency. Coming to the next question, which of the following is not a criteria for diagnosis of diabetic ketoacidosis? It is simple. Diabetic ketoacidosis means more sugar level, plasma glucose level is more than 250 milligram per deciliter, pH, there is metabolic acidosis, so pH is less than 7.3, bicarbonate level decreases. This is because to buffer the acids which are produced, the ketone bodies which are acidic in nature, and for buffering of this bicarbonate is utilized. So bicarbonate level drop down below 15, and serum potassium level, here the potassium level increases. So this is not a criteria for diagnosis of diabetic ketoacidosis. In the diabetic ketoacidosis, there is hyperkalemia. Hyperkalemia because in blood there is increase in the H positive ion concentration, and to decrease this H positive ion, this H ions moves inside the cell. So in exchange of the potassium, so in the extracellular fluid, potassium ion concentration increases. So there is hyperkalemia in the diabetic ketoacidosis. And when we give the insulin therapy, because of rapid opening of the potassium channel, insulin dependent potassium channel, there is hypokalemia on giving the insulin because of potassium redistribution and rapid opening of the potassium channel. So hypokalemia is there in the insulin treatment. So in diabetic ketoacidosis, there is hyperkalemia. Okay. Which of the following is a post-transcriptional modification except which of the following is a post-transcriptional modification? See, 5' capping, that is guanosine triphosphate capping, is the post-transcriptional modification. Then 3' tailing is a post-transcriptional modification. This option was not known to me. Whether it is exonuclease or something like exon, if it is related with the exon splicing, it is a post-transcriptional modification. Here answer is glycosylation. Glycosylation is the post-translational modification. It is not post-transcriptional modification. Post-transcriptional modification include 5' GTP capping, that is guanosine triphosphate capping, 3' poly A tailing, then exon splicing. Exon splicing means joining of the exons and removing the introns with the help of spliceosome and SNRP. So this is about this. So except glycosylation, glycosylation is the post-translational modification. So methylation, 5' guanosine triphosphate, okay, capping. So if it is glycosylation, glycosylation is the answer. And something related to the exon, if it is exon splicing, it is also a post-transcriptional modification. Okay, exonuclease. एक्सोन्यूक्लियस था या एक्सॉन था ये प्रॉपर पता नहीं है. इट इज रिमूवल ऑफ द इंट्रॉन्स विद द हेल्प ऑफ स्प्लाइसियोसोम्स and joining of the exons together, that is known as the post transcriptional modification. Match the following. This was the simple question related with the glycogen storage disorder और glycogen storage disorder से related specifically glycogenolysis पे हर मतलब repetitively questions आते हैं. Now match the pair, the multiple answer type question. Von-Gerg's disease, the answer is it is glucose 6 phosphatase deficiency. It is glucose 6 phosphatase deficiency. Pompe's disease, it is due to acid maltase deficiency. Pompe's disease is also a lysosomal storage disorder. Then Cory's disease, the other name for the Cory's disease is limited dextrinosis. You you must have remembered this A, B, C, D. Okay. So Anderson disease, branching enzyme, Cory's disease, debranching enzyme. Okay, but here there is no enzyme for the Cory's disease. It is also known as limited dextrinosis. There is accumulation of limit dextrin. So limit dextrin accumulation is related with the Cory's disease. And McArdle disease, all of you know that muscles are involved and there is exercise intolerance and fatigue related to the McArdle's disease. So exercise induced intolerance in the McArdle's disease. So this is glycogen storage disorder. So next question. Delayed sexual development is due to deficiency of. This is a simple question. This was simple question. It is related with the zinc. Remember, zinc is required for the maintenance of germinal epithelium. It is required for the spermatogenesis. It is required for the chronic deficiency of zinc causes the hypogonadism. So zinc is related with the sexual development. Okay. Selenium, it is antioxidant. Copper, it is required for the it is important with the various enzymes, that is lysyl oxidase, cytochrome oxidase, then catalase, various enzymes it is related with. So it is important for the blood formation also. Iron is important and there are various iron containing enzymes. So zinc deficiency causes acrodermatitis enteropathica, but it is also related with the sexual development. Neurotransmitters not amino acid derived, not amino acid derived. So answer was simple, creatine. Creatine, it is formed by the glycine, arginine and methionine. It is derived from amino acid, but it is not a neurotransmitter. Creatine is converted into creatinine and it is a waste product, or creatine is converted into creatine phosphate and it is utilized for the energy purpose. Epinephrine, norepinephrine, dopamine, gamma aminobutyric acid, GABA, which is derived from the glutamate. These are the neurotransmitters. Epinephrine neurotransmitter, norepinephrine neurotransmitter. 5-hydroxytryptamine, serotonin is also a neurotransmitter. 5-hydroxytryptophan is also a useful neurotransmitter. Okay, so here answer is creatine. So the next question was deficiency of which of the following causes lactic acidosis? The answer, It is simple lactic acidosis. The pyruvate is converted into lactate in the pathway. So pyruvate, it is converted into lactate, and pyruvate is converted into acetyl coenzyme A. So this enzyme deficiency, that is pyruvate dehydrogenase complex, if it is blocked, it is diverted for the lactate production. So lactic acidosis will be there in the deficiency of pyruvate dehydrogenase complex. So these are the questions related with the biochemistry, but some overlapping questions are there. That is fish, which does not cover the point mutation, then high anion gap metabolic acidosis, which is already covered by the Vivek sir, and Korsakoff psychosis, that is the memory loss and psychosis, which is connected with the Wernicke's encephalopathy. It is already covered in the psychiatry. So this is all for the rapid recall of biochemistry. Over to you, Ranjit sir, please.
Thank you, sir. Thank you for the very amazing recall of all the questions in biochemistry. So next we have Dr. Santosh with us. Dr. Santosh.
Hey guys, give me a confirmation if I am live and audible to all of you.
Yeah.
So how was the exam? Well, medicine, as you all know, was underrepresented, and those who had decided to skip medicine because it was vast, maybe you derived some benefit. But still, we have recalled around 8-9 questions, and you know that 8 or 9 marks can make or break the difference, right? Okay, so the topics are very predictable. Most of the questions that came from medicine were from predictable topics. Medicine was underrepresented, and most questions were one-liners. So let me start with whatever questions we have recalled. This is our first question. Okay. Now, the first question was about CPR, and I repeatedly tell CPR is one essential skill which all the doctors need to study regardless of what specialty you are going to practice in future. Okay. The question was, which of the following shows accurate CPR? And it was a multiple correct answer type of question. So I'm not trying to build the stem. I would rather just read the options that were available and let us make the list of right options. The first one was chest compression rate should be 100 to 120, which is absolutely right. And as you all know, we follow the ACLS protocol when it comes to the rules of CPR. And as per ACLS protocol, we should compress 100 to 120 per minute. That is true. So first statement was true. Second statement was chest compression of about 3 to 4 centimeters depth, which is false. The reason we do chest compression is to compress the ventricles so that we will achieve some ejection of blood from ventricles to aorta. The main objective of doing CPR is to keep your brain and other vital organs alive. We're not pushing the chest to revive the heart. Remember, whenever we do CPR, we give adrenaline. That is used to stimulate the heart. The compression is not for stimulation of the heart. Compression is to contract the ventricles so that we eject the blood to go to brain. That's our primary objective. We will be able to achieve that when we compress it by 5 centimeters, which is roughly equal to 2 inches. Anything less than that means the CPR is waste. So that's a false statement. Okay. Option C, we should allow the complete recoil of the chest. That is true, because once I compress, I have ejected the blood from the ventricle. I need to also give time for the ventricles to fill. So this is also true statement. And last one was 2 breaths after each 30 compression. That is what we call as ventilation compression ratio or breath compression ratio. For an adult, the recommendation is 30 compressions, 2 breaths. So that is also true. So from this list, A, C, and D are true statements. Okay, I hope the options were exactly same. Anyway, even if they're not same, the essential point is we should know the rules of CPR very well. Every exam, one or the other question comes from CPR. Okay. Now, this is the next question. A man presented with pedunculated abdomen. Basically, they're talking about obesity most likely, or the abdominal obesity, thin skin, purple striae, and non-healing wound. What is the most probable cause? Well, this is a very straightforward question. They're talking about Cushing's syndrome, and we know Cushing's syndrome is due to excess of cortisol. So the answer would be hypercortisolemia. In insulin resistance, the only cutaneous manifestation that I would expect is to see acanthosis nigricans. In hypothyroidism, I can see coarse, dry skin. Along with that, maybe myxedema. If I have hypercholesterolemia, maybe I can have xanthomas and xanthelasmas. But here they're specifically talking about thin skin. which is a sign of Cushing syndrome. It has a high predictive value in comparison to, like, one of the common differential diagnoses for Cushing syndrome is obesity and alcoholism. And the signs which help us to differentiate the obesity, alcoholism from Cushing syndrome is thin skin, purple striae which are more than 1 centimeter in their width, right? And the other Cushingoid features like the redistribution of fat, buffalo hump, all of that. So this question is typically talking about Cushing syndrome, and we will go ahead with hypercortisolemia as our answer. Okay. Then there was one question about the upper motor neuron lesion. I guess the question was which of the following is true or which of the following is false. So can anybody help me to recall the... Okay, so if the question was reframed as high quality CPR, yes, quality of CPR is very, very important, because until and unless we are achieving the appropriate rate of compression and depth of compression, we will not be able to sustain the brain. We will end up losing the brain. So in the end result, you may revive the heart, but lose the brain, and you have a brain dead individual. Okay. So now there was one question about the features of UMN lesion. Can anybody help me to list the options available? What are the options we had for the UMN lesion? Okay. They had asked about features of or features not of UMN lesion. See, remember, the upper motor neuron has a suppressive action, and lower motor neuron is the one which is responsible for maintaining the muscle tone. Okay, let me say there is an exaggerated reflex. Okay. Then one of you mentioned that there was an option about rigidity. Okay. Was spasticity one of the option? Okay. So remember, lower motor neuron is the one which is responsible for maintaining tone of the muscle, right? It maintains tone, and it is part of the reflex arc, So the reflexes are executed by the lower motor neuron, and the tone is maintained by the lower motor neuron, and upper motor neuron has a suppressive action on the reflexes and the tone. So whenever there is damage to the suppressor, what will happen? The tone will increase and the reflexes will get exaggerated. So if the question was about the upper motor neuron lesion and which of the following is or are features, definitely exaggerated reflex is one of them. Atrophy, fasciculations are all suggestive of, as we know, lower motor neuron damage. Spasticity, if it was there as an option, it indicates that it was an upper motor neuron damage. Rigidity generally is a manifestation of extrapyramidal lesion. It is a manifestation of extrapyramidal lesion and not the upper motor neuron lesion. Remember, upper motor neuron belongs to the pyramidal tract, not the extrapyramidal tract. So if these were the options, I will go ahead with option D as the only right answer. If there was spasticity also mentioned, we will definitely choose that also as a manifestation of upper motor neuron lesion. If spasticity was not there, rigidity, exaggerated reflex, fasciculations, and atrophy were the options, then exaggerated reflex is the only right answer. Okay, cool. Now let me take you to the next question. I guess there was a question asking you about the oral hypoglycemic agents which increase the risk of urinary tract infection. And okay, so if multiple choices were there, even then the UMN should have manifested with spasticity and exaggerated reflexes. These two options were there. You can choose those two options. If spasticity was not there, then only exaggerated reflex. And if the question was framed as which of the following are not features of UMN, and then in that case, it will be muscle atrophy, fasciculations, and rigidity. Those will be our correct answer. Okay. I will properly reframe the questions by talking to the students again, and I will come out with that. But I hope I have given you an idea. What are the features of UMN and what are the features of LMN damage? Okay. Then I guess there was one question about the oral hypoglycemic agent, which increases the risk of urinary tract infection. I think all of us know that there is one oral hypoglycemic agent which inhibits the reabsorption of glucose in the kidneys, and thus we have glucoseuria. Whenever we have glucoseuria, we are providing indirectly our urine is becoming culture media for bacteria, and we have a tendency to get UTI. So as a class, the answer would be SGLT2 inhibitors. And if it was not the class, right, the SGLT2 inhibitors, which generally are gliflozins, if they're not mentioned as a class, if they're mentioned a specific drug, you can choose specific drug, whichever they had mentioned, dapagliflozin, empagliflozin, right? canagliflozin, whichever they had mentioned, you could have chosen that. And I guess this is a very simple and straightforward question. Most of you would have got it right. Okay. Then this is one question which was again a pretty straightforward, a predictable topic. There was a question on ECG which was showing an irregular narrow complex tachycardia. Okay, so I heard that most of the students said the drug mentioned was dapagliflozin. So if DAPA was the option, then we know that that's the answer. Okay. Then there was a question on an irregular narrow complex tachyarrhythmia. Yes, I know the ECG image was given. And they had mentioned that patient was dyspneic or unresponsive or hemodynamically unstable. Right, that's what, hypotensive. Now, the reason I've not given an ECG image here is because I want to deliver an important message. Any arrhythmia, any tachyarrhythmia, if the patient is hemodynamically unstable, what is the treatment of choice? If a patient is hemodynamically unstable, what is the treatment of choice? Shock, right? So just make an important note here. Any hemodynamically unstable pharmacotherapy is to be used when you have a stable patient. So hemodynamically unstable tachyarrhythmia, it should be shock. Now there are two types of shock, as you know. One is the synchronized cardioversion. The other one is defibrillation, which is also called as asynchronized cardioversion. Right? The term cardioversion, if they mention, it means that we're talking about synchronized shock. And if they mention defibrillation, it is asynchronized. So the synchronized cardioversion is used for all arrhythmias except two. Right? So there are only two arrhythmias where we use defibrillation. Defibrillation. What are those arrhythmias? First one is ventricular fibrillation, and the second one was ventricular tachycardia without pulse, right? For all other narrow complex tachyarrhythmias and VT with pulse, all we have to do is do synchronized cardioversion. So for these patients, we have synchronized cardioversion. And the moment a question mentions that it is a case of narrow complex tachyarrhythmia or the ECG, you can clearly notice that the rhythm was narrow, means the QRS complexes were less than 120 milliseconds. We know that it is a narrow complex tachyarrhythmia, and in that case, it has to be synchronized cardioversion, and that's the only option which becomes valid here. I would have used adenosine if it was a PSVT and patient was stable, right? I would have considered amiodarone for most of the arrhythmias, that being a broad spectrum antiarrhythmic, and I would have considered carotid massage or Valsalva for narrow complex tachyarrhythmias, particularly SVT, provided patient was hemodynamically stable. Here, clearly, patient is hypotensive, so obviously the answer would be synchronized DC cardioversion. Okay. Now, this is one question. I need your help here. So I heard that there was an ECG-based question where they were able to see ST depression in lead V2, V3, V4. Okay. And probably patient had presented with chest pain. And we had to decide whether patient has got options. As I could recall from the students' conversation, one of the option was NSTEMI. The other option was posterior wall MI, right? And then one more option was unstable angina. I'm not able to recall the third option. Okay, so guys, what do you think? Okay, there was an option of myocarditis also. Okay. So what do you think is the answer here? Okay, so let me break some of your hearts because this is a tricky question. So when you say ST elevation, see, whenever a patient presents with unstable angina, means chest pain that started at rest or chest pain that did not get relieved within 5 minutes of rest or taking nitrates, we call it as unstable angina, right? Any patient with MI is going to present as unstable angina. Initial presentation will be unstable angina. The first step we do is to do an ECG. If ECG shows ST elevation, then we know that we are talking about a case of STEMI. Okay. As all of you recall, there was no ST elevation in the ECG. So STEMI was definitely not a direct answer for sure. Okay. Then if ECG shows no ST elevation, then two possibilities are pending. One is non-ST elevation MI, NSTEMI, and the second one is unstable angina. Okay, so how do you distinguish between NSTEMI and unstable angina? The main distinction between NSTEMI and unstable angina is with the help of cardiac biomarkers, because to call it as MI, there should be infarction. So what biomarker can help me to identify infarction? Troponins are most commonly performed. So if the troponin was positive, then NSTEMI. If the troponins were weakly positive or negative, then it will be called as unstable angina. But one fact we are missing. Now, do we have leads for the posterior wall on the standard 12 lead ECG? The answer is no, right? We don't have leads for the standard posterior wall on the standard 12 lead ECG. If you suspect that patient has got posterior wall MI, you need to add additional leads, right? The posterior leads to recognize it. We call those leads as V7, V8, V9. But when do I suspect? Because the principal blood supply to posterior wall is from the right coronary artery. Any patient with inferior wall MI, we should suspect he may be having posterior wall MI also, and we should do posterior lead ECG. Similarly, posterior wall, though it does not have direct representation on the 12 lead ECG, it has anterior leads as its reciprocal leads. And we know that there are something called as reciprocal changes. So if posterior leads are supposed to show ST elevation, anterior and to some extent septal leads can show ST depression. So whenever you get ST depression in the anterior and septal leads, which is nothing but V1, V2, V3, V4, we should suspect the possibility of posterior wall MI. Okay. I cannot call something as non-ST elevation MI without you telling me that the cardiac markers are positive. Okay. And the question was also kind of tricky because you can have ST depression in NSTEMI also, and you can have ST depression in these leads in posterior wall MI. The feature that helps me to distinguish is in the lead V1, I have to look at the R by S ratio. R by S ratio, that is one point. And second, the nature of ST depression. Normally, if it is posterior wall MI, the ST depression will be downsloping ST depression. Okay, was there T wave inversion in lead V1? Only lead V1 there was T inversion? Just give me a confirm. Was there T inversion in lead V1? Okay. See, if on the given ECG, the R by S ratio was more than 1 and downsloping ST depression, in the sense like this is my P wave QRST, right? If the ST segment was downsloping and the T wave was upright, not inverted, then it is suggestive of posterior wall MI. If the ST segment was downsloping or flat, not upsloping, okay, downsloping ST segment or a flat ST segment which is depressed, flat ST segment depression with upright T waves, no T inversion, then it is suggestive of posterior wall MI. So I'm not very sure how was it. If you're very sure that there was T inversion, in that case, the answer would be, it is safe to go ahead with the answer as NSTEMI. Okay, but if you say that, sir, the R wave was the dominant wave in lead V1, and along with that, there were upright T waves after the ST segment depression, then I would go ahead with the posterior wall MI as my diagnosis. Anyway, both the points we have learned today, right? If it is NSTEMI, I would have seen a predominant S wave in V1 and ST segment may be depressed. And if it is posterior wall MI, I would see predominant R wave in V1 and the T wave will be upright. That's it. Okay. Now, there was one more question on a patient with heart failure with reduced ejection fraction, and they were asking which anti-diabetic will be useful. Now, when it comes to a patient with heart failure with reduced ejection fraction, when do we call it as reduced ejection fraction? When EF is less than 40%. Less than 40%. Okay. In such patients, there are few drugs which are having a mortality benefit, and that includes AC inhibitors. They reduce the mortality, or ARBs, beta blockers, right? And then mineralocorticoid receptor antagonists like spironolactone. Then a new class of drugs called as ARNI and SGLT2 inhibitors, right? These are all associated with reduction in mortality. And for that reason, there is a strong recommendation to use the SGLT2 inhibitors in patients with heart failure, even if they are non-diabetic, because SGLT2 inhibitors per se do not cause hypoglycemia. So we do use them even when they do not have diabetes. So obviously the answer should have been, if it is a class, then it will be SGLT2 inhibitors. If they had mentioned dapagliflozin or empagliflozin, I would have gone ahead with those drugs. Okay. Okay, so that's all we could recall from this exam. As I already told, there was underrepresentation of medicine, but there are a lot of questions which are already taken up by my other colleagues, which I could claim that they belong to medicine. Like there was a question on dengue, there was questions on malaria, there were questions on lactic acidosis. Because they have been addressed earlier, otherwise, I'm not taking them up. But if the STEM was more complex, we will definitely reconstruct that and share on the Telegram. If you guys have any more questions from medicine which we are not able to recall, definitely you can ping me on Telegram or the Instagram, and I will address them through the social media handles as well as a properly reconstructed PDF from the PW MedEd. Dr. Ranjit, that's it from me, and over to you.
Thank you, Dr. Santosh. And like I said, so once medicine is less number of questions, medicine is going out, and I am going to welcome Dr. 𝐒𝐿𝐴𝐀𝐄𝐝 for orthopedics. This time orthopedics has more number of questions. Over to you, 𝐒𝐿𝐴𝐀𝐄𝐝.
Hello everyone, hope I'm visible and audible. So I'm so happy, as Ranjit sir told, this time we had many questions from orthopedics, and quickly let's go through the orthopedics, because now orthopedics is playing an important role in deciding your rank. So the first question is the standard care of treatment in neck of femur fracture in 70 years old female, right? So in this question, what is important is the treatment part, and the most important thing which you have to look here is 70 years, that is the age. And if somebody is like, these exam is usually attended by people who have completed internship, right? So if you have attended your clinicals, the neck of the femur fracture is very, very important. Like you see regularly in the OPDs. And what you have to remember is you have to always divide it, or you have to first see whether it is an intracapsular fracture or an extracapsular fracture. So intracapsular fracture is nothing but your IC, and extra is IT. So the treatment varies whether it is an IC or IT, right? So for IC, depending upon the age, if the age is more than 65 years, you directly go for hemiarthroplasty or arthroplasty. So as the options here given shows only hemiarthroplasty, here there is no arthroplasty included. Like that is THR, what I mean. So here you see hemiarthroplasty. So the answer here would be hemiarthroplasty, as it is an intracapsular fracture, what I'm talking about. If it was an extracapsular fracture, like if it is an IT fracture, similarly for a more than 70 years patient, the answer would be a PFN, that is proximal femoral nailing. Right? So this is how you have to deal with this, both the questions. I hope most of the students have come with telling us there were two questions on neck of femur fracture. That is, one is extracapsular and the second one is intracapsular, right? So here the intracapsular answer would be hemiarthroplasty. So there is no role of tractions, no role of nails in case of IC. And as I've told you, again, there is a fourth one is some bar traction. So there is no role of traction for people with the IC fractures, because the complication is avian. So we don't actually deal with the tractions in case of this IC fractures. Now, second question is again an IT fracture. As I've told you, the extracapsular fracture, or it is also called as IT fracture. So here the treatment is proximal femoral nail. Sometimes we also deal with DHS, but usually the option would be proximal femoral nailing. So here hemiarthroplasty would not be an option, right? So this is the answer of IT is proximal femoral nail, and for IC it would be hemiarthroplasty. If at all it was given THR was included, then again you have to read the question again. If there is an any word such as active individual or any arthritis of the acetabulum was also seen on the X-ray, then you would go for a THR option, right? So that is how we deal with the first two questions. And then this is a very easy question. The most common osteoporotic fracture. In case of osteoporosis, the most commonly we see the fracture is vertebra. So the vertebral fractures are said to be the most common, followed by your distal radius and followed by your proximal femur, right? Proximal femur. So these three are the areas where you see the osteoporotic fractures. The other three, usually we don't deal them in osteoporosis, right? So that is actually, this is one of the most easiest question. So most common osteoporotic fracture is vertebra would be the answer if this is the question, right? If it is the most, if the question was, which was not seen in osteoporosis, as somebody has claimed from other, like other students have told me that if the option is not most common, then the answer would be your subtrochanteric, because usually subtrochanteric would be the last option in case of osteoporosis, right? So that is about the third one. And coming to the most interesting and important topic of orthopedics, this is ankylosing spondylitis. So we usually deal with much, as you have to remember that ankylosing spondylitis, the most commonly seen in males, and usually in the younger males of 20 years, where they are associated with HLA-B27. And what is the most important thing? They are present with extra-articular manifestations, right? So there are many extra-articular manifestations which you see, and usually they present with syndesmosis, right? So there will be fusion of the spine, that is syndesmophytes. You see, so there is fusion of the joints, and this is erosion arthritis. So the option here, the fourth option here is not non-erosive arthritis with the increased joint gap. That would be the false statement regarding the ankylosing spondylitis. So all other options, such as it usually affects males, which is right, and the 70 to 80% which is associated with HLA-B27 is also right, and usually seen in early male, that is more about in 20 years age group. So the option third one is also right. Usually if the option was this, non-erosive arthritis with increased joint gap, this would be your wrong answer, right? So somebody can help me with the ankylosing spondylitis if you want, add something. Okay, then nothing to be added to that question. Then we'll move to the next question. So students have come up telling me that there is a patella fracture. So what they told was there was some knee X-ray which was shown, and the option of patella fracture was there. So patella fracture option was there, and fracture tibial condyle option was there. Usually whenever you see fractures are easy to identify on the X-ray. So usually you see the fractures, but if it was hemarthrosis or RA, so hemarthrosis, usually we don't take any X-ray. So nothing to be seen on the X-ray for hemarthrosis, except for, a hemophilia where there will be intercondylar distance. So if that was the case, then it could be true. And rheumatoid arthritis, as you all know, if they would have put up their clinical question stating that a patient presented with the morning stiffness and there were multiple joints which were involved, then there is a polyarthralgia, then it could be RA. But maybe probably most of, like I have listening to so many students, I've understood that this could be a patella fracture, but in AP view where student is, to see them whether they're keen on identification of that thing or not. So if you see in this particular picture, you can see that there is a gap between the patella. So there is a line which is seen here. So this could be the probable picture which is shown and showing a patella fracture, right? And if it was a fracture tibia condyle, you can easily identify that fracture tibia condyle X-ray, right? And the next one, the question was regarding the chronic osteomyelitis. I am not very sure whether there was an MRI put up or a CT scan which was put up in the exam. But what they have told us is the question framed was a clinical question where the patient presented with thigh pain, and there was an MRI which is presented there. And if at all the MRI was showing something which is like the dense sclerotic bone, right, which is surrounded, then there are two things which you have to identify. One is your sequestrum, then use your involucrum. If you see these two, involucrum and sequestrum, then you should opt for the chronic osteomyelitis. And if you see something like sunburst appearance or something which is very spread even to the soft tissues, it could be an osteosarcoma, right? And usually for osteomalacia, we don't take an X-ray. Osteomalacia, we usually don't take an X-ray, right? So it could be osteosarcoma. And Ewing's is, again, you have to see whether the patient has presented with any clinical symptoms, right? Like the raised ESR or fever. So, and then the biopsy becomes important for diagnosing between Ewing's and your osteosarcoma, right? So as of now, taking the students' opinion, the answer would be chronic osteomyelitis there, where they have seen these particular CT scan which was put up, and there is a sequestrum and lot of new bone which is seen, okay? And then the seventh one. So here there was a question which was asked, a 24 years old female with right proximal third femur fracture. So here whenever there is a fracture, we have to first see whether it is a periarticular fracture or whether it is a shaft fracture, right? So periarticular includes both your epi and the diaphysis, epi and the metaphysis, and shaft includes the diaphysis. So whenever it is shaft, we go for intramedullary interlocking nail. So you see a nail with two locking screws above and below. And if it is a periarticular fracture, you go for plating. So as the question is framed proximal third femur fracture, I believe the answer would be intramedullary interlocking nail. So usually for proximal femurs, we don't go for cast or slab, or in 24 years old female, we don't go for hip spica. Hip spica is preserved for only the children, right? That too about 2 to 4 years. And cast and slab usually we see for fractures of tibia. And usually for proximal femur, we don't go with casing or slab. So the answer here would be intramedullary interlocking nail, right? And then Salter-Harris, this pediatric question which was there, that is type 1 fracture. Salter-Harris type 1 fracture is related to what? So if you see the growth cartilage, we all know that there are 4 zones, right? So from this is, if you think this is the epiphysis towards the metaphysis, so you have your reserve zone or the resting zone, right? Then you have a zone of proliferation, then you have zone of hypertrophy, and you have your zone of calcification. And if you all remember, this is a very, very basic question where the zone of hypertrophy is supposed to be the weakest area. And whenever there is a Salter-Harris type 1, which is through the physis, like S is for straight, right? The first one, SALTER, what we remember as a mnemonic. So S is straight, which is through the physis, that is through your zone of hypertrophy, right? So this is only through the zone of hypertrophy, which is the weakest area in the growth cartilage, and Salter-Harris type 1 is related to this particular zone. So that is about the question regarding the Salter-Harris, right? And then there was a question which is related to teriparatide, which is a pharmacological integration question. So usually for treatment of osteoporosis, we also include the teriparatide, which is supposed to be the anabolic hormone, right? And it is used in the synthesis. It is used in the used in the formation of the bone, right? So here the options are the osteonecrosis of the jaw and subtrochanteric fracture. These two are mainly the side effects of the bisphosphonates. So these two are usually the side effects of the bisphosphonates, and the net loss of bone is not an answer. As I've told you, this increases the formation of the bone. And the leftover option is osteosarcoma. So the answer would be osteosarcoma. So these are the various questions which have been asked in ortho, and I have just to be sure of this question of chronic osteomyelitis, which I'm not pretty sure, because what was the CT MRI findings have not been told. I'll be happy if somebody puts up in the comments. Hope I have covered everything. If anything is left out, please let us know through your comments. We'll come up with the complete recall sooner. Thank you. Over to Dr. Ranjit, sir.
Thank you, Alekhya. It was a brief and amazing discussion of orthopedic questions. So thank you once again. So next, Alekhya will be followed by Dr. Jasir. Jasir, over to you.
Thank you so much, Ranjit sir. I hope I'm audible and visible.
Yeah, you are.
Thank you so much. So to start with, just a minute. Yeah. So regarding dermatology, I hope that all of you are having a great recall session. First of all, thank you all the students for sharing all the recall questions in such a short time frame. And just going forward, I have got almost 5 questions from dermatology. And all those questions are a little surprising because usually what we expect in psoriasis and all were not asked. Instead, let us see what are the questions that were asked. And in the meanwhile, if there is any suggestions that you have about the accuracy of the questions, do let me know in the chat box. So going to the first one, which leprosy drug causes pigmentation as a side effect? So here again, usually in leprosy, we usually get a clinical case, which is usually an image-based question. But this time what was tested was the side effect of a drug. So in the options given were dapsone, rifampicin, clofazimine, and probably the last option was prednisolone. So out of all these options, we all know that in leprosy, we go for a multi-drug therapy. So in this multi-drug therapy, we use all these 3 drugs, that is dapsone, rifampicin, and clofazimine. Now, which among all these 3 is going to show a side effect as pigmentation of the skin? So any hyperpigmentation of the skin, etc. Yeah, very good. Your drug of choice is answering that this is going to be clofazimine. Excellent. So this is going to be the right answer here. So among all the leprosy drugs, we know that the various side effects has been discussed. Like in the cases of dapsone, there is chances of hemolysis, methemoglobinemia. Also, some cases may also report peripheral neuropathy as well. When it comes to rifampicin, you must have already learned along with the side effects of anti-tubercular drugs as well as for leprosy. One of the side effects is hepatotoxicity. Along with that, red or orange discoloration of body fluids. Now coming to clofazimine, which was asked in this exam, in clofazimine, this side effect, that is the hyperpigmentation of the skin. So this discoloration of the skin is going to be a common side effect. The importance of this side effect is that this is going to be a little bit persistent. Even though this is going to be reversible, this may be persistent for several months. or sometimes up to several years. So there is going to be a persistent discoloration of the skin for certain months or certain years. That is the reason why this can be a very important question. And other than that, again, photosensitivity, dry skin, all these things, including ichthyosis, has been reported as a side effect of this drug called clofazimine. Now, moving to the next question. A pregnant lady having a painful genital ulcer gives birth. After some time, the child develops the lesion. So was this the same question that was asked? So in this question, you can see that the main thing that you have to go through here is the painful genital ulcer. So whenever you get any question about genital ulcer, you always will have to differentiate between a painful and a painless genital ulcer, right? So painless is, we can remember it as LSD, that is LGV, syphilis, and donovenosis. But in the question, like all these three is not there. It is asked as a painful genital ulcer. Usually two of the causes of painful genital ulcer, they are the chancroid and the herpes, right? So among the options also, it is not difficult. Herpes 2, herpes zoster, hepatitis. Obviously, herpes zoster and hepatitis does not cause a genital ulcer. So here the right answer should be herpes 2. So HSV 2 is going to be the right answer. Yeah, thank you so much for confirming in the chat box. So now let's go to the next one. Again, not a difficult question because the question was annular lesions are seen in. So what do you mean by an annular lesion? Annular lesion means rounded lesions, right? So see the options. The options given was urticaria, pityriasis rosea, porokeratosis, and tinea corporis. So urticaria, all of you know, they are going to present as hives or wheals, right? So these are like some edema that is seen beneath the skin. Pityriasis rosea. Porokeratosis, it is a rare disease. It is a disease of, defective keratinization. And the last one is tinea corporis. In fact, actually speaking, like which all diseases, including porokeratosis, can show an annular lesion. But among them, all these options, the most appropriate one would be tinea corporis. Because in tinea corporis, okay, some of you are saying that is asked as in not seen. See, in case it is seen, then in the case of tinea corporis, we always get an annular lesion or a rounded lesion with a raised border, and there would be some peripheral scaling. And in the central part, there will be some central clearing as well. Fine. So that is about this question about annular lesions that is seen. Now, in the next question, it is about the match the following. So some of the students told about which is wrongly matched. Some of them said which is going to be there was a question like match the following. So just let me know how the question was asked. Now in this question, there were 4 options like leprosy, split skin smear. Obviously in leprosy, we do the split skin smear just to assess the count of the bacteria. Like we have the morphological index, isn't it? All those things are coming under the split skin smear. Tinea KOH, like in all the cases of tinea, be it tinea versicolor or in dermatophytosis. Okay, Shahrukh is saying that it was match the following. Fine. So in that case, in tinea also, the investigation of choice is going to be the potassium hydroxide test. The next one was patch test. So in patch test, can you confirm whether it was given as contact dermatitis or was it given as irritant contact dermatitis? Because if it is irritant contact dermatitis, that is going to be a wrong answer. So that is going to be wrong because this is actually the investigation of choice in allergic contact dermatitis. And the last one is lupus vulgaris. Lupus vulgaris means it is a cutaneous tuberculosis. In cutaneous tuberculosis, obviously we can go for a skin biopsy because in the histopathology, we would be able to make out a diagnosis based on the histopathology as well as the PCR testing, etc., isn't it? So all these investigations, probably if it is a match the following, then multiple right answers. Or if it is wrongly matched, if the option was given as irritant contact dermatitis, that would have been the wrong answer. Okay, if it is just given as contact dermatitis, then the thing is that in contact dermatitis, two diseases do come, like irritant contact dermatitis and allergic contact dermatitis. So if it is just a patch test for contact dermatitis, that is going to be the wrong one. All the remaining would be the right answers. Fine, there would be like multiple correct answers. So, and the next one was a question from vitiligo. So see this question, which form of vitiligo later becomes stable and non-progressive? So the question is about the stability and the non-progressive nature of vitiligo. In the options, you can see focal vitiligo, which means just one or two lesions would be present anywhere in the body. The second one is segmental vitiligo. So what do you mean by segmental? Segmental means this is going to be along the dermatomes, isn't it? Along the dermatomes. The next one is acrofacial. Just like the name says, the extremities and the face can be involved. And the last one is mixed. Now, which among the following do you think that it is more going to be stable and non-progressive? Remember, among all the options here, the one that is going to be non-progressive or which becomes stable in some point of time is going to be the segmental type of vitiligo, where you get this loss of melanocytes along a dermatome. So for that reason, the entire segmental vitiligo is going to be unilateral. It will not cross the midline, and this is going to be a non-progressive type of vitiligo. So these are the questions that you have got from dermatology. So only 5 questions I could gather. And I hope that if there is anything more, please do let us know. And I'm sure that PW will come up with a more comprehensive recall and will share it in the app. So that's it, Ranjit sir, from my side about dermatology recall.
Thank you, Jesse. So that's the dermatology. And following dermat, we are going to have forensic medicine. We have a legal expert coming in soon. Manjunath sir. So over to you, sir.
Yes. Thank you, Ranjit sir. So there were around 78 questions from forensic medicine. So I'm going to discuss in next around 10 minutes. The question number one very important question, very commonly discussed in our classes. That is ideal suicidal, that is cyanide poisoning. The question is very simple. Antidotes used in cyanide poisoning. So look at the options. Amyl nitrate, sodium nitrate, sodium thiosulfate, sodium nitroprusside. So the answer is very simple. ABC is the correct answer. ABC is the correct answer. Okay. Amyl nitrate is used, as you know. Sodium nitrate, sodium thiosulfate, we call it as Trimurti in case of cyanide poisoning. Okay. The answer is ABC. Sodium nitroprusside is not used. So this is what we discussed in our classes. Treatment of cyanide poisoning along with the doses. The next question related to paraphilia. So repeat question from last year exam. Match the following sexual paraphilia. What do you mean by sexual paraphilia? Abnormal sexual behavior, right? Option A, proteirism. What is proteirism? Also known as toucherism. So the answer is rubbing against non-consenting person. A2, that is. A2. Eonism. What is eonism? Transvestism, right? Cross-dressing and feminine behavior. That is B3. Necrophilia. That is sexual intercourse with the dead. C4. And active algolegnia, also known as sadism. What do you mean by sadism? Inflicting pain to partner to get sexual pleasure. So the answer is 2. That is the correct answer. So this is proteirism, also known as toucherism. Okay. It is punishable under section 290 IPC. This can be asked in your upcoming NEET PG exam. Question number 3. The question number 3. A case of poisoning a 40-year-old female who had consumed white, odorless, tasteless powder. Okay? Rat poison. Odorless, tasteless powder. Came with a history of salivation and other clinical feature. Serum hypokalemia. That is, potassium level is 2.5 milliequivalents. So, hypokalemia is given. So, hypokalemia with areflexia. So, what would be the correct answer? What would be the correct answer? It is not warfarin toxicity. Zinc phosphide, no. Aluminum phosphide, hypokalemia is not seen. Answer is barium carbonate. Hypokalemic paralysis, that is commonly seen in barium carbonate poisoning. So the answer is A. And what you can see here, barium carbonate, colorless, tasteless powder, well-known rat poison. Next question. Question number 4 about the declaration. One more very important topic commonly discussed in our classes. Declaration of Oslo by World Medical Association in 1970, which refers to Oslo. There are 2 O's are there. That means it is abortion. Answer is therapeutic abortion. Torture, that is Tokyo. Tokyo declaration is for torture. Ethical aspects of medical research, that is Helsinki declaration. The declaration of hunger is known as Malta. Declaration of Malta for the hunger. So the answer is A is the correct answer. You can remember T for torture, that is for Tokyo declaration. Next. During autopsy of fetus, correct order of opening cavities. The options are abdominal cavity, thoracic cavity, pelvic cavity, neck. So what is the answer? Anyone can you guess? It is given in standard textbook. The first cavity should be abdominal cavity. Then should be thoracic cavity. So the answer is A is the correct answer. A is the correct answer. Not the neck, not the pelvic cavity. If option given cranial cavity, then answer is cranial cavity. The first cranial cavity, then abdominal cavity, then thoracic cavity. Okay. So to detect live birth, your answer should be abdominal cavity. 100% answer is abdominal cavity. Okay. Sanket Korade. To detect live birth, the first cavity should be opened is abdominal cavity to know the level of diaphragm. Question number 6. Features of Korsakoff psychosis. Very simple question. Very commonly asked topic is alcohol. So what are the features of Korsakoff psychosis? That is vitamin B1 deficiency. Amnesia can be seen. Polyneuropathy can be seen. There can be compensatory confabulation. So the answer is 1 is the correct answer. A, B, C correct answer. Ophthalmoplegia commonly seen in case of 𝐌𝐞𝐿 encephalopathy. Okay. And well-known mnemonic we discussed many times in our Instagram reels also. Welcome to Goa. 𝐌𝐞𝐿 is equal to welcome to Goa. That is G for global confusion, O for ophthalmoplegia, A for ataxia. And the question number 7. The question number 7, it was about the gunshot injury. A picture was given. Injury over the skull showing inner table beveling. Inner table or outer table beveling. Cruciate entry wound. What is the weapon causing it? Definitely not iron rod. No. Scissor, no. Hammer, it causes depressed fracture. Very commonly asked question. Signature fracture. The answer would be bullet is the correct answer. It is a gunshot wound. Very simple it is. And this is what the depressed fracture caused by the hammer. And the last question, following crystals are seen in dash poisoning. Some crystal picture was given. The finding was colorless bipyramid shaped crystals of calcium oxalate. So the answer would be ethylene glycol poisoning. A is the correct answer. And this is what we discussed in our classes, the metabolism of ethylene glycol, glycol into aldehyde, aldehyde into glycolic acid. So there were 8 questions, all 8 questions from our PW MedEd notes and the videos. I can say strike rate is 100%. Thank you. Thank you, Ranjit sir. Over to you.
Thank you, sir. Thank you for that quick and an amazing recall. And it's very glad to know that all the questions that come from the notes and the PW lectures. Thank you once again, sir. So after forensic, we have Dr. Oshika. We'll be recollecting the questions which came in the OPG. Over to you, Oshika.
Thank you, sir. INI continues to be a mix of, one-liners and, a little bit of concept-based questions. So up till now, I was able to get around 19 questions that were directly or indirectly related to OBG. Of course, I'm not including the Oslo Convention, the obsession with MTP in INI continues. So barring that, I'm going to discuss whatever else I've been able to get. Some of the options I was not able to get in the recall. So if something is missing, you can let me know. So starting with which of the following variety of twins is not possible, and the options given are monochorionic monoamniotic, monochorionic diamniotic, dichorionic diamniotic, and finally dichorionic monoamniotic. Now remember, we have done this in class. And remember, the chorion forms first. So it forms at around 8 days after implantation, whereas the amnion or the amniotic sac is forming some 10 days after implantation. And this division or these type of twins that are forming is because of a cleavage. So naturally, there is no possibility in which the amniotic sac divides, but the chorion is unable to divide, right? So by exclusion, we know there can be no, monoamniotic dichorionic twins. So the answer is DCMA or D. So I'm going to do a very brief explanation here because I have a lot of questions and I only have 15 minutes. So a detailed video will come later. Next question is, if I understand a low-lying placenta partially covering os, what is the next step? And this again has been covered in our class. And when we talked about the asymptomatic placenta previa, we talked about how we call it a low-lying placenta till the time that it is confirmed, because there is a trophism of the placenta, which means if this is the uterus, if towards the beginning of the pregnancy, the placenta is over here, till about 32 weeks, it can migrate upwards. So if there is a lady, even if she's had a bleeding episode due to a low-lying placenta at, for example, 20 weeks or 21 weeks, we will not label her placenta previa. The next thing we will do is we will repeat a scan at 32 weeks. At 32 weeks, if it is still low-lying or within 2 centimeters of os or covering os, only then we will refer to it as placenta previa. There is a good possibility that this lady who bled at 21, 22 weeks because of a low-lying placenta has an upper segment placenta when we do a repeat scan at 32 weeks. So the answer will be A. So remember, MRI does not have a lot of, only in cases of a posterior lying placenta where visualization is difficult do we do an MRI. Otherwise, the diagnosis of placenta previa is through ultrasound. So this. Next question, again, pretty straightforward. Dose of antenatal corticosteroids. And we have 2 antenatal corticosteroids that we use. And this is a favorite question because children tend to, confuse the dosing and the time interval. So the answer over here again is dexamethasone 6 milligram 12 hourly for 4 doses. Remember, beta has only 2 doses. So the correct dose of betamethasone is 12 milligram 2 doses. 24 hours apart. Whereas for dexamethasone, it is 6 milligram, 12 doses, 4 doses, 12 hourly. 4 doses, 12 hourly. So the correct answer is A. Again, this is something very straightforward question, has been covered in our lectures. Next, which mineral is required for fertility? The answer, again, a one-liner. This is zinc required for spermatogenesis. The details will be dealt with in the following class. Dose of Antara, again, a straightforward one-liner. What is Antara? Antara is under the Ministry of Health and Family Welfare basket of contraceptive choices. This is injection DMPA. I could not get the options for this. Or it is a long-acting reversible contraceptive. It is a non-oral hormonal contraception, and it contains DMPA, dipomedroxyprogesterone acetate. Now, the question was, what is the dose of Antara? So typically, Antara is given in an IM dose of 150 milligram. And this lasts for around 3 months. But in case the lady is not able to return for a repeat dose, there is a grace period of 28 days or 4 weeks or 1 month, whatever you want to call it, because there is a delayed return to fertility with DMPA. However, because I could not get the options, and INI has a tendency to ask newer questions, and this again has been covered in the class. So it is 150 milligram if we are giving an IM dose. However, women can be trained to take DMPA or Antara injections themselves, which can be taken in a subcutaneous manner. So if it is subcutaneous, the dose is lower, and that is around 104 milligram. So depending on what was the exact nature of the question, in case nothing else was specified, we will go for the standard. Dose, which is 150 milligram IM, because that is how it is given mostly. Coming to the next question, which hormone has no role in intrauterine growth? So we know hypothyroidism in the mother can cause FGR in the fetus, and T3 and T4 are very important hormones for fetal growth, and insulin along with its corresponding growth factors, typically IGF-1 and 2, especially IGF-1 help in fetal growth. And we talked about this in detail when we talked about diabetes in the mother. This was in fact the same hormone that was responsible for causing macrosomia and the differential fat distribution on the shoulder of the fetus, which predisposes these mothers to shoulder dystocia at the time of delivery. So the answer over here is growth hormone. Growth hormone has no role in the fetal growth in utero. After the baby is born, of course, however, it's a different story. Now coming to another very straightforward question, very common question. And all of these one-liners you can expect in NEET PG as well. So this is a 30-year-old patient with chronic hypertension. Which drug is contraindicated in the management of PPH? So remember, the methyl ergometrin or methergin, which is an ergotamine, is a very, very potent vasoconstrictor, right? And in a woman who has chronic hypertension, not just chronic hypertension, even if she's suffering from PIH, this can cause stroke, this can cause MI, this can cause gangrene of extremities, right? So methergin is contraindicated, right? Again, this has been covered in our class, and other contraindications have also been discussed. Apart from being a very potent vasoconstrictor, it is also a very potent uterine contractile agent. So in any of the cases when we do not want the uterus to contract too vigorously, we want it to contract, but we do not want it, to contract too vigorously. In those cases, we do not want methergin. And what are those conditions? We do not want it to contract too vigorously or too hard, is because what is going to happen is all the blood in the sinuses of the uterus are going to go back into the maternal circulation. So we want to decrease the rate of autotransfusion. Right? So we want to decrease autotransfusion in Rh negative pregnancies, in HIV mothers, and in mothers with heart disease. Of course, the other contraindication we have already discussed, hypertension, and because it is a very potent contractile agent, if after the delivery of the first twin and before the delivery of the second twin, we use methyl ergometrin or methergin, it can lead to fetal distress of the second twin. So it is also contraindicated in the delivery of the second twin. Now, the next question, again, I was not able to get a very accurate recall. Now, if the question was, which is the most potent natural estrogen? So if it is natural estrogen, remember, then the answer is going to be estradiol. However, if the question was, which is the most potent estrogen only, then your answer would change to D, CEE, or conjugated equine estrogen. Remember, in severe acute AUB, we were using conjugated equine estrogen, which is a very, very potent estrogen to stop the bleeding, right? But if the question is natural estrogen, then the answer will be E2, the estrogen found during the reproductive age group. Now, the next question, a female accompanied by her mother with primary amenorrhea on examination, what is seen as secondary sexual characteristics are present, which means breasts are present. Breasts are Tanner stage 5, so there are adult breasts. The karyotype, very important. They have already given us the karyotype. That is not left to guesswork or finding out. It's 46XX. And FSH and LH are pretty much within the normal range, right? So what is the most possible diagnosis? So first of all, I can just rule out AIS. I can rule out AIS straight away because I already have the karyotype. Androgen insensitivity syndrome is going to have an XY karyotype with palpable testes at the level of, the mons pubis or in the inguinal canal. If I talk about the other three options, B, C, D, gonadal dysgenesis. Now, gonadal dysgenesis can be XO, XX, or XY. It has been already given to us that this is an XX. This is an XX. Now, Kallmann syndrome, what that does is there is a defective migration of neurons that secrete the GnRH. So if there is no GnRH or if there is low GnRH, then my FSH and LH will not be in the normal range. So if my FSH and LH are not in the normal range, definitely there is going to be a primary amenorrhea, but there is also going to be low estrogen, low progesterone, everything is going to be low. So I am definitely not going to have a Tanner stage 5, right? I am going to have some infantile characteristics. Coming to the two options that we are left with, which is gonadal dysgenesis and Mullerian dysgenesis. Now, gonadal dysgenesis, we have discussed in our class. This results from what we call premature ovarian insufficiency or premature ovarian failure, which is a state of premature menopause. And how do we diagnose it? This is due to a depletion or a lack of ovarian reserve. So this lack of ovarian reserve means a low estrogen, which will stimulate a very, very high FSH. And this FSH has to be at least 25 international units, at least on 2 occasions, 4 weeks apart. So because we have a normal FSH, normal LH, by exclusion, we can say that this lady has Mullerian agenesis, also known as MRKH syndrome. Coming to the next question. A female came in 36 weeks of pregnancy with a BP of 170/100. There was a visual disturbance, headache, and urine protein of 3+. What is the next best step? So what is this lady suffering from? Definitely she has PIH. She has PIH, right? And not only does she have PIH, the urine protein is more than 2+. It's more than equal to 2+. So she also has preeclampsia. She has preeclampsia. But does she have any ordinary preeclampsia? No. Look at her. She has BP in the severe preeclampsia range. What is our BP for severe preeclampsia? So at least our systolic blood pressure has to be more than equal to 160, or my diastolic blood pressure has to be more than equal to 110 mm of Hg. Not just that, she is having blurring of vision. She is having headache. So not only is this severe preeclampsia, this is impending eclampsia. Now, if impending eclampsia means this lady is going to throw a fit very soon, right? We cannot wait for another week. Okay, we will deliver her at term, we will deliver her at 37 weeks. We need to expedite the delivery and we need to give her anti-seizure prophylaxis. So what are we going to do for that? First thing we are going to do is control her BP. So definitely IV labetalol is given in all of the options, right? And we are going to expedite delivery. Now we have 2 options in which we are straight away going for delivery. That is option number A and option number B. right? In the first one, option number A, I see steroids. Steroids is only given if the fetus is less than 34 weeks. This lady is 36 weeks period of gestation, right? And we are not giving her any anti-seizure prophylaxis, right? So the answer will be magnesium sulfate for anti-seizure prophylaxis, IV labetalol for BP control, and expedite delivery. So this has also been discussed in class in detail with regards to what sort of PIH has to be delivered when. Coming to the next question, a female with complaints of abdominal pain and bleeding per vaginum since 2 days. Her LMP was 6 weeks ago, and she has hypotension, tachycardia, and her ultrasound shows fluid filled in pelvis. So this is a woman who is in shock. She is hemodynamically unstable, and whatever options are given to us, barring missed abortion, unless it has started bleeding torrentially, all the three can lead to the woman going in shock. But what is the important thing that is given to us? One is 6 weeks. This is an early gestation. So we are definitely not talking about abruption and placenta previa. And the other important clue that is given to us is the ultrasound shows fluid filled in pelvis. When will we see free fluid in pelvis? That means there has been some bleeding in the intraperitoneal cavity, right? So in case of placenta previa and abruption, the bleeding is going to be outside the body, or at most remain confined to the uterus if, for example, if it is a concealed abruption. So the answer over here, very simple, is a ruptured ectopic pregnancy. So this also has been covered in class with pictures, and we have also talked about what are the other ultrasound features. For example, we will see, ring of fire in the adnexa, right? You will see an adnexal mass, and we will also see a thick ET in the uterus without any gestational sac. Now, next question, IUGR criteria all except. So let me just warn you for all future topics also. I have also discussed this separately in YouTube. IUGR is an AIMS favorite. IUGR is an obstetrician favorite. In fact, so expect IUGR in all your exams. So IUGR criteria are all except AC less than 3rd centile, estimated fetal weight less than 3rd centile, PI more than 95th centile, and absent end diastolic flow. Right now, I could not get what PI, whether they were talking about uterine artery PI or umbilical artery PI. Right. So if I talk about the definition of IUGR, it is a lengthy definition. Again, there is an early sort of FGR, there is a late sort of FGR, and it has been covered in detail in the class. I'm going to do it again when I do a lengthier video description, question description. But what we need to know is that there are certain features that very quickly clinch the diagnosis of FGR, which means a solitary or a single criteria is enough to diagnose FGR, and abdominal circumference or estimated fetal weight less than 3rd centile happens to just clinch the diagnosis. So definitely they will fall under the definition of FGR. The next is AADF. AADF alone. AADF means there is almost no blood flow going to the fetus during the diastolic phase. So this suggests severe placental insufficiency, and this is also FGR. So umbilical artery EDF was given, and uterine artery PI. So first things first, uterine artery PI is not included in the definition of FGR. It is the umbilical artery PI. Umbilical artery PI more than 95th centile will help us move towards the diagnosis of FGR. Why am I saying move towards the diagnosis? Because this criterion by itself is not strong enough to make a diagnosis of FGR. This has to be combined with something else to make it FGR. So an umbilical artery PI of more than 95th centile along with a small baby, not very small, but sufficiently small baby, by which I mean the estimated fetal weight is less than the 10th centile, or the AC is less than the 10th centile. So if these things are present together, that is when we will call it FGR. But by itself, remember, uterine artery PI not included in diagnostic criteria of FGR. And even if it is umbilical artery PI, this will be the most incorrect choice of all, which means the answer is PI more than 95th centile. The rest, all of them suffice by themselves. They are solitary criteria for FGR. Coming to the next question, a female 40 weeks of gestation with prolonged labor, she's getting adequate contractions. So she's getting at least 3 contractions in 10 minutes. This lady is getting 4 in 10 minutes. Fetal head is 3+, right? So it's come quite a bit down. Sagittal suture in line with AP. So this baby is almost pretty much ready for delivery. There is, no malrotation, nothing of that sort. And caput is present. Caput is present, which is understandable because this lady is having prolonged labor, right? So there is a lot of edema and caput is present. Also, there is fetal bradycardia up to 70 beats per minute. Now, what is to be done? And the options are all options of instrumental delivery. Now, first things first, let us think about it in an exam manner. Okay, let's not go in too much into the details of this right now or the logic of this right now, but all given to me are instruments. Now, I know that, and we have covered this in class, that outlet forceps is used when the head is at the perineum, near about +4, +5 station, right? +4, +5 station, right? And then when we talk about the low cavity forceps is used when the head is slightly above, but it has to be lower than +2 station. And finally, we have the mid cavity forceps, which is not used anymore because it leads to a lot of maternal trauma. And that was used when the head was between 0 and +1. So from the station, we already know that we cannot use outlet forceps because it is not at the perineum, and we cannot use mid pelvis forceps because A, we do not use it, right, currently, and B, it is not the correct station. So we are left with low cavity forceps and ventules. Now, the rotation is complete. Right? So if the rotation was incomplete or if the rotation was more than 45 degrees, so instead of being in AP, this is how the head was. So if it is, very rotated, then we prefer to use a ventules. But over here, even the rotation is complete. Now, there are 2 things over here that will help us to know what is best to use. So one is there is a fetal bradycardia. So always remember ventules has a lower success rate. It has a lower success rate than outlet forceps or any other forceps for that matter. So ventules is associated with a lower forceps, with a lower success rate. So this is not a case where, there is just maternal exhaustion or there is prolonged labor that even if we fail to bring out the baby with ventules, we can go for something else. There is fetal bradycardia. We might lose the baby if we waste our time in trial and error, right? So that is number 1. And another thing, remember where we put the ventules? We put the ventules on the flexion point. Where is the flexion point? The flexion point is 3 centimeters in front of the posterior fontanelle. Now tell me, in this lady with prolonged labor, with the presence of a caput, will you be able to find a flexion point? Will this not further decrease your chances of having a successful ventules delivery? Right? So that is why, for that reason, over here, we will not use ventules. What will be used instead? We will use a low cavity or low pelvis forceps. So that is that question. Now, next question is 29-year-old mother, gravida 2 para 1 living 1, delivered a baby, but due to medical issues, the baby died. So for breast engorgement of the lady, or what they mean to say is for lactation suppression, what are we going to give? Right, for lactation suppression, what are we going to give? So lactation suppression, remember, so what cabergoline does. So the typical thing that we use is dopamine agonists, because we know dopamine from our pharma and physiology, we know this blocks prolactin, right? So cabergoline is something that we prefer to use. I could not get the other options, but the reason I want to discuss this for another minute is, in the question, what they have given is, due to some medical issue, the baby died. Now, whose medical issue? Was it some maternal issue? Was it the baby's issue? Because what I want to tell you over here is, cabergoline, remember, is also an ergot derivative. It is also an ergot derivative. Remember methergin? So this is also an ergot derivative, which means it is very, very capable of causing severe vasoconstriction. So if your mother has PIH or if she has chronic hypertension, then we will not give her cabergoline for lactation suppression. So if the mother has PIH or chronic hypertension, we will instead give her tablets of pyridoxine, which is vitamin B6. vitamin B6. In those cases, cabergoline is contraindicated. So I could not get the exact recall of this question, but depending on what the question was, your answer may change, right? Now, the next question is, again, another question where I have gotten, varying recalls. 18 weeks fetus suspected of having neural tube defects, positive, and Down syndrome negative on quadruple marker test. So what this possibly means is the AFP was very high, right? So why I'm saying I'm getting differing recalls on this is some students are saying it was saying neural tube was negative, but Down syndrome was positive. Some were saying both were negative. So in either case, let us just discuss very briefly. Now, one thing that you need to remember is neural tube defects are defects like your spina bifida, right? Or your Arnold-Chiari malformation. These are things you can very easily see on an ultrasound. There is no need of doing an expensive invasive test or an expensive test like NIPT to diagnose your neural tube defect. So if you ever have doubt of neural tube defect, right, what we are going to do is straight away we are going to go for an ultrasound. However, Down syndrome, the features of Down syndrome, you cannot diagnose Down syndrome or Patau's or Edwards on ultrasound. You cannot do that, right? So if the question was Down screen is positive, NTD is negative, then we will go for amniocentesis. Right? Because it is 18 weeks. If it was Down's negative and NTD positive, we will go for our anomaly scan, which we would have done anyway, even if everything was negative. So if it was Down's negative and NTD negative, we would have gone for our routine anomaly scan or level 2. So depending on what the question was, because I was not able to get the exact recall of this, your answer may change, right? So the next question is very simple question, 13-year-old, pelvic pain that is cyclical in nature, and on examination, there is a suprapubic bulge. What is the suprapubic bulge? So we are typically talking about primary amenorrhea. That is due to obstructive lesions. This obstruction is what is causing the cyclical pelvic pain, right? And there is a suprapubic bulge. What is the suprapubic bulge? The suprapubic bulge is your hematometra. It is your hematometra, right? So now your hematometra can be formed in your vaginal septa also, and in your imperforate hymen also, and in your cervical stenosis also. But what is helping us clinch the diagnosis in this case? At the level of the vagina, at the introitus, we are able to see a bluish tense bulging membrane, which means the hymen is bulging, which means this is a case of imperforate hymen. So if there is a transverse vaginal septum, it is not at the level of the introitus necessarily. It can be higher up, it can be at the mid-level also, it can be lower down also. But definitely remember, the septum tends to be thick, whereas the hymen is thin. So the bulging will not be seen in the transverse vaginal septum, even if it is a low septum. And definitely in the case of cervical stenosis, the obstruction will be higher up. And remember, in imperforate hymen, it begins definitely with hematocolpos or blood in the vagina. So initially there is pooling of blood in the vagina, but with increasing obstruction, it also starts inflating the uterus, and that is what leads to the hematometra, right? So this is also something that has been discussed in class, and this is typically the kind of bulge that we see in imperforate hymen. Now, this is also a conceptual question being discussed in detail in the class and also in the separate YouTube session that I have taken, which is there is an Rh negative pregnancy, and the father is Rh positive, and anti-D is given at 28 weeks of gestation. When will the next anti-D be given? And 4 clinical scenarios are given to us. Now, remember, anti-D, the work of anti-D is to prevent isoimmunization. So 2 cases where anti-D will be absolutely useless is when there is no risk of isoimmunization, which means what? When the baby blood group is negative. In that case, even if there is feto-maternal hemorrhage, there is no risk of antibody formation. So isoimmunization, there is no risk. So anti-D is useless, right? So anti-D is useless. And because it is to prevent isoimmunization, it will also be useless if the isoimmunization has already occurred, right? So if the isoimmunization has already occurred, then also anti-D is useless. is useless. So which means what? Which means what? The baby blood group, for me to give anti-D, the baby blood group has to be positive. There has to be a risk of isoimmunization, right? And secondly, there has to be no isoimmunization already, which means the antibody screen or DCT should be negative. DCT should be negative. So the answer over here will be O positive baby and DCT negative. So this is something also we have covered in detail in the class, right? And finally, we have a white purulent discharge from Bartholin's gland, most likely causative organism. Now, the two options that the students remembered were chlamydia and Neisseria, right? But I would like to tell you, these two are actually quite rare when it comes to causing Bartholin's gland. So if anybody is able to tell me what the other options were, that would be very helpful. Remember, the most common organism is E. coli. Although it can be polymicrobial, bacteroides and all of those can cause. But if you are to choose a single organism, the most common is E. coli, followed by staph and group B step. So if you can help me recall the other options, that will be very, very helpful. So DCT is direct Coombs test. It has been discussed in detail in class. Because we are running short of time, I will take a class on it separately. And I also have a YouTube video on RH non-isoimmunized pregnancy, RH negative, ICT negative pregnancy. So if you can just have a look at that, that will be helpful. Otherwise, I'm going to come out with a session very soon, right? And finally, pregnant lady with painful genital lesions gives birth vaginally and baby develops the same lesions. What is the organism? So this is typically, what is this typically? These painful genital lesions are the lesions of HSV2, herpes simplex 2, right? And it is for this reason we have discussed in teratogenic infections of pregnancy that if you have these lesions, so remember in teratogenic infections of pregnancy, rubella was the only one in which the first trimester risk of transmission was the highest. In the rest of them, it was more in the third trimester. And what was interesting in HSV2 was that most of the transmission was occurring during delivery, not so much in utero, but during delivery, right? And that is why it is very important. If there are active herpes genital ulcer lesions, then we have to do a cesarean section. We do not go for a normal delivery. And even though we have antiviral treatment like valacyclovir and acyclovir for treatment of these lesions, right? If there has been active genital herpes in the last 6 weeks and this lady has received treatment, even then we will go for a cesarean section. We will not go for a vaginal delivery due to the risk posed to the fetus. So that is all for the recall of obstetrics and gynecology questions. Thank you. So if I have missed out any questions, or if the framing was not correct, or some options were wrong, just let me know. And very soon I'm going to come up with a detailed analysis and explanation of the questions. So I was short of time here. So that's it for today. Thank you.
Thank you, Shika, for the amazing review of all the questions that have been asked. Students, like she said, like we'll be coming up with a very detailed review soon with all the explanations and the proper stem of the questions. Thank you once again. So next we have Dr. Siraj Ahmed for recall of pharmacology. Over to you, sir.
All right. Thank you, sir. I hope I'm clearly audible and visible to all the students. Let me take up your comments as well. Okay, great. So we got roughly around 19 to 20 questions in pharmacology, and let us see what all question that we got. And most of you have already got your answers, I believe, but let me see my perspective and the perspective from Goodman and Gilman. Now, this was one of the very, very easy question. Which of the following antidyslipidemic drug act by decreases LDL by inhibiting PCSK9? Or in a simple term, examiner simply asks, which of the following is one of the PCSK9 inhibitor? PCSK9 inhibitor, I told you that the two drugs that we are having, 𝐒𝐿-𝐴 and other one is known as your 𝐒𝐿-𝐴 and 𝐒𝐿-𝐴. So I used to tell you that there is a person by the name of Ali. Ali actually evolved as a PCS. Ali is evolved as a PCS. And there is one more, that is inclisiran, that is the newer one.
inclisiran, that's the newer one. But as of now, just remember Ali is evolved as a PCS, and here we have the answer, that is evolocumab. Other option, lomitapide, which is one of the MTP inhibitor. Ezetimibe is an easy peasy drug, and when I say easy peasy drug, what do I mean? Easy peasy, their mechanism of action is easy. That means they are simply going to inhibit the absorption of cholesterol by inhibiting your NPC1L1, right? And by inhibiting this NPC1L1, they actually inhibit the cholesterol absorption. So their mechanism of action is very, very easy peasy, right? Bempedoic acid is one of the ACL1 inhibitor, and they also inhibit the cholesterol formation. For this given question, Ali is evolved as a PCS, is a very simple mnemonic to remember. Remember, this is one of the PCSK9 inhibitor, proprotein convertase subtilisin caxine type 9 inhibitor, right? Now, this was a very easy question. We have discussed this a number of times. Now, this was one of the most controversial questions that many of the students have given, and I have tried to clarify, clarified from many students whether there was any not or whether there was any except. Many of the students, they frankly first-hand denied, sir, there was no not, there was no except, because for this question, HER1 inhibitor will be 3 drugs, that is going to be your cetuximab, necitumumab, and also your panitumumab. These are the HER1 inhibitor. HER1 inhibitor. Other name of this HER1 inhibitor is also your epithelial growth factor receptor inhibitor, EGFR inhibitor. And these agents are mainly going to be utilized in a head and neck cancer. Head and neck cancer may we can actually utilize, and in addition to that, we can also utilize them for colorectal carcinoma. Colorectal carcinoma, head and neck cancer, दोनों के लिए हम utilize कर सकते हैं. So this was the question. I believe all of you guys have seen and got confused with this one. Even we are also shocked. If any of the student could remember, was there any not or except in this one? Because pertuzumab is the one. Pertuzumab is one of the drug that we are having here. That is your HER2 new inhibitor. HER2 new inhibitor. Pertuzumab is one of the HER2 new inhibitor. राइट तो HER1 इनहिबिटर और HER2 का ही दूसरा नाम है न्यू इनहिबिटर. सो HER2 न्यू इनहिबिटर विल बी pertuzumab. सो इसमें मैं बोलता हूँ कैसे याद कर लो. देयर इज अ गर्ल बाय द नेम ऑफ मार्जी, राइट? मार्जी पर ट्रस्ट करना है आपको. मार्जी पर ट्रस्ट, राइट? मार्जी वाज द नेम ऑफ द गर्ल जिसको ब्रेस्ट कैंसर हुआ, एंड मार्जी पर ट्रस्ट करना है. तो मार्जी टुक्सीमैब इज अ न्यूअर ड्रग दैट गॉट अप्रूव्ड इन ईयर 2020 itself, already included in our Goodman-Gilman 14th edition. Then we are also having pertuzumab and trastuzumab तो हम पढ़ते आ रहे हैं, बट एक और ड्रग मैं ऐड कर रहा हूँ यहाँ पे. तो 3 ड्रग का नाम देख लीजिएगा. तो मैंने बोला ब्रेस्ट कैंसर होगा तो मार्जी पर ट्रस्ट करना है. मार्जी पर ट्रस्ट. दीज आर द HER2 न्यू इनहिबिटर. ठीक है. सो इन दिस वन आई थिंक मैं किसी भी क्वेश्चन को इस पे जवाब देने से आई विल रिफ्रेन, बिकॉज इफ इट इज मल्टीपल आंसर देन द करेक्ट आंसर फॉर दिस वन इज गोइंग टू बी योर A, C and D. They are the one that is going to be your HER1 inhibitor or EGFR inhibitor. अगर इसमें नॉट था या एक्सेप्ट था तो प्लीज टेल मी. अदर देन दैट, या इफ देयर इज सम अथॉरिटी, और अगर इसका कोई प्रावधान है that you can get your question checked once again, you can even write about this one, because 3 options are HER1. अगर आप श्योर हैं HER1 था तो you can write it down, and this question can definitely go under scrutiny. Which of the following anti-leprosy drug causes skin hyperpigmentation? I think ये क्वेश्चन आपके डर्मा फैकल्टी ने भी दिया होगा, और अदर सब्जेक्ट फैकल्टी लाइक PSM में भी कई बार इसको लोग डिस्कस कर लेते हैं. सो कलरेशन कर देता है. तो मैं बोलता हूँ लेप्रोसी में जो कलर कर देता है दैट इज क्लोफेजिमिन. सो यूजुअली यू कैन से सर रिफाम्पिसिन भी तो कलर करेगा. यस, दे कैन लीड टू बॉडी सिक्रीशन डिस्कलरेशन. Yes, they can also lead to, if the person is wearing intraocular lens, तो lens का भी discoloration कर देगा. But clofazimine is one of the anti-leprosy that is causing skin discoloration. It can also lead to skin. It can lead to skin, and it can also lead to your eye का discoloration. तो कलर कर देता है, दैट इज नोन एज क्लोफेजिमिन. एंड आई ऑलवेज यूज्ड टू से, बार बार मैं क्लास में बोलता हूँ कि कभी भी रिफाम्पिसिन जब भी आता है एंटी ट्यूबरकुलर ड्रग या एंटी लेप्रोटिक ड्रग, स्टूडेंट्स ऑलवेज लुक फॉर रिफाम्पिसिन. और रिफाम्पिसिन नहीं ऑप्शन में तो मैं बोलता हूँ लुक फॉर क्लोफेजिमिन. और अगर टीबी की बात करें, इफ देयर एग्जामिनर इज आस्किंग अबाउट टीबी एंड रिफाम्पिसिन इज आल्सो नॉट देयर, देन लुक फॉर वन मोर, दैट इज उसके नाम में ही है, स्टेन का नाम आता है पास. दे आर आल्सो एसोसिएटेड विद बॉडी सिक्रीशन डिस्कलरेशन. ठीक है, बॉडी सिक्रीशन डिस्कलरेशन पास कैन आल्सो बी कॉजिंग. सो Why am I discussing all this topic? Because इसी topic से next potential MCQ बनते हैं आपके upcoming examination के लिए. Undoubtedly, dapsone is one of the drug of choice for leprosy, but they are not associated with their hyperpigmentation. Rifampicin can be used in leprosy, there is no doubt, but they are causing body secretion discoloration. Ofloxacin is one of the fluoroquinolone. It's a highly cidal drug, can be used in leprosy, can cause other problems like, let's say, nausea, vomiting, diarrhea. It can lead to photosensitivity. It can lead to photosensitivity. It can lead to tendinitis, arthropathy, and tendon rupture. Tendinitis and tendon rupture and arthropathy. So all these kind of side effects can be seen, but not this body secretion discoloration. So clofazimine is the correct one for a question like this. Now, patient with a whitish productive cough, which of the following is the management? तो मैं अगर patient को productive cough हो रहा है, आपको पता ही है, तो उस condition में we will be using drug either those who can increase the mucus secretion, या तो म्यूकस सिक्रेशन को बढ़ा देगा, बिकॉज ऑफ द इंक्रीजिंग द म्यूकस सिक्रेशन में भी द म्यूकस विल बिकम थिक, और यू आर गोइंग टू यूज अ ड्रग दैट इज गोइंग टू हैव अ म्यूकोलिटिक प्रॉपर्टी, right? Mucolytic properties. Among the given choices, the only one which is having mucolytic property is going to be a bromhexine. Dextromethorphan, guys, it's a drug that is going to suppress the medullary cough center, and they will be utilized mainly in the dry anti-tussive agent. For a dry cough, they are mainly going to be utilized as an anti-tussive agent. Likewise, same goes for codeine. So dextromethorphan जहां पे भी है उसको तो नहीं देंगे, because they are anti-tussive agent and they are going to suppress the medullary cough center. So in this question like this, remember bromhexine is the only one that can be used for the productive cough. This is a quick summary. I used to tell you mucolytic drug. Expectorant करना है तो दो तरीके से कर सकते हो. Mucolytic, the mucous fibers should be broken down with the help of ABC drug. ABC stand for ambroxol acetylcysteine. Actually acetylcysteine को हम बोलते हैं N-acetylcysteine. Acetylcysteine और N-acetylcysteine, bromhexine और carbocysteine. So ABC हो गया, I think is बड़ा आसान है. Then secretion enhancer will be sodium citrate, potassium citrate, and potassium iodide, ammonium chloride, and guaifenesin. These are the secretion enhancer, and they will ease down the expectoration. इसलिए हम इन drugs को use करेंगे productive cough में. A patient presented with the shortness of breath on lying down. BP high है, ejection fraction is 50% of the normal. At any point of time, if you guys feel कि question में थोड़ा alteration है या language needs to be refined, please feel free to answer, because we have taken a good amount of feedback from a lot of students to come up with the finest version of these questions. Altered echo texture, portal vein mildly dilated, HbA1c okay, HbA1c level बढ़ा हुआ है, and heart failure के symptom आ रहे हैं. Simple है, heart failure का symptom आ रहा है because again there is a congestion everywhere, including the liver as well. Which of the following drug should be preferred? So remember, diabetic agent, anti-diabetic agent in a heart failure patients. The preferred one is always going to be one of the SGLT2 inhibitor. So empagliflozin, dapagliflozin, they are the one that is going to be preferred. They are the one that is going to be the preferred agent. लेकिन उसके साथ ब्लैक कैम, उसके साथ एक ड्राई कफ का भी है. तो आप एक पेशेंट में ड्राई कफ और वेट कफ दोनों का ड्रग कॉम्बिनेशन कैसे दोगे डॉक्टर? ये तो वही बात है कि आप किसी पेशेंट को हाइपरटेंशन ट्रीट करना चाहते हो, एंड यू आर गोइंग टू गिव ड्रग दैट इज गोइंग टू इंक्रीज द हाइपरटेंशन आल्सो एंड एंटी हाइपरटेंसिव ड्रग आल्सो. तो वो तो अगेन है ना, दैट इज नॉट गोइंग टू बी feasible for the patient, right? So SGLT2 inhibitor is something that can be utilized as an anti-diabetic agent that is also effective for your heart failure patient, right? Other options like metformin, of course, it's a drug of choice. Pramlintide, it's one of the amylin analog, can be utilized in type 1, type 2 diabetes mellitus, and they are not approved to be utilized in a heart failure patient. So correct answer for this one is going to be B, that is dapagliflozin, that is one of the SGLT2 inhibitor. Now, next time the examiner can frame a question like this: which anti-diabetic agent is going to be contraindicated in heart failure patients? So उस condition में मैं हमेशा बोलता हूँ, याद रखिएगा, the drugs that is going to be your pioglitazone. So glitazone is one of the drug that is actually going to be associated with your sodium and water retention. They actually cause lots and lots of sodium and water retention in a patient with a congestive heart failure. Already there is a lot of congestion. How can you actually increase congestion by giving a drug that is further increasing the sodium and water retention? So we are not going to give this one. ठीक है? हाँ, आरती सुधर, that's what I told you, no डॉक्टर. अगर आपके पास ये ऑप्शन में है कि एक म्यूकोलिटिक और साथ में डेक्स्ट्रोमेथोर्फैन, तो डेक्स्ट्रोमेथोर्फैन इज एंटी-टूसिव, नो, तो उसको साथ में नहीं कैसे देंगे? अगर सिर्फ एलोन ऑप्शन ब्रोमहेक्सिन में था तो दैट इज गोइंग टू बी द प्रिफर्ड वन. Okay, now next question. This was also one of the questions that confused many of the students. In a patient with the enterococcal infective endocarditis who is allergic to penicillin. Now, as soon as you hear the term allergic to penicillin, patient allergic to penicillin, what is the preferred antibiotic? What is the preferred antibiotic? So we usually jump down to एक drug जिसको बोलते हैं macrolide. Drugs like your erythromycin, azithromycin, any of the macrolide we can actually utilize. अगर ये नहीं है, then we actually also jump for the next one that we call it as a astronam, which is one of the monobactam. Astronam, which is one of the monobactam. Now look at this question here. The patient is having enterococcal infective endocarditis, which is one of the gram-positive organism. Remember, astronam, it is not effective for anaerobes. It is not effective for anaerobes. It is also not effective for gram-positive organism. Now, because the patient is already allergic to one type of beta-lactam, he is likely to be allergic to other type of beta-lactam as well. We call this phenomenon as a cross allergy, right? And in this, ceftriaxone is one of the cephalosporin. It's one of the beta-lactam. Piperacillin is penicillin, and astronam मैंने बता दिया we are not using because of the reason that they are not effective for your gram-positive. So the only option that we are left with is vancomycin. In fact, Goodman-Gilman clearly mentioned that it can be utilized in this patient who is having allergy or hypersensitivity to penicillin, vancomycin. Clear line directly from Goodman-Gilman as well. So in this patient, in this case, I'll go ahead with the vancomycin. Which of the following anticoagulants need therapeutic drug monitoring? Now, therapeutic drug monitoring often is going to be required mainly with the injectable anticoagulants. Injectable anticoagulants, which actually require therapeutic drug monitoring, is actually going to be your unfractionated heparin. Right? Unfractionated heparin actually is considered as the indirect thrombin inhibitor. Indirect thrombin inhibitor. Yeah, indirect 10A inhibitor. They are indirect because thrombin or 10A दोनों को inhibit करते हैं. In addition to this, we also have a direct thrombin inhibitor. This direct 2 inhibitor, they may also require monitoring, and the name of these drugs are going to be drugs like your hirudin, lepirudin. There are other agents as well like bivalirudin. Now you might be wondering, ki, sir, isme we also have a drug that is dabigatran. Dabigatran, remember guys, इसके बारे में बार-बार पढ़ते हैं, दवा के दारू वाला. So इसके overdose में we give idarucizumab, and reason being we are not monitoring this one because they are orally effective. Orally effective, their therapeutic index is also very wide. So among the given choices, enoxaparin. What is enoxaparin? They are one of the low molecular weight heparin. Perin के जैसा है. Fondaparinux, they are actually like a perin but targeting only X. So they are ultra low molecular weight heparin, that targets only X. Fondaparinux, idraparinux, they target only X. Only X मतलब target only 10A. Only 10A को सिर्फ target करते हैं ये fondaparinux. They are from the low molecular weight heparin only. They do not require monitoring. But अगर मैं देखूं lepirudin, so they are the injectable. मैंने बोला आपको injectable वाले जितने भी होंगे we may require. In addition to that, ऐसा नहीं है कि सिर्फ injectable का requirement है. We require monitoring of the warfarin as well, है ना? Among the given choices, since warfarin is not there, neither heparin is there, we will go ahead with the lepirudin, right? अगर APTT से monitoring करना है तो of course इसकी monitoring चाहे वो heparin हो बच्चे, चाहे वो heparin हो या direct. Heparin is, what is heparin? It is one of the indirect thrombin inhibitor. Or we are also having lepirudin, bivalirudin. What are they? They are actually direct thrombin inhibitor. So in दोनों की ही monitoring we will be doing with the APTT. However, अगर warfarin होता तो PT-INR से monitoring करते. All right. So I hope these questions that whatever we are discussing is the closest to the actual question that was asked in your examination. At any point of time, if you feel there is any left and right, please feel free to message in the comment section. Now, this was one question, which of the following is false about voriconazole? Many of the students have got this question, and many of the students are having a lot of worry. This question is directly taken from Goodman-Gilman. An examiner deliberately made this question to make sure that you guys are actually going to make this wrong. Now, please tell me whether these options are correct or not. It should be combined with a pyrazinamide. Pyrazinamide is one of the first-line anti-tubercular drug. It should be taken on empty stomach. Loading dose should be given. Therapeutic drug monitoring should be done. Please tell me if this question was asked and the options were same. The student, those who are watching me, definitely you guys have given the examination. आप हमें आंसर मत बताइए, आप पहले ये बताइए क्या ये क्वेश्चन आया था कि नहीं आया था, डॉक्टर अब्दुल्ला एंड एनी अदर स्टूडेंट, क्या ये ऑप्शन सही है? I'll rule out each of the option from the textbook itself. Student, those who are listening to us, exactly same आया था, ठीक है. Now listen to me very very carefully. According to Goodman-Gilman, this drugs, इसका ये वोरिकोनाजोल एक स्पेसिफिक ड्रग है कंपेयर टू अदर एजोल्स. इसके साथ थोड़ा सा चेंजेस ये है कि देयर बायोअवेलेबिलिटी इज एक्चुअली अल्टर्ड विद द मील. तो इसको खाने से 1 घंटा पहले देते हैं या खाने के 1 घंटा बाद देते हैं. कौन बोलता है ये टेक्स्ट बुक बोलता है. मैं टेक्स्ट बुक की लाइन को कोट कर रहा हूँ आपके सामने. आई वॉन्ट ईच वन ऑफ यू गाइज टू रीड दिस वेरी वेरी केयरफुली. लुक एट दिस व्हाट द टेक्स्ट बुक इज सेइंग. बिकॉज हाई फैट मीन्स रिड्यूस वोरिकोनाजोल का बायो अवेलेबिलिटी, ओरल ड्रग शुड बी गिवन आइदर 1 आवर बिफोर. 1 घंटे पहले दीजिए खाने के. ठीक है, तो आई थिंक एक ऑप्शन तो रूल आउट हो गया. अब आते हैं अगले वाले पे, थेराप्यूटिक ड्रग मॉनिटरिंग, जैसे कि डॉक्टर वसीम ने बोला था. अब देखिए क्या बोला है कि थेराप्यूटिक ड्रग मॉनिटरिंग इज फ्रीक्वेंटली यूज. ये नहीं बोला rarely use, frequently use with the target serum concentration 1 to 5. So they also are having narrow therapeutic index. So with this class of drug, therapeutic drug monitoring is required. So INICET है, क्वेश्चन इतना आसानी से नहीं देगा. ठीक है, so remember this one. Monitoring is particularly important for pediatric population who have very unpredictable plasma level of voriconazole. So again ये ऑप्शन भी रूल आउट हो गया. फिर एक और ऑप्शन आता है आपका कि वेदर लोडिंग डोज रिक्वायर्ड होगा कि नहीं होगा. Now ध्यान दीजिएगा, ट्रीटमेंट यूजुअली इनिशिएटेड विद द IV इन्फ्यूजन ऑफ लोडिंग डोज. सो पहले 2 दिन बोलता है कि 6 mg पर kg के हिसाब से, पहले 2 डोज, नॉट 2 दिन, नॉट 2 डेज, 2 डोजेस. सो फर्स्ट ऑलवेज रिमेंबर, लोडिंग डोज का आधा होता है ऑलमोस्ट मेंटेनेंस डोज. सो फर्स्ट 2 डोज 6 mg पर kg फॉलोड बाय 3 mg पर kg एवरी 12 आवर्स. तो क्या लोडिंग डोज देंगे? आप ध्यान से देखिए ना, टेक्स्ट बुक की लाइन से क्वेश्चन उठाया जाता है, ध्यान से देखिएगा. तो लोडिंग डोज देंगे, हाँ जी देंगे. क्या खाने से पहले देंगे? बिल्कुल खाने से पहले देंगे. क्या थेराप्यूटिक ड्रग मॉनिटरिंग रिक्वायर्ड है? वोरिकोनाजोल के साथ रिक्वायर्ड है, हाँ जी. वोरिकोनाजोल इज अ ड्रग विच इज कंसिडर्ड एज अ ड्रग ऑफ चॉइस इन अ पेशेंट विद एस्परजिलोसिस. इट्स अ ड्रग ऑफ चॉइस फॉर एस्परजिलोसिस. अगर एस्परजिलोसिस इससे रेस्पॉन्ड नहीं करता है, देन वी कैन एक्चुअली गो फॉर योर एम्फोटेरिसिन बी, अनडाउटेडली एम्फोटेरिसिन बी. ठीक है, इट शुड बी कंबाइंड विद पायराजिनामाइड. सी, पायराजिनामाइड का एंजाइम इंडक्शन प्रॉपर्टी नहीं है. देयर इज नो सच कंपल्शन कि आप एंटी ट्यूबरकुलर के एंटी फंगल के साथ ऐड करो. तो अगर मैं बोलूं रूल ऑफ एक्सक्लूजन यूज करो, तो आपके सामने मैंने इन तीनों ऑप्शंस को रूल आउट कर दिया. आई हैव रूल्ड आउट डायरेक्टली फ्रॉम द लाइन ऑफ द टेक्स्ट बुक. सो अब आप खुद सोच के बताइए ना, व्हाई विल यू कंबाइन एंटी ट्यूबरकुलर ड्रग विद एंटी फंगल ड्रग until unless the patient does not have. अगर पेशेंट के पास टीबी है तो डेफिनेटली हम तो सारे ड्रग यूज करेंगे, बट बोला इट शुड बी कंबाइंड विद पैराजिनामाइड. नो, नॉट रिक्वायर्ड, not required, not required. ठीक है, so I hope it is making sense to all of you guys कि how examiner smartly have placed some of the important options. ठीक है, तो ये डायरेक्टली गुडमैन गिलमैन से आप चेक कर सकते हैं. Now cannabinoids are not used in which of the following scenario? Cannabinoids are not utilized in which of the following scenario? Now among the given choices, I think this was very straightforward. Rett syndrome पिछले एग्जाम में पूछा हुआ था, which drug is the only approved drug? So ध्यान रखिएगा, इसके लिए the only drug that we are having is known as your trofinetide. Trofinetide is the only agent that is the FDA approved drug for the Rett syndrome. Now cannabinoids as a drug has been tried and has been utilized in certain epileptic condition like Lennox-Gastaut syndrome, tuberous sclerosis associated with infantile spasm, Dravet syndrome. Dravet syndrome में भी हम cannabinoids को utilize किए हैं and it has been utilized. So किस में नहीं यूज करेंगे? तो Rett syndrome में इसका कोई रोल नहीं है. Neither it has been studied, neither it has been mentioned in the textbook as well. Which of the following is a known side effect of intermittent teriparatide? Now teriparatide is one of the drug that is known as your recombinant parathyroid hormone analog. Recombinant parathyroid hormone analog. We are having drugs like your teriparatide. We are having drug like your teriparatide. We are also having drug like your abaloparatide. Teriparatide and abaloparatide. So नाम में ही paratide, parathyroid जैसा आ रहा है. Because it's a parathyroid hormone, we cannot give them in a high dose. We always use them in the intermittent dosing. Intermittent and low dosing. Intermittent and low dosing हम हमेशा करते हैं. और उसके साथ एक साइड इफेक्ट, यूजुअली ये इंजेक्टेबल देते हैं 20 माइक्रोग्राम इंजेक्टेबल देते हैं, पेरी एम्बिलिकल एरिया में देते हैं, या हम ऑन द लेटरल एस्पेक्ट ऑफ द थाई सबक्यूटेनियस इसको हम देते हैं इंजेक्टेबल, है ना, फॉर अप टू 2 years only. Beyond 2 years we do not give because they are the anabolic drug, they are the bone anabolic drug. So in one of the previous examination they have asked which of the following anabolic agent that can be used in the treatment of your osteoporosis. तो in this case scenario इसके साथ इंजेक्शन साइट रिएक्शन एक साइड इफेक्ट होता है, मेनली इंजेक्शन साइट रिएक्शन, myalgia, injection site reaction, myalgia, and in some animal models they have been shown to increase the risk of osteosarcoma. इसीलिए if there is any patient with the history of osteosarcoma or increase in the risk of osteosarcoma, हम usually इसको नहीं देते हैं. Which of the following is the known side effect? तो osteosarcoma has been reported in the animal model. Right, they do not cause subtrochanteric mandibular. Mandibular osteonecrosis by बहुत सारे बच्चे कंफ्यूज हुए. बच्चे ये जो साइड इफेक्ट होता है ये किसका होता है? This is going to be the side effect of your bisphosphonate. Side effect of your bisphosphonate. Like risedronate, alendronate, इन सब के side effect होते हैं. They are the side effect of your bisphosphonates. ठीक है? So this is again from Goodman-Gilman. You can see should not be used in patients who are increased baseline risk for the osteosarcoma. अगर osteosarcoma है तो we should not be using recombinant parathyroid hormone analog, that is teriparatide. Teriparatide or abaloparatide should not be utilized. ठीक है? Anti-diabetic drug causing unexplained persistent diarrhea. Unexplained persistent diarrhea, again among the given choices, we are having sitagliptin. We are having sitagliptin, that is one of the DPP4 inhibitor, metformin. Metformin is the one that fits the choice most here among the given choices, because others like glimepiride, it is one of the second generation sulfonylurea, and glimepiride is associated usually with the side effect. Among this one, the side effect of glimepiride is going to be most common side effect is always going to be hypoglycemia. Hypoglycemia, bone marrow suppression, agranulocytosis. These are the important side effects that has been associated with them. They are also associated with your hepatotoxicity. But the one that is actually causing persistent diarrhea, metformin, has been associated with this one. Apart from this, metformin के साथ जो other side effect noted किए गए, they actually decrease the vitamin B12 absorption, and that can actually lead to a problem known as your megaloblastic anemia and peripheral neuropathy. Right? Lactic acidosis has been a dangerous side effect that has also been reported. Okay. Pioglitazone, I told you already, they are causing sodium and water retention, and they can also lead to macular edema, cystoid macular edema, and they can also lead to sodium and water retention. Sodium and water retention, that is another side effect noted with them. Okay. Gliptins are the DPP4 inhibitor. They are associated with your URTI, upper respiratory tract infection, nasopharyngitis word कई बार use करते हैं उसके लिए, nasopharyngitis, headache. These are the kind of side effects. So among the given choices, the one that fits the best is going to be metformin. Which of the following anti-diabetic agent causing UTI? Now, was this question asked or not? I was not very sure, but many students have mentioned that yes, sir, it was asked in our groups as well. Many of the students were mentioning, sir, anti-diabetic causing UTI. So I think ये question तो कई बार आ चुका ना, that all the SGLT2 inhibitor drugs like your canagliflozin, dapagliflozin, जिसके नाम में gliflozin आए, they can lead to side effect like UTI, है ना, dapagliflozin वगैरह वगैरह वगैरह. Okay. So their important side effect, if I just quickly summarize the important side effect, remember, which could be the potential MCQ, the most common side effect is UTI. Sometimes they use the term vulvovaginitis for the female patient. Vulvovaginitis for the female patient. Apart from that, they can also lead to other side effect called your Fournier's gangrene. Fournier's gangrene. They also are associated with your weight loss, euglycemic ketoacidosis. So these are going to be the potential MCQ. Earlier, it was believed that actually they are associated with your increasing the risk of fracture, but this claim has now been denied. This claim has now been denied. The recent Goodman-Gilman says clearly that although canagliflozin has been associated, canagliflozin although previously has been associated with increasing the risk of fracture, but now this claim has been denied. However, they increase the risk of amputation, wo baat to hai, but they are actually not increasing the risk of fracture. Amputation ke risk ko badha rahe hain, okay, agreed, but they're not increasing. This is again going to be the next potential MCQ for all of you guys. So among the given choices, anti-diabetic drug causing UTI, I think other side effects मैं rule out कर चुका हूँ. So the only one that is left here is going to be your dapagliflozin, which is one of the SGLT2 inhibitor. This was a straightforward and very easy question. Now again, ये heart failure वाला case है. This already has been covered in one of the previous one. Anti-diabetic drug in heart failure patient is going to be your SGLT2 inhibitor. ये question already previously हो चुका है. So this is just another version of the same. पिछले वर्जन में क्या था कि उसका थोड़े हेपाटोमेगाली भी था वगैरह वगैरह, है ना, तो विच एंटी डायबिटिक ड्रग विल बी यूटिलाइज. सो उसी का ये अदर वर्जन है. तो अगेन SGLT2 inhibitor, एंटी डायबिटिक ड्रग इन हार्ट फेलियर. Now, this was the question also. I'm not sure whether this question was in the same frame or it was in a little different frame. Which of the following is correct regarding diuretics and its site of action? Please correct me at any point of time. है ना, कि इसका what is the correct form of this question? Was it something like this? Carbonic anhydrase inhibitor at the PCT, right? Thiazides acting. Thiazides का actual site of action क्या होता है? They are mainly going not collecting duct, distal collecting tubule, DCT. Distal collecting tubule, early part of DCT. Mannitol will be acting at the PCT and mainly loop of Henle. इसी order में PCT and loop of Henle पे. Spironolactone is one of the potassium sparing diuretic. They are mainly going to act at the collecting duct. So carbonic anhydrase is the only one that is acting at the proximal convoluted tubule. And in the review class, just I think 2-3 days ago prior to the examination, I told you that we have a review class. 4 hours का रिव्यू क्लास था, उससे अराउंड आई थिंक 12-13 क्वेश्चन डायरेक्टली उस 4 घंटे के रिव्यू क्लास से आए हैं. और ये दिस इज आल्सो वन ऑफ द क्वेश्चन फ्रॉम द सेम प्लेस. यू कैन चेक इट आउट, है ना. तो अगेन, विच ऑफ द फॉलोइंग इज करेक्ट रिगार्डिंग द डायरेटिक्स एंड इट्स साइट ऑफ एक्शन? तो दिस वाज अ वेरी इजी पीजी क्वेश्चन. यू कैन कंसीडर दिस एज अ फिजियोलॉजी क्वेश्चन, एज अ फार्मा क्वेश्चन. इट हार्डली मैटर्स. Now, which of the following agent is used to rapidly reverse? Now, this was also a question that was troubling many students. This was a very easy peasy question. Rapidly reversing the action of rocuronium, right? So, आपको याद है मैंने बताया था कि वीरू को rapidly सही करना है. वीरू को rapidly सही करना है तो हमें सुगम को बुलाना पड़ेगा, सुगामाडेक्स. So, rapidly वीरू is stand for your vacuronium. तो इन दोनों के लिए rapid है ना, इनके एक्शन को रैपिडली एंटागनाइज करने के लिए, बिकॉज व्हाट विल दिस सुगामाडेक्स डज, इट इज एक्चुअली गोइंग टू एक्ट एज अ केमिकल एंटागनिस्ट. अब आप बोलोगे सर ये केमिकल एंटागनिस्ट क्या है? तो दिस केमिकल एंटागनिस्ट दैट वी नो, इट इज गोइंग टू बाइंड विद द वैक्यूरोनियम एंड रॉक्यूरोनियम, इनएक्टिवेट, बाइंड करेगा, इनएक्टिवेट करेगा, एंड इट इज गोइंग टू प्रोमोट इट्स एक्सक्रीशन, तो आप इसको एनेस्थीसिया क्वेश्चन मानना चाहते हो मान लो, है ना. बट फार्मा में भी वी यूज्ड टू डिस्कस व्हिच ऑफ द फॉलोइंग एजेंट रैपिडली रिवर्सेस. तो मैंने बोला वीरू के लिए वैक्यूरोनियम एंड रोक्यूरोनियम, इन दोनों के लिए हमें सुगम को बुलाना पड़ेगा. वी नीड टू कॉल सुगामाडेक्स. तो अगेन इसमें एक ही ऑप्शन है, बाकी अदर ऑप्शन अगर आपको याद आ रहा है तो यू गाइस कैन लेट मी नो, आई कैन जस्ट एडिट ऑन, बट द आंसर विल बी सुगामाडेक्स. रैपिडली वर्ड अगर दे दिया है या वेरी फास्टेस्ट वर्ड दिया हुआ है तो अगेन द आंसर विल रिमेन द सेम, दैट इज गोइंग टू बी योर सुगामाडेक्स. इनहेलेशनल नाइट्रिक ऑक्साइड, अगेन पल्मोनरी आर्टरी हाइपरटेंशन, प्राइमरी पल्मोनरी हाइपरटेंशन का ये प्रिफर्ड ड्रग है. ये क्वेश्चन भी आया हुआ था. एंड नेक्स्ट अपकमिंग एग्जामिनेशन में आई विल बी मेकिंग अ सेपरेट वीडियो फॉर पल्मोनरी हाइपरटेंशन. तो अपकमिंग एग्जामिनेशन में आपके लिए आएगा ड्रग ऑफ चॉइस. ड्रग ऑफ चॉइस क्या होगा, किस पर्पस के लिए? फॉर द पल्मोनरी आर्टरी हाइपरटेंशन द ड्रग ऑफ चॉइस इज ऑलवेज गोइंग टू बी योर एंडोथेलिन रिसेप्टर एंटागोनिस्ट. सो इसके ऊपर एक सेपरेट वीडियो मैं बनाऊंगा अंडर इन द सेम आपके जो PW का YouTube चैनल है, आप उसको देख सकते हैं. आपके आने वाले नीट पीजी के लिए एक क्वेश्चन डेफिनेटली पल्मोनरी आर्टरी हाइपरटेंशन पे देख लीजिएगा आप. एंडोथेलिन रिसेप्टर एंटागोनिस्ट ड्रग्स लाइक योर एम्ब्रिसेंथान, बोसेंथान, राइट, एम्ब्रिसेंथान, बोसेंथान, मैसीथेंथान, दे आर द एंडोथेलिन एंटागोनिस्ट. थोड़ा समय की कमी है इसलिए वी आर रनिंग, बट अगेन एक बार हम जब टॉपिक को पकड़ते हैं ना, तो टॉपिक को वी डिस्कस लाइक दिस दैट यू आर नेवर गोइंग टू फॉरगेट दैट टॉपिक. सो एज ऑफ नाउ जस्ट रिमेंबर इनहेल्ड नाइट्रिक ऑक्साइड, सिंस ये रिकॉल है आपको जल्दी से खत्म भी करना है, तो इसलिए we'll just quickly finish it. Now, this was a question again that was very confusing. Which of the following is suicide inhibitor? Many students have given many type of option. कुछ बोल रहे हैं सर ये ऑप्शन था ही नहीं, कुछ बोल रहे हैं सर ऑप्शन था. Now, suicide inhibitor पे जो क्वेश्चन आया हुआ था, let me tell you suicide inhibitor होते क्या हैं. Suicide inhibitor are something like your irreversible inhibitor. एक बार इनहिबिट करके they will be out, but the action may remain longer. एक बार ना इनहिबिट करके दे विल बी आउट बट द एक्शन मे रिमेन लॉन्गर. प्लीज कंफर्म वेदर दिस ऑप्शन वाज इन दिस फॉर्म: रिडोनावीर, बेंजोथायाजीन, स्पाइरिनोलैक्टोन व्हिच इज अ पोटेशियम स्पेयरिंग डायरेटिक, एथिनील एस्ट्राडायोल दैट इज E2, द मोस्ट पोटेंट एस्ट्रोजन, potent estrogen. The potent one is ethinyl estradiol. This question, was it in this frame? And अगर इसमें कोई भी confusion है तो suicide inhibitor के these are the important suicide inhibitor that has been given in the textbook. Goodman-Gilman पे जहाँ कहीं भी suicide inhibitor का discussion है, we have discussed about this. I mean, I have just made a summary of this one. Xanthine oxidase inhibitor, they have shown to have suicide inhibiting property. Drugs like your allopurinol, drugs like your febuxostat. So I'm just quickly giving you a summary of this one. Your 5-fluorouracil, that is one of the thymidylate synthase inhibitor. GROMA, it stands for your guanethidine. GROMA stands for your guanethidine. GROMA stands for your reserpine. O for your omeprazole. Then your MAO inhibitor like, salicyline, rasagiline, safinamide, MAO inhibitor, and A stands for your aspirin. All these are also suicide inhibitor. Beta-lactamase inhibitor, drugs like your clavulanic acid. Drugs like your clavulanic acid, they are the beta-lactamase inhibitor. Clavulanic acid, avibactam, sulbactam. So ये जितने भी हैं, avibactam, sulbactam, all these are actually showing your suicide inhibiting properties. Zirobudine is one of the nucleoside reverse transcriptase inhibitor. Exmestane is one of the steroidal aromatase inhibitor. They are also having suicidal inhibiting property. Vigabatrin is one of the GABA transaminase inhibiting GABA transaminase inhibitor, anti-epileptic drug. And eflornithine, that is one of the ornithine decarboxylase inhibitor. Ornithine decarboxylase inhibitor. So these are the example of suicide inhibitor. And if you guys will help me out about the option what was asked in suicide inhibitor, and among the given choices, if they are going to ask you which one is the suicide inhibiting property, so I'll be going ahead with the benzothiazine. But many students also said कि सर ये question ऐसे नहीं था, उसमें option कुछ अजीब अजीब drug थे और उसमें 1 and 2 था, 2 and 3 था, 3 and 4 था, ऐसे करके option थे. अगर ऐसे करके भी थे तो I have given you the entire summary textbook में जितने भी suicide inhibitor के list दिए हुए हैं, I have already given to all of you guys. I hope you go through this one and you get your answer. जो भी आपको recall हो रहा है आप इसमें put करिए. These are the suicide inhibitor that has been given in the textbooks. A female delivered a baby neonate died after a week due to some medical reason. Which of the following would be given to the mother for the management of the bilateral breast engorgement? Again, breast engorgement का reason क्या होगा बच्चे? Prolactin. And we already know अगर prolactin level बढ़ा हुआ है तो what is inhibiting prolactin? We know that dopamine always have inhibitory effect on the prolactin. So we used to give a dopamine agonist. So we have dopamine agonist drugs like your bromocriptine, cabergoline, कैबरगोलिन एंड परगोलाइड. इन सभी में सबसे ज्यादा जो कॉमनली यूटिलाइज करते हैं वो हमेशा कैबरगोलिन करते हैं. लॉन्गर टी हाफ लाइफ एंड लेसर साइड इफेक्ट. Longer T half life, lesser side effects. So again, if for this patient, we are actually going to utilize cabergoline as a compound. Cabergoline as a compound, quickly we are going to utilize. Now, this was also a question, tetanospasm. Simply पूछ रहा है कि भाई tetanus का बता दो mechanism of action क्या है या botulinum toxin का mechanism of action क्या है. So they inhibit the acetylcholine release. So मैंने बताया था कि botulinum बाहर नहीं आने देगा. botulinum बाहर नहीं आने देगा. So this is going to be botulinum toxin का mechanism of action. They do not inhibit the GABA or the epinephrine release. They inhibit the acetylcholine release, right? So these are actually the question. Let me quickly take you in the 60 seconds of all the question that was asked and the question that I could collect. Tetanospasmin, that is botulinum toxin का mechanism of action inhibiting the acetylcholine release. Cabergoline, again, they are the dopamine agonist, will be given to inhibit the prolactin ka release. And suicide inhibitor ka entire list I have given to all of you guys. Anti-tubercular drug benzothiazine has been tried. They are also having suicide inhibiting property. Inhaled nitric oxide for the primary pulmonary artery hypertension and rapidly reversing the rocuronium is going to be your Sugamadex. And the diuretic and its site of action we have discussed in more detail a couple of times. Carbonic anhydrase inhibitor, PCT, it fits the best. If there is any other thing, remember, we can discuss in more detail, and you can find it out, lot of video that we are having on YouTube as well. That I have uploaded already. A diabetic patient on symptom of heart failure and diabetic. So SGLT2 inhibitor is always going to be preferred. And the anti-diabetic agent that is causing UTI-like symptom, that is SGLT2 inhibitor. Once again, dapagliflozin will be the correct one. And unexplained persistent diarrhea, metformin. I don't know in this examination what is the love with the diabetes. 3-4 question on the diabetes directly asked. Teriparatide increasing the risk of osteosarcoma. This is the screenshot taken from the Goodman-Gilman. Osteosarcoma is the side effect that has been associated with the teriparatide, a recombinant parathyroid hormone. Cannabinoid is not preferred in Rett syndrome. other cannabinoid, other epileptic disorder like tuberous sclerosis, Dravet and Lennox-Gastaut, that is a resistant form of epilepsy में we can actually utilize. Now voriconazole वाला ये challenging था, इसलिए मैंने एक screenshot Goodman Gilman से लेकर rule out कर दिया. There is no point of adding pyrazinamide with the voriconazole. Remember that we need to give prior to meal, and therapeutic drug monitoring is required, and bolus dose is also, or loading dose is also required in this scenario. Okay, for this one, leperidine के लिए we need monitoring. Other drugs do not require monitoring. They are relatively much safer. Vancomycin enterococcal infective endocarditis के लिए prefer करेंगे, even if it is going to be allergic to penicillin. Remember, other beta lactams cannot be used due to a phenomena called cross allergy. But vancomycin is one of the glycopeptide. They can be utilized in this patient. Estronam is not effective for anaerobes and your gram-positive organisms. ठीक है, again ये वही वाला question है, diabetic with heart failure, dapagliflozin, one of the SGLT2 inhibitor that is going to be preferred. And expectorant, इसमें different students are having different views कि इसमें mix option आए हुए थे. So देखिए जिस option में bromhexine है, या जैसे मैंने बता रहा हूँ ambroxol bromhexine कार्बोसिस्टीन के साथ जिस option के साथ ये जिस ऑप्शन में ये दिया हुआ है दैट विल बी द प्रेफर्ड वन. तो एक ही ऑप्शन के साथ ब्रोमहेक्सिन था, बाकी किसी के साथ नहीं था. तो अगर आपको लग रहा है कि नहीं किसी के साथ मिक्स था, तो समटाइम वी कैन यूटिलाइज ब्रोमहेक्सिन के साथ भी. ठीक है. एंटी लेप्रोसी कॉजिंग हाइपरपिगमेंटेशन तो कलर कर देता है, दैट इज क्लोफाजिमीन. एंड HER1 इनहिबिटर, तो ये चैलेंजिंग था क्वेश्चन था. मैंने बोला था कि इसमें या तो एग्जामिनर हैज फॉरगॉटन या आपने हमें गलत रिकॉल दिया है, या तो इसमें नॉट या एक्सेप्ट था. नॉट या एक्सेप्ट था तो इसका आंसर परटुजुमाब. अगर HER1 इनहिबिटर आप श्योर हैं तो इसमें HER1 इनहिबिटर के 3 आंसर होंगे ACD. या तो एग्जामिनर ये बना रहा था और उसमें एग्जामिनर वांटेड टू मेक ऑप्शन लाइक ओनली 1 and 2 आर करेक्ट, 1, 2, 3 आर करेक्ट, 1, 3, 4 आर करेक्ट, वो भूल गए शायद. So if you want, if there is some clause, if you know that already, you can challenge this question. HER1 3 आंसर इसके होंगे. And anti-dyslipid inhibitor, that is PCSK9 inhibitor, that is going to be your evolocumab. So this was everything in pharmacology. I hope you got maximum correct. And most of the question I saw was pretty simple, except for 1 to 2, especially the voriconazole wala question. Thank you very much, Ranjit sir. From my side, we are done with pharmacology.
Thank you, sir. It was an amazing recall. And I think diabetes, almost entire diabetes covered, right?
Yes. Diabetes, they have covered like anything. Diabetes, they have covered like anything.
It's like great, sir. So thank you, sir, once again. Next, we'll be having Dr. Rishabh, and Rishabh, over to you.
Thank you, sir. Thank you, Siraj sir, for that lucid discussion on pharmacology. Just give me a quick confirmation on the live chat that I am audible.
Yeah, you are. Go ahead.
Yes, sir, you are audible, sir.
Thank you, sir. So in radiology, if we look at the all image-based questions that were discussed in radiology, so around 10 questions came from core radiology, and 5 questions I could recollect were from integrated systems, combined questions from some major subjects and radiology. So I'll discuss both more the core systems than integrated systems. And if we divide the core radiology into subcategories, so around 2 questions were from respiratory radiology. General radiology had 2 questions, which was, rare because general radiology, the latest trend in INICET was not asking general radiology questions from CT scan or ultrasound contrast agents, etc. But this INICET had a lot of weightage on radiology, and I'm happy to know that all of those questions were covered in the class in my lectures. Now, neuroradiology had 2 questions, GI radiology 2 questions, then MSK 1 and head and neck 1. Now, few of the questions might already have been discussed with other faculties, especially the clinical branches. And if you have already done, you can skip it. I'll try to cover the entire radiology discussion in the next 15 minutes. So the first question is, which of the following statement is true concerning the computed tomography? Now, this is a question which is a core radiology question asked from CT basics. And इस टाइप के क्वेश्चन में आपको ये नहीं देखना होता है कि मुझे सारे ऑप्शंस आते हैं कि नहीं. हमारी नॉलेज लिमिटेड है जो हम MBBS के लिए नीट PG के लिए पढ़ते हैं, और उन्हीं से हमें सारे क्वेश्चंस क्रैक करने हैं. सो मेक इट अ हैबिट टू रूल आउट ऑप्शंस. और अगर रूल आउट नहीं कर सकते, एक भी ऑप्शन आपको पता है वो सही है, ऑप्शन क्वेश्चन में भी ट्रू पूछा गया है, मार्क दैट ऑप्शन. ठीक है. सो अगर आप देखो ऑप्शन सी, a CT number of 0 is assigned to water. So what is the CT number? The HU value. And we know that Hounsfield unit of 0 is assigned to water. So this is the correct option. Okay, we have already covered CT attenuation, Hounsfield unit in our lectures. And I told you that the maximum Hounsfield unit of plus 1000 for metal and minus 1000 is for air. Now, in between, we have different shades of grade in radiology, and 0 is the Hounsfield unit we assign to water. Correct? Now, usually fat has been asked as a previous year question in INICET, and it has usually an attenuation between -20 to -100. But remember, minus attenuation on a CT scan is fat unless and otherwise stated. Okay. Soft tissues usually have 50, and hemorrhage is one substance which has an attenuation value of around 60 to 80 HU on a non-contrast CT. So these all are attenuation on a non-contrast CT. ठीक है, not on a contrast enhanced CT. And आगे वाले क्वेश्चंस में, आगे वाले एग्जाम में क्या क्वेश्चन बन सकता है? अगर वाटर की 0 है तो सिंपल सिस्ट की एटेन्युएशन वैल्यू क्या होगी? It will be less than 20 HU. ठीक है, nearing water because cyst has almost water-like consistency. उसकी HU भी less than -20 होती है. Remember this point, especially for your NEET PG. ठीक है. Now other options हम देख लेते हैं. Unfiltered X-ray beam is used in a CT scan. आपको हो सकता है ना पता हो ये क्वेश्चन, ना पता हो ये ऑप्शन, बट सी अगर आपको पता है कि वाटर 0 है एंड ये हमने क्लास में कवर भी कर रखा है, तो आपका ये आंसर, ये क्वेश्चन ठीक हो जाएगा. नाउ क्या CT स्कैन में अनफिल्टर्ड एक्सरे बीम यूज होती है? नो, वी यूज अ फिल्टर्ड एक्सरे बीम. व्हाई? बिकॉज अनफिल्टर्ड एक्सरे बीम will have very high dose on CT, and that is why filtering of radiation is always and always done in an X-ray based modality, be it simple X-ray, CT scan, fluoroscopy or DSA. ठीक है. Now the second option, first investigation is suspected gallstone on the CT scan. Big no. We have already know that gallstone के लिए investigation of choice is an ultrasound. ठीक है. For all other renal stones, pancreatic calcification, उनके लिए CT scan होता है. But I told you in the class also, gallstones is one exception जिसमें ultrasound is the investigation of choice. Why? Because gallstones के stones cholesterol के होते हैं, not calcium. Now D option, typical effective dose for CT head is 20 millisievert. Now 20 millisievert is very large dose. CT head की डोज अगर आपने लेक्चर्स में देखा हो, मैंने बता रखा है 1.6 मिलीसीवर्ट होती है. एंड ये मैंने वैल्यू कहां से ली है? ऑफिशियल साइट से ली है, अमेरिकन कॉलेज ऑफ रेडियोलॉजी. ठीक है. सो फर्स्ट क्वेश्चन इज डन, आंसर इज सी. Now next question, a patient with stab injury to the chest came to the emergency. X-ray is given below. What is the diagnosis? ठीक है. What are we talking about? We are talking about opaque hemithorax. Opaque hemithorax has been asked previously in multiple questions. Opaque कभी-कभी lucent hemithorax आ जाता है. Lucent hemithorax मतलब एक तरफ का चेस्ट व्हाइट है. सॉरी, lucent hemithorax मतलब एक तरफ की चेस्ट पूरी ब्लैक है. ओपेक मतलब एक तरफ की चेस्ट पूरी व्हाइट है. सो वी आर डीलिंग विद ओपेक हेमीथोरैक्स. ठीक है. सो देख लेते हैं कि रूल आउट क्या क्या कर सकते हैं. न्यूमोथोरैक्स में तो ब्लैक दिखता है बिकॉज ल्यूसेंसी है एयर, तो उसमें ओपेक हेमीथोरैक्स नहीं होगा. हाइड्रोन्यूमोथोरैक्स में क्या मिलेगा? वील गेट एयर फ्लूइड लेवल्स. व्हाई? बिकॉज देयर इज बोथ hydro, that is fluid, and pneumo, that is air. Now right hemithorax में we'll get opaque hemithorax like this. We'll get an opaque hemithorax. Now I don't think that this was the original image that was asked to you in the exam. So hemithorax अगर typically होगा तो उसमें क्या मिलेगी हमें? Contralateral tracheal shift. ठीक है. Contralateral tracheal shift मिलेगी कि ट्रेकिया हमारी यहां को जाएगी because there is mass effect on the right pleural cavity. So इसका आंसर क्या है हमारा? right hemothorax. इसका आंसर है right hemothorax. This is a case of opaque hemithorax जिसमें contralateral tracheal shift होनी है. Now let's see the next question. Which part of the rib is marked? Now this is again becoming a favorite of examiners. Recent INICET question जिसमें rib marking was asked previously. ठीक है. So last year, someone was asked to track the ribs. So 7th, 8th rib का fracture दे रखा था. This time they directly pointed an arrow to the rib and asked whether this is a posterior or an anterior end. So अगर हम इस वाली rib को देखें, so this is the posterior end of this rib, और anterior end कौन से होते हैं हमारे? ऐसे horizontal जा रहे होते हैं हमारे anterior end. These are our anterior ends of the ribs. Okay, so if I were to follow or trace a rib, how will I do that? This becomes my first rib. This becomes my second rib. ठीक है, so all of this has been covered. Answer here is a posterior rib end which has been marked by this arrow. So this is the diagram how we follow the anterior and the posterior ends. The posterior ends are like this, straight. Anterior ends are horizontal like this. Okay. Now the next question, a direct question, simple one-liner question in radiology. Mount Fuji sign is seen in, and the direct answer is a tension pneumocephalus. Already covered in the class, wherein I showed you this image of a tension pneumocephalus. This is how a Mount Fuji looks like. It is a mountain in Japan. And in cases of tension pneumocephalus, okay, that is air. Pneumocephalus means air in the cranial cavity, right? Whenever this air is under pressure, that is under tension, what it does, it compresses on the underlying brain parenchyma, which causes tenting of the dura mater. So the dura mater gets tented like this, giving it a Mount Fuji sign. Okay. Now it is a simple one-liner. Pneumothorax we don't get. What are the signs that we get in pneumothorax? These are ultrasound-based signs. ठीक है, जो कि हम बारकोड साइन पढ़ते हैं, stratosphere sign पढ़ते हैं. These are based on ultrasound. Pneumomediastinum may also we can get some signs, but again these signs are on X-ray and not related to Mount Fuji. And pneumoperitoneum के लिए there is a whole list of signs that we see on pneumoperitoneum, but Mount Fuji is specifically related to tension pneumocephalus. Now very good question asked this time, and I was hoping that AIMS कभी ना कभी ultrasound contrast agents पे question पूछेगा ही पूछेगा, because contrast enhanced ultrasound is now becoming very common in big hospitals and central institutes. Okay, so AIMS had to ask one question on contrast enhanced ultrasound, and it asked it this time. So contrast agent safe in CKD patients. ठीक है, अगर kidney खराब है तो I cannot give iodinated contrast because they are excreted through the kidneys. I can also not give gadolinium based contrast. Why? Because they are causing risk of nephrogenic systemic fibrosis in CKD patients. And iohexol तो हमारी kidneys और खराब कर देगा. So which modality do we use? We use an ultrasound, and उसमें what is the agent that we use? On contrast, ultrasound agent is SonoView or Sonazoid. दो brand names आते हैं. And what is the compound that they have? It is sulfur hexafluoride. Okay, potential question for your NEET PG and further INICETs, because this is a new question which has been asked. This is not a PYQ. This is a new question which has been asked this time in the INICET. There is likelihood that it will be asked again in the next sessions. Okay. So this is again a direct repeat from our lectures. So I covered ultrasound contrast agents in the radiology lectures at MedEd, and we discussed the agent, the mechanism of action, and also mentioned that it is used in CKD patients. Now the next question. A CT image was given. I'm not sure if this was the exact CT image, but I have been told that the CT of a femur was given, and that was showing some destructive lesion along with sclerosis. And so I believe this was the CT scan that was given. Please mention in the comment section what was the type of CT scan that was mentioned. So if this was the question and this was the CT scan, so you can see a lot of sclerosis, bone thickening. So this is sclerosis. This is my bone thickening. And there are multiple lytic lesions like this inside the bone. So this is an infective etiology. Okay? This is an infective etiology, and answer here becomes your chronic osteomyelitis. Okay, so answer in this case is a chronic osteomyelitis. Now, Ewing sarcoma will not cause sclerosis. Ewing sarcoma will cause lysis. Okay? And it causes a lot of soft tissue mass. There is a soft tissue mass associated with any cancer. Now, osteosarcoma will have sclerosis, but you know what kind of sclerosis? It will have malignant periosteal reactions. So it will have these sunburst periosteal reaction. Okay, or it can have Codman's triangle type of periosteal reaction. But none of that can be seen in this question. This is a bone thickening, so it is a benign type of periosteal reaction, and hence the answer here is a chronic osteomyelitis. Okay. Now, so Sanket is saying that the mark structure was not asked, sir, not ripped. So what was asked, please tell me in the comment section so that we can make this recall session more accurate for you guys. So I was told that one of the students that this was the rib that was marked, and hence I told you that this was the question. But in case there was a different question, the options were different, please do let us know in the comment section so that we can make this recall more accurate. Now, the next question. A 26-year-old with dysphagia, halitosis, and regurgitation comes to the OPD, and barium swallow is shown below. What is the likely diagnosis? So I think this has already been covered in surgery also. And, typically dysphagia, regurgitation, halitosis given. And on this barium X-ray, you see this bird beak appearance. What is this? This is a bird beak appearance of esophagus. And this is simply a one-liner. It is an 𝐒𝐿𝐴 ठीक है. Esophageal अगर CA esophagus होगा तो क्या होगा, तब उसमें irregularity आएगी, ठीक है, and we'll get rat tail appearance. But if you see this smooth narrowing in the distal part of the esophagus, this is nothing but your bird beak appearance, and the answer here is 𝐒𝐿𝐴. Now, this has already been covered in our class, and where we talked about 𝐒𝐿𝐴 signs, diagnosis, investigation of choice, and 𝐒𝐿𝐴, is again a favorite of AIIMS. 𝐒𝐿𝐴 is favorite of AIIMS people because they operate a lot of 𝐒𝐿𝐴 patients. What is the surgery that we do at AIIMS for 𝐒𝐿𝐴? It is POEMS. Okay, it is a POEM surgery done by gastroenterologist for 𝐒𝐿𝐴, and hence 𝐒𝐿𝐴 is a very favorite of AIIMS people. Now, anatomical variant that you see on CT scan. So I believe this was the CT scan that was given to me, given to you guys in the question. Tell me in the comment section if this was the CT scan that was given. So if this was the CT that was given, some people told me, some students said that, sir, this was an air containing structure adjacent to the trachea, and we marked the answer as tracheal diverticulum. Okay, but bacha, listen that this air containing structure is not trachea. Esophagus also runs in the mediastinum. So this air containing structure you see is your esophagus and not a tracheal diverticulum. What is this arrow mark structure here that you see? So this is what is your aberrant right subclavian artery or URSA, right? And this is the correct answer, which goes posterior to the esophagus and causes what? What kind of dysphagia? Dysphagia lusoria. Yes, it causes dysphagia lusoria. So the answer to this question is your aberrant right subclavian artery or URSA. Okay, so this is how an aberrant subclavian artery goes posterior to the esophagus, arises from the aortic arch, and causes dysphagia lusoria. So this is an anatomical variant you commonly see in your practice as well. Now, the next question, and I'm very happy to see this question come up in this INICET. So, radiological intervention done for intracranial aneurysms. So, intracranial aneurysm is treated by neuroradiologist, and this is one domain that belongs to us. So, what is the treatment for intracranial aneurysms done by radiologists? It is your coiling. It is endovascular coiling. So, if this is your aneurysm, we go through this tiny catheters and fill up this aneurysmal sac with coils, and slowly over the time this sac gets thrombosed and the aneurysm disappears. Now tell me in the comment section if clipping of aneurysm was an option. So clipping is done by your surgeons, your neurosurgeons. So that is not done by radiology. Now angioembolization is done for any bleeding vessel in which it is a end vessel. In brain, for a bleeding ruptured aneurysm, you cannot do an angioembolization. Angioembolization means that you are blocking the main artery. Tell me in the comment section if angioembolization was one of the option. So Bhavesh is saying that clipping of aneurysm was not an option. Okay, so if clipping was not an option, tell me in the comments what were the options. Angioembolization का क्या मतलब है कि हम मेन आर्टरी को बंद कर रहे हैं with a coil, glue or any other thing. In case of intracranial aneurysm, we cannot occlude the main artery because it is supplying vital parts of the brain. What do? We do sac coiling. We go inside the sac and coil it endovascularly. So endovascular coiling is the answer. Bare metal stent. This is done for stenotic lesions. Okay, so if for example, carotid stenosis, you will do stenting. Okay, if there is intracranial atherosclerosis or ICAD, intracranial atherosclerosis, then also we do stenting, but not for aneurysm. For aneurysm, we have to do coiling. Now, Nivedana is saying that sclerotherapy was one of the option. Okay, so if the fifth option was sclerotherapy, now what is sclerotherapy? Very, very important for you guys to know. Potential question. Okay, sclerotherapy, remember, is done for slow flow vascular malformation. Slow flow vascular malformations. Okay, so if there are slow flow vascular malformations in the head, in the arm, in the face, etc., for them you do sclerotherapy. What you do? Since these slow flow channels are there inside the body, through an ultrasound guidance, you first put in a needle inside these channels and give some sclerosant. Okay, so that is done for slow flow vascular malformation, not for intracranial aneurysm. For aneurysm, we do endovascular coiling. So this is how we do an endovascular coiling. This is an aneurysm which is coming out from one of the branches of the ICA, and we through a catheter we fill this with coils. And post coiling run, if you take, you see that the aneurysm is not filling up now. So this is how you do endovascular coiling for intracranial aneurysms. So next question. So best view for frontal sinus. So abhi tak we have best view for frontal sinus. So I think this has already been covered in ENT. And yes, the answer correctly is Cadwell's view. Cadwell's view is best for your frontal sinus. It is also known as, tell me, क्या बोलते हैं? Occipito-frontal view. Occipito-frontal view, and this has been covered in our lectures. We discussed about Waters' view and Cadwell's view. Cadwell's view best for frontal sinus and superior orbital fissure. Now हम याद कैसे करेंगे ये चीज? I told you that for Waters, remember W को उल्टा कर दो, maxillary sinus, M for maxillary sinus. So Waters' view is for maxillary sinus visualization. And again, M से क्या है? Occipito-mental view. Occipito-mental view. अब आरती सिंह, ये क्वेश्चन नहीं कहा था. अगर ये क्वेश्चन नहीं था तो फिर बताइए और क्या क्या क्वेश्चंस थे. ठीक है, टेल मी, हेल्प मी इन अ गुड रिकॉल. Endovascular coiling was, some students said that this was one of the questions that was asked. Now the next question, which of the following is a common fracture in osteoporosis? So this I think has been covered in orthopedics again, but I'm covering all the topics that I discussed in radiology. And some radiology questions will obviously be overlap with clinical scenario, because nowadays radiology is integrated with your core clinics. ठीक है, so which of the following is a common fracture in osteoporosis? So remember, जब भी हम osteoporosis में bone mineral density measure करते हैं, किससे करते हैं? DEXA से करते हैं. जब भी हम bone mineral density measure करते हैं, हम where all do we measure it? We measure it in the lumbar vertebra. We measure it in the neck of femur, and we measure it in the radius, wrist, distal end of radius. ठीक है, so glenoid and humerus हम out कर देते हैं, they are not common site of osteoporosis. Now between vertebra and subtrochanteric fracture of femur, अब आप बोलोगे सर neck of femur में भी measure करते हैं क्योंकि वहां पर भी bone mineral density कम होती है, वहां पर भी fracture हो सकते हैं. Yes, हो सकते हैं, but within this neck of femur, it is not at the subtrochanteric level. Subtrochanteric थोड़ा नीचे हो गया. It is usually at the mid neck level that this fracture happens. So among these four, the best option will be vertebra, will be lumbar vertebra. That is where we measure bone mineral density. Okay. Now next question, again, I think surgery overlap, and this management was asked in this INICET. So 25-year-old patient met with a road traffic accident, now presented to the emergency with unconscious state. And tell me in the comments whether unconscious state was given, whether non-dilated, non-reactive pupils was given. Because, you know, if these things are given in the question, then your answer will change. If these things are not given in the question, then the answer will be different. So if you have unconscious state, if you have signs of raised ICT, then what will be the next step? So obviously CT scan, I don't think anybody has any problem in identifying what is the diagnosis. So it is a biconvex bleed inside the brain. This is a non-contrast CT where you see a biconvex shaped bleed in the right frontoparietal region. And what else do we see? We see a midline shift. We see a midline shift, which is looking much more than 5 mm. So even, you know, अगर क्वेश्चन में इमेज ऐसी दे रखी थी जिसमें मिडलाइन शिफ्ट था, तो आपको फर्क नहीं पड़ता कि भाई अनकॉन्शियस स्टेट दे रखा है कि नहीं दे रखा, आपको सर्जरी में इवैक्यूएट करना है. बट अगर नहीं दे रखी ऐसी इमेज, देयर इज अ डिफरेंट इमेज इन व्हिच, यू नो, दिस मिडलाइन शिफ्ट इज नॉट सो वेल अप्रिशिएबल, then you have to look at the clinical information that is given. If there are signs of raised intracranial pressure, then you have to do for an urgent evacuation. Decompression करना पड़ेगा आपको, ये EDH को evacuate करना पड़ेगा. ठीक है. Now again we discussed EDH and its management briefly in the class, in which we discussed that midline shift more than 5 mm, presence of raised ICT features warrants an urgent surgery. Now next question, I think for medicine radiology overlap. So this X-ray of the chest was given in an adult man who came to the OPD. Some students are saying that history of fever was given, shortness of breath was given. ठीक है, 1 month की हिस्ट्री वॉज गिवन. अब इनकरेक्ट स्टेटमेंट इसमें से ढूंढना था. सो अगर आपको, यू नो, एक्सरे नहीं भी समझ आ रहा, तो ऑप्शंस पढ़ के एक बार देख लो, उससे चल जाता है पता कि भाई एग्जामिनर किस डिजीज के बारे में बात कर रहा है. सो इफ यू नो ऑप्शंस में दे रखा है पल्सेस पैराडॉक्सेस, पेरिकार्डियोसेंटेसिस, so we know that the examiner is talking about cardiac tamponade. And incorrect statement कौन सी होगी? So pulses paradoxes मिलते हैं, yes मिलते हैं. Pericardiocentesis, do we have to do? Yes, we have to do emergent pericardiocentesis to drain this pericardial fluid. Now loud S1 मिलता है क्या in cardiac tamponade? No. In fact, muffled heart sounds मिलते हैं हमें. Muffled heart sounds. Beck stride, remember? So loud S1 is an incorrect option here, and that will be the correct answer to this question. Okay, so Aarti is saying that midline shift was there, sir, but not this much. तो ठीक है, अगर midline shift दे रखी थी and question में दे रखा था कि unconscious है या dilated pupil है, non-reactive pupil है, then also the answer will be an urgent evacuation. Now the next question, primary survey in a trauma patient includes what? ठीक है, so primary survey में क्या क्या आता है? So remember, chest X-ray is part of your primary survey. Very, very important question. ठीक है, so this is directly given in your Washington Manual of Surgery, जहाँ से मैं सब लोगों को बोलता हूँ कि भाई आप सर्जरी पर वहां से ट्रॉमा का पार्ट एटलीस्ट वहां से पढ़ो. ठीक है, so chest X-ray is included in the primary survey. Remember, NCCT head, endotracheal intubation, ICD insertion, all these are part of secondary survey. ठीक है, NCCT head is not a part of primary survey. Chest X-ray is part of primary survey. ठीक है, similarly अगर आपको X-ray limbs का भी दे रखा हो, that is also a part of your primary survey. ठीक है. Now the last question, what is the diagnosis of the following image? So I don't know what kind of image was given to you in the paper. Tell me in the comment section whether it was an AP X-ray of the knee, a lateral X-ray of the knee, or a skyline view of the knee? What was the view that was given to you in the question? ठीक है, क्यों? क्योंकि अगर मान लीजिए एपी व्यू दे रखा है आपको और ये इमेज है, तो अगर डायरेक्ट क्वेश्चन पूछा गया है विदाउट गिविंग एनी हिस्ट्री, तो रूमेटॉइड अर्थराइटिस कैन नॉट बी द आंसर. ठीक है, रूमेटॉइड अर्थराइटिस में ऑलवेज द एग्जामिनर विल गिव सम फॉर्म ऑफ हिस्ट्री. Now, tibial condyle fracture will be fracture of the tibial condyle here. Patellar fracture, patella AP पे थोड़ी मुश्किल से दिखती है. So this is an approximate location of your patella, and we can see a faint fracture line passing midline, passing midway. ठीक है, so this, if this was the image, then the answer will be patella fracture. But अगर ये image थी, ये वाली image थी, तब यहाँ पर tibial plateau का fracture है, तो answer here will be a tibial plateau fracture. अगर स्काईलाइन व्यू दे रखा था तो दिस इज ऑल्सो पटेलर फ्रैक्चर. ठीक है, अगर लैटरल व्यू दे रखा था और उसमें पटेला का फ्रैक्चर दिखा रहा था, दे रखा था, सो दिस इज अगेन अ पटेला फ्रैक्चर. सो स्काईलाइन लैटरल व्यू में पटेला फ्रैक्चर्स आर बेटर विजुअलाइज्ड. इन एपी व्यू वी सी tibial plateau fractures and femoral condyle fractures. Okay, so that was all with regards to your radiology discussion. Thank you, and over to Ranjit sir.
Thank you, Rishabh. Thank you, Rishabh, for the detailed discussion of all the images and the questions. Like every teacher has been saying, this is the first-hand information what you have got from the students directly, and we will definitely come up with a much detailed explanation of the stem of the questions also. Thank you, Rishabh, once again. And I welcome Murugan sir to complete the PSM questions. This time PSM has been a bouncer, sir. So over to you.
Okay. Hello, everyone. Hope I am audible. Ranjit, am I audible?
Yes, sir.
Fine. Okay. So good evening, guys. Okay. So hope you did well your exams. Okay. So this time PSM we have limited number of questions. Okay, but most of the questions are simple and straightforward. Now I will start with the first one. Okay, this is probably in micro and PSM we discussed this. Which of the following is not a polysaccharide vaccine? Okay, it's a straightforward question. It's there in our class notes also. What is the answer here? Yes. So the answer here is this first one, H influenza, meningococcal meningitis, pneumococcal, all are polysaccharide vaccines. So if you see here, so these are the vaccines. So the surface of bacteria is covered by a capsular shell, and this is polysurface polysaccharide, and we have vaccines for it. So the polysaccharide vaccines, what we discussed in the class, it's there in the class notes also. Pneumococcus, meningococcals, H influenza B, and typhoid. Okay, VA polysaccharide vaccines. One drawback of polysaccharide vaccines is that we cannot give it less than 2 years of age. Okay, so conjugate vaccines we can give. Okay, pneumococcal, meningococcal, H influenza B is there. This we can give less than 2 years. Less than 2 years can be given. Okay, and hepatitis B is a recombinant beta subunit vaccine. We have Lyme's disease is there. Okay, HPV is there. Cholera toxin B is there. HPV is a recombinant beta subunit vaccine. So the answer here is hepatitis B, guys. Okay, hepatitis B. This is a recombinant beta subunit vaccine. It's a direct question, guys. Subunit vaccine. Okay, fine. Next, H influenza B is we are giving. What about the next question? Which of the following is seen in some dehydration? Okay, so based on IMNCA guidelines, okay, so which of the following we can see in some dehydration, IMNCA guidelines. Okay, so we have these IMNCA guidelines, no dehydration, some dehydration, severe dehydration. Okay, fine. I think the question was multiple options were there. Multiple options were there. Okay, no dehydration. 4 things we will look for. Okay, so 4 things. General condition we will see. Second, you will look for sunken eyes. Thirst you will see, and you will look for skin pinch test. Okay, you will do the skin pinch test in the abdomen. You will do abdomen. Okay, you will do the skin pinch test. Okay, fine. Now, general condition is fine. No thirst, no sunken eyes. Skin pinch test is normal. No dehydration. Some dehydration. Okay. When you say some dehydration, when the thirst is increased. When the thirst is increased, we call it as some dehydration. Okay, delayed skin pinch. Skin pinch is delayed less than 2 seconds. Okay, less than 2 seconds. Sunken eyes is present. Okay, if out of this, and one more thing will be there, general condition of the baby is irritable. Okay, irritable and restless. Okay, if out of these 4, if any 2, okay, any 2 we call it as some dehydration. Some dehydration. So what we don't have is lethargic and decreased urine output. This comes in severe dehydration. This we get it in severe dehydration. So thirst, skin pinch test, sunken eyes, we can find it in some dehydration. And lethargy and decreased urine output, we can see in severe dehydration. Okay, fine. Next question. Okay, so if you have anything else to add, please add on this chat box. Okay, we can discuss. Immediate life-threatening injuries classified in which color of triage? Okay, so triage, we are classifying injured people based on their chance of survival. So we are going to do triage at the site of disaster. We are going to do triage. Okay, what is red color indicates what? Red color indicates high priority. Okay, yellow means medium. Green means ambulatory. These are straightforward question. Black means dead people, guys. Okay, black means dead. And the question is life-threatening injuries, high priority. So it will go to red color, guys. Okay, red color. High priority, red color. So life-threatening injuries will go into red color, guys. Red color. Fine. All of the following is correct regarding rotavirus vaccine. Okay, I got only 2 options. So rotavirus vaccine, it's what type of vaccine? Okay, the question was except should be there. Okay, so what type of vaccine? It's a live vaccine. This is a live vaccine. It is given orally, it is given. Schedule is 6, 10, 14 weeks. Okay, 6, 10, 14 weeks. Okay, maximum we can give it for 1 year. The national immunization schedule, we can give it for 1 year, we can give maximum. Okay, fine. And the document says that, okay, avoid first dose after 12 weeks. Okay, avoid first dose after 12 weeks because it can cause intussusception. This is what we have discussed in the class. These are all the questions. Okay, 4 questions we have discussed, all are from class notes. Okay, it cannot be given more than 6 months. Okay, this statement, okay, is wrong. Okay, it can be given more than 6 months. Avoid the first dose after 12 weeks. 12 weeks, but maximum wattage you can give. You can give it for 1 year, guys. Okay, 1 year, fine. Dose of Antara. Okay, so we are giving this Antara vaccine. We are giving. What is the dose, guys? I think this may be related with OG also. So Antara, we are giving. What is Antara? Antara means DMPA, depot medroxy progesterone acetate. Okay, depot medroxy progesterone acetate. We are giving it in the program Antara. How much we are going to provide? So we are going to provide 150 milligram IM injection, guys. IM every 3 months once. Every 3 months. So this is the IM injection we are giving in the program, guys. Okay, so 150 milligram IM injection every 3 months. We also give one more is also there, norethistyrone enanthate. Okay, 200 milligram IM every 2 months. Okay, fine. But this is what we give it in the program, guys. Antara is what we give in the program. So answer is 150 milligrams. Okay, 150 milligram we are giving. Okay, what is this Chaya? Chaya also we are giving the program. Okay, Chaya is that. Okay, Senchromon. Okay, Senchromon. But what was the question is? Antara was the question, guys. Antara was the question. Okay, fine. And we had a question on survival curve. Okay, I'm not sure of the question. Okay, so if you have anything to share, please share. There is one image was given on survival curve. Okay, If you tell me, it will be helpful for us, okay, for the next session. Okay, fine. So question was survival curve. So survival curve analysis, we can do it in two ways, guys. One is, okay, life table analysis we can do. Okay, and the second is that we have this Kaplan-Meier curve analysis we can do. Kaplan-Meier curve we can do. Survival curve. Survival curve we can do in both ways. Okay, so what is this Kaplan-Meier? Last time also that was asked, Kaplan-Meier curve was asked. Okay, this is, you take time. The survival analysis, you take time in the x-axis and probability of percentage of surviving in the y-axis, guys. Percentage of survival. Okay, in the y-axis. Okay, you do this. Now, what is this Kaplan-Meier curve? Okay, so this is this chapter I have added in this 2.0 version we have added actually. So Kaplan-Meier curve, okay, it's a variant of this life table method. So life table method, the x-axis, the time axis is divided into predetermined intervals like months, years, fixed intervals. Okay, first year, second year, third year, like that we have fixed intervals. In Kaplan-Meier curve, okay, the time axis is not defined by the fixed length, by the occurrence of the event. Event means maybe a death or a loss to follow. Look here. So here the time for the death is, first is 4th month, then 10th month, 14th month, then 24th month. Okay, like this is Kaplan-Meier curve. Okay, this is Kaplan-Meier time for the event. Okay, but in life table analysis fixed. So this here it is time for the event was added here, guys. Okay, time for the event was added. So what is Kaplan-Meier curve will tell you is that probability of surviving the individual interval is 1 minus the probability of dying in the interval. Okay, dying in the interval. Probability of surviving is equal to 1 minus, what is the probability ranges from 0 to 1. So probability of survival minus of the interval is 1 minus probability of dying in the interval. Okay, fine. So hope this gave some idea, guys, about the questions. Okay, if you have any more questions, okay, please, okay, so put it in the chat box. Okay, thanks, Dr. Ranjit. Okay, hope it went well.
Thank you, sir. You covered everything which came in the PSM subject, and like sir said, we'll be definitely coming up with a better recall. And next is Dr. Vinesh, sir. Over to you, sir.
Sir, I'm visible and audible, sir. Fine.
Yes, sir.
Visible and audible.
Yes, sir, you are.
So I'll just start, sir. Okay. So guys, I'll be discussing the anesthesia part. The questions from anesthesia were fairly simple as always, right? Most of the time, this is the only subject which provides relief to everyone. And hopefully after this long session, we'll have some relief with the guitar as well, okay? I've just kept it ready. We'll try to do one song, all right? So it's been a long time. Dr. Ranjit has been here. Everyone has been here listening to each other. All the students who are there were listening to all this, recall. So let's go ahead with the anesthesia recall. Basically, there were 4 questions, 4 plus 1 question mark, right? That's a question mark which is included in part of medicine or pharmac. We'll just discuss all of them and go forward, and then with a guitar session, right? Small song. So the first question, a patient was given rocuronium for a short surgery, right? Which of the following would you use to end its effect fast? Okay, a short surgery, person has given rocuronium, and which of the following would you use to end its effect fast? Edrophonium, neostigmine, sugamadex, and glycopyrrolate were the options given. All the 4 were given. The point is, this question was never asked before, but for the last 3-4 years, all the teachers, all people have been setting up sugamadex because it was this has been one of the best reversal agents which has come for rocuronium. It was made for rocuronium. It's like a binding agent, it just catches it and takes it away. So it's one thing which is now available in India. And last 3-4 months, it's been available. People are using it. And that's why this question is fairly important. And, we have been setting it for a lot of time. The correct answer here is sugamadex. Can we use neostigmine? Yes, neostigmine can be used, but it is not going to end its effect fast. And second thing is glycopyrrolate. Glycopyrrolate is normally combined with neostigmine so that the neostigmine, which has its muscarinic side effects, if you give only neostigmine for reversal, so glycopyrrolate was going to counteract that. So for any reversal of a muscle relaxant, normally what we do is tuning in for any reversal of the muscle relaxant, we add neostigmine plus we add glycopyrrolate. At the same time, either glycopyrrolate or atropine can be added, and this is going to take care of the muscarinic side effects. What about edrophonium? Can edrophonium be used? Edrophonium, yes, it can be used, but not for rocuronium. The reason being is that rocuronium is an intermediate acting aminosteroid muscle relaxant. Okay, it's an aminosteroid muscle relaxant, intermediate acting. This is the structure and duration of action. Now, edrophonium basically becomes short acting. Neostigmine normally is preferred and the most common use because it becomes intermediate acting, right? The only place where you can use edrophonium as a reversal can be with mevacurium, which normally does not need a reversal because it gets metabolized by plasma cholinesterase. So in this question, can edrophonium be used for rocuronium? No, normally it is used, but not for rocuronium. Rocuronium is intermediate acting. Neostigmine can be used? Yes, it can be used. But neostigmine is combined with glycopyrrolate together so that glycopyrrolate takes care of the side effects. And sugammadex is a new reversal agent. This is what is a new reversal agent. It's been for long, but available in India now. And this works more for rocuronium. It can also be used for recuronium. And lastly, it can be used a little bit for pancuronium as well. It kind of just binds to the molecule and takes it away in simple terms. And hence, this is important. So a lot of us have used sugammadex also. It's one of the best agents. It works, in fact, within 10 minutes. It works. So I mean, even if you have given rocuronium right now, and if you want to reverse the patient, it's a difficult airway. You can just give sugammadex and it works wonders. It works wonders. So this is the answer, sugammadex, right? Any other thing, guys? So just let me know in the chat box. Next question. Simple question again. Which of the following is a second generation LMA? Maybe the lining of the sentence was different, but the options were the same. AMBU LMA, a ProSeal LMA, intubating LMA, or flexible LMA. So now that, guys, correct answer to this question is option B, a ProSeal LMA. So this time they didn't ask you a question from intubation, but from the airway devices, the question came on laryngeal mask airway. So laryngeal mask airway normally is basically classified as first generation or the second generation. The difference between the first and second generation was that the second generation has a drain tube from which you can insert a nasogastric tube and you can do a suctioning, Riles tube or a Riles tube and do a suction from there. The first generation only functions as an airway device. So therefore, second generation is an airway device plus a drain tube. Out of the options given to us, so second generation are normally the ProSeal LMA, which you know. There is an iGel, which has no cuff or the cuffless. And there is something called as LMA Supreme. So these are second generation. AMBU LMA, these are all single tubes like the classic LMA. The first generation LMA is what is called as classic LMA, which only has an airway tube. So AMBU LMA is single. Flexible LMA also is a single tube. Intubating LMA is also single tube. The only one which has a double tube, which means airway device and drain tube, is your ProSeal LMA. This has two tubes. All others are basically single tube. Intubating LMA is basically a LMA from where you insert an endotracheal tube for intubation, but this LMA itself is a single tube. It does not have a double tube like ProSeal. So the only one which has two tubes, airway device as well as drain tube, is your ProSeal LMA. So the correct answer is option B, ProSeal LMA. Right? Correct. Guys are marking the correct answers. Right. Simple question from anesthesia. All was simple. And this, in fact, the previous question, this question actually is a repeat previous year question with just one word change. That's it. Otherwise, it's the same question which has been a repeat from a previous year. It's not a previous year topic. This is a previous year question. Which of the following shows accurate CPR in an adult? Chest compression at the rate of 100 to 120 per minute. Chest compression about 3 to 4 centimeter. Allow complete recoil. And ventilation is 2 breaths after 30 chest compressions. So this is correct. This is correct. This is correct. This is the wrong option. So anything which has B is wrong. Anything which has B is wrong. Anything which has B is wrong. So the correct answer is A, C, and D. Right? So chest compression at 100 to 120 per minute is correct. Chest compression, the depth of chest compression is never 3 to 4. We normally say it as 5 to 6 centimeter or 2 to 2.4 inches. Guys, these are the points of high quality CPR. When you define a high quality CPR, which means effective CPR to save someone's life, these are the points for that. A chest compression 100 to 120 per minute. Chest compression depth is about 5 to 6 centimeter or 2 to 2.4 inches. allow a complete chest recoil, and ventilation. They even add one more breath. No excessive ventilation should be given. That's another point for a high quality CPR. No excessive ventilation, and restrict all your timings to less than 10 seconds. Minimize interruptions to less than 10 seconds. These are the points for a high quality CPR. So the correct answer here is D, which means A, C, and D are the correct options, and this was the wrong. Anything that has B is the wrong option. Yes, guys, any questions and doubts, please ask me. Nothing? Take it. Let's go forward to the next one. Here the point was the fourth option. Some students told me was halothane. Some students said it was nitrous oxide. But whatever be the fourth option, the correct answer is C. Simple question. This again is a favorite question and a previous year question, not a previous year topic. Best inhalational induction agent for a pediatric patient. Is it isoflurane? No. Is it desflurane? No, because this is maximum pungent. Isoflurane also is pungent. But if halothane and sevoflurane are given, not nitrous, but halothane and sevoflurane both can be used. These are sweet smelling agents. These are bronchodilators. But the problem is halothane has more complications than sevoflurane. So sevoflurane normally has less complications. So because sevoflurane has less complications, it is fast acting, fast onset, and fast recovery, you will prefer to use it over halothane. So even if halothane was the option, yes, both can be used for pediatric patient, but of the two, sevoflurane is preferred. And if the option given was nitrous oxide, still our answer remains the same. It is sevoflurane. Docs, so easy. Such may NEET maybe as a question aa jaye. हाँ यार. From anesthesia, I will always say that. As a question aa jaye NEET PG maybe. Simple question. Okay. One more last I'm going to take. This was because some students said, sir, is it nitrous oxide or was it nitric oxide? I think they had asked you nitric oxide, which is NO. And always, whenever we teach, guys, the first thing we always say, remember, N2O is nitrous oxide, NO is nitric oxide, and inhaled nitric oxide. This is an inhaled pulmonary vasodilator. So it works for pulmonary hypertension. A similar question, guys, we have discussed in our session, even on a YouTube session, I think, INICET. I think a year back when we discussed the INICET, last year when we were discussing, I have discussed this question there also, right? So this has been as a previous year topic, sort of, and this inhaled pulmonary vasodilator, which is inhaled nitric oxide, and the correct answer here was pulmonary hypertension. I'm not sure about the other options, but the answer for nitric oxide, if the answer was nitric oxide, I mean, the question asked was nitric oxide, the answer would be pulmonary hypertension, primary pulmonary hypertension. Okay, so that finishes off my anesthesia part. So I'll just take one song. We'll just do one song, right? Something different. And then I'll share thing too with Dr. Ranji, right? So let's do a song in a scenario like this. I don't know how it comes on the OBS, but let's see how it works. कुछ पानी पियो आस आस कोई अरमा हो जो खास खास आशाएं हर कोशिश में हो बार बार करें पलकों के आर पार आशाएं तूफानों को झील के मंजिलों को झील के आशाएं हंसे अब मुश्किल नहीं कुछ भी नहीं कुछ भी आशाएं हंसे अब मुश्किल नहीं कुछ नहीं कुछ Thank you. Over to you, Ranjit sir.
Thank you, sir. Thank you, sir, for the anesthesia recall as well as the song. And now we're in the last subject today of the INICET recall. You have completed successfully close to 6 hours and still counting. Sir, over to you.
Thanks for your patience indeed. So as far as pediatrics questions are concerned, it is not that tough. Almost majority of our questions were from our video series as well as question bank. So let's go to my first question. Ideal choice of fluid for resuscitation in child is, you all know it is here. Easy answer. As per IAP, Indian Academy of Pediatrics, as well as clinical practice guidelines, it is 5% dextrose along with the normal saline. We don't use half normal saline, 1/4 normal saline, and 1/5 normal saline, which are all hypotonic. Normal saline, the osmolality is as equal as or compared to your blood plasma. And we don't use 10% dextrose in a normal child. 10% dextrose and other high dextrose containing fluids are mainly used in cases associated with the hypoglycemia. And sometimes you can use potassium containing fluids also, provided you know the results of potassium if the patient is admitted with. As of now, as a blank statement, I can say the treatment of choice for resuscitation is in children is 5% dextrose with normal saline. Second question, rate of increase in head circumference in first month of life relatively easy. In the first 3 months, it is 2 centimeter per month. From 3 months to 6 months, it is 1 centimeter per month. And from 6 months to 12 months, it is 0.5 centimeter per month. So the question is first months, the answer is A, that is 2 centimeter per month. The child's head circumference is normally between 33 to 35. So 2 centimeter per month roughly comes around 6 centimeter at the end of 3 months. So at 3 months, the head circumference of any child is somewhere between 40 to 41 centimeter. The answer for this one is first 3 months, 2 centimeter per month. Right, nutritional rickets. You all know that initially what will happen, your calcium will be reduced and your phosphorus will be reduced because hypovitaminosis is associated with less absorption of calcium and less absorption of phosphorus. So both of them are reduced. This hypocalcemia in turn triggers your parathyroid hormone. So parathyroid hormone increases in blood. This parathyroid causes calcium absorption in the blood and phosphorus excretion in the blood. As a result of which, what will happen? Your calcium can become normal. So can become normal, but your phosphorus will be invariably low. So what will be the biochemical parameter in case of rickets? Calcium will be low or it can be normal also. Phosphorus will be invariably low. Parathyroid hormone will be invariably high. So normal calcium can be a possibility, high pH is the possibility, low phosphorus must come. So as far as increased urine calcium by creatinine ratio, it doesn't look a fit into this scenario. Nutritional rickets are commonly associated with normal calcium or low calcium. Phosphorus will also be low, parathyroid hormone will be high. And as you all say, alkaline phosphate will always be high. Answer D doesn't fit into nutritional rickets. Diagnostic criteria for DKA in children. Anion gap is normal between 8 to 12. So high anion gap should occur in case of diabetic ketoacidosis. Bicarbonate, yes, it should be less than 15 millimole per liter. Potassium, yes, hypokalemia is a manifestation of DKA, but it is not the criteria to diagnose diabetic ketoacidosis. And glucose of more than 250 milligram per deciliter, as per the current guidelines, it is 200 milligram per deciliter. I hope the question should contain glucose of 200 milligram per deciliter. One of the PG aspirants recall says it is 250. It is unlikely to be 250. It is 200 milligram per deciliter. So if it is so, then the answer should be C. Even though hypokalemia is part and parcel of DKA, it is unlikely to be the criteria to diagnose DKA. Next question. Dengue hemorrhagic fever investigation of choice after 5 days. In the first 5 days, NS1 antigen will be there. PCR will be there. But after 5 days of illness, at the end of 5 days of illness, we often rely on IgM antibody. okay, to diagnose new dengue. If it is a old dengue, IgG can be positive. So IgM antibody after 5 days of fever is the investigation of choice to diagnose dengue, because we are unlikely to get yield with respect to NS1 antigen and PCR. The next question. Yeah, I don't think I have 4 choices with me right now. Inborn errors of metabolism in children. What is the investigation of choice? What is the investigation of choice? So the first and foremost investigation is, we used to say something called a 𝐒𝐿𝐴𝐶. So what do you mean by 𝐒𝐿𝐴𝐶? In any case of inborn errors of metabolism, the first thing is you will find out what is the glucose, what is the electrolyte value, what is the lactate, what is the anion gap, what is the ammonia level, and finally ketones. Finally ketones. So this is the first thing that we'll do in any case of suspected inborn errors of metabolism. But as far as and we also do urinary, okay, metabolic screening. But the confirmation is, take a drop of blood and put it in a tissue paper and subject it to tandem mass spectroscopy. So TMS is the investigation of choice to diagnose majority of your inborn errors of metabolism. Parvovirus B19 do not cause. Yes, it causes aplastic crisis in children with hemolytic anemia. Yes, it causes red cell aplasia. It also rarely causes petechial fever, petechial rash along with fever. But with respect to hydrops fetalis, it can be due to 2. Hydrops fetalis can be due to immune hydrops and non-immune hydrops. As far as parvovirus B19 is concerned, it causes non-immune hydrops, and most common cause for immune hydrops fetalis is RH incompatibility. I hope if the question is correct, it should be except means it should be an immune hydrops fetalis. It usually causes non-immune hydrops fetalis. What is insure technique? You all know that insure means you intubate and you give surfactant through that intubation, and then you extubate. This you need to do, particularly in infants with respiratory distress syndrome as a result of hyaline membrane disease due to surfactant deficiency. And even then, the treatment of choice in hyaline membrane disease is CPAP. If CPAP doesn't work, then you can go for insure technique. So the insure technique is mainly meant for hyaline membrane disease caused as a result of respiratory distress syndrome caused as a result of hyaline membrane disease due to surfactant deficiency. Even then, the drug of choice is CPAP. The treatment of choice is CPAP. If it fails, you go for insure technique. The next question, 13-year-old, short stature with upper segment, lower segment ratio 0.1. Whenever we see any child with a short stature, it can be of 3 things. One is increased upper segment to lower segment ratio. Second one is proportionate short stature. Third one is reduced upper segment to lower segment ratio. By about 10 years, the upper segment to lower segment ratio is 1. If it is less than 1, then it can be due to problem in the upper segment. Problem in the upper segment means it can be either congenital or acquired. Congenital means it is spondyloepiphyseal dysplasia, whereas acquired means it can be due to Pott's disease. It can be due to Pott's disease. And what is this? Yeah, 13-year-old child, short stature, boy with the SMR of stage 5. So it means precocious puberty, hyperpigmentation, and hypertension. 21-alpha hydroxylase is associated with hypotension. 3-beta HSD is also associated with the hypotension. Hypertension along with the precocious puberty, it is more in favor of 11-beta hydroxylase deficiency. In case of females, it causes precocious puberty. Child with the following Z scores. Next question. Is it severe acute malnutrition? If weight for height is less than -2 standard deviation, it is severe acute malnutrition. If height for age is less than -2 standard deviation, it means chronic malnutrition. If weight for age is less than -2 standard deviation, here it is -3 standard deviation, then the answer must be acute on chronic malnutrition. The answer for this one is acute on chronic malnutrition. Not seen in Kawasaki disease. Kawasaki disease is characterized by red maculopapular rash, and one more point along with this is strawberry tongue. It is not associated with purulent conjunctivitis. It is a type of vasculitis, medium vessel vasculitis. The answer is non-purulent conjunctivitis, and so not in Kawasaki disease is purulent conjunctivitis, and cervical node of more than 1.5 centimeter. Single cervical node of more than 1.5 centimeter is another criteria. The answer for this one is A. Spastic quadriplegia. What is the abnormality associated with it? Remember, you can have spastic diplegia. Spastic diplegia, it predominantly occurs in preterm, and in MRI you will get periventricular leukomalacia. Whereas in spastic quadriplegia, which is severe form of HIE, particularly occurs in children who are survived from HIE stage 3, in whom there will be plenty of dead spaces which are filled up by empty spaces, and this is called as cystic encephalomalacia. So spastic quadriplegia is associated with cystic encephalomalacia. Free flow oxygen. Next question. Free flow oxygen in emergency in pediatric is, it is what? It is face mask over mouth and nose. It is not self-inflating bag. It is neither your face mask over your mouth. It is not your tubing over your mouth and nose. It is using your face mask along with closing your mouth and nose and giving a free flow oxygen. Right. The best indicator of some dehydration in severe acute malnutrition. Sunken eyes you will see in severe acute malnutrition. Lethargy you will see. Skin pinch you will see. So all these features occur both in severe acute malnutrition as well as in some dehydration. So best indicator of some dehydration in SAM is thirst. Right. So with this, I am completing my session. Thanks for your patient listening. Thank you so much, Ranjit. A brilliant coordination indeed from PWD team. Bye-bye.
Thank you, sir. So this brings us to the end of the entire 19 subject recall. What happened is what's been happening from 5 p.m. So it's the session will not end without thanking all the people who are behind this. Starting obviously with the students who gave us all the questions in a very short span of time, in spite of them completing the exam, coming back with the tiredness, they had the zeal to give us all the recalls. First, thanks to all the students and all the students who are listening to us and patiently giving us the corrections whenever we went wrong, right? And next to all the faculty members who were with us for the past 6 hours, continuously going from one person to another and not skipping any one of the sessions, right? And Dr. Hara and his team, Dr. Jigar, Dr. Anto, Dr. Vijay, Dr. Manish, and yes, surely we'll share the PDF, right? Okay. Dr. Arshad, Dr. Vijay and everyone, and Raman for the coordination, Dr. Ms. Kanchan for making sure all the faculty's timetable, everything is sorted, and nothing goes without definitely thanking the PW management for letting us an opportunity to interact with all of you guys. And I hope you enjoyed the session, and we'll share the recall PDF. We'll share the more refined question recall with the correct answers with you guys soon. because we feel that this is very, very important, because there are some topics which might get repeated in the NEET-PG exam also. And all the very best for the upcoming exam. There's hardly approximately a month left for you guys. And I hope you guys will rock the NEET-PG exam as well, right? So thank you everyone once again for being here, being with us for the 6-hour long journey. Thank you. Thanks a lot. Thank you, Aditya. And team, Aditya and studio team, I missed it. And if I missed anyone else, apologies for that. 6 hours, right? Brain fade is happening. Fine. Thank you, Aditya. And Aditya, we can end the session.